today with my co-moderators for this program. Today's learning objectives, we're going to cover some of the testing and validation behind AI systems, demonstrate the outcomes of artificial intelligence, including machine learning, deep learning algorithms on disease progression and outcomes analysis. We'll identify some practice management considerations associated with AI systems, recognize the potential of AI to tailor therapies based on distinct disease characteristics, and describe how AI in screening and diagnosis can improve the practice efficiencies and patient outcomes, and explain the current limitations and challenges associated with its use. This activity is supported by an independent medical education grant from TopCon and Regeneron. And I want to also thank my co-moderators for today's program. We're going to be each taking part in moderating the portions of the program today. I'm going to start off with the first two sessions. My name is Dr. Rishi Singh. I'm from the Cleveland Clinic in Cleveland Clinic, Florida. I'm joined also by Ted Lang from the Byers Eye Institute in Stanford, and Dr. Jenny Lim, who's from the Illinois Eye and Ear Infirmary and University of Illinois at Chicago. And we have a huge panel of faculty members today who are going to be joining us during the program. I'm going to introduce them as they come along here. Here are some of those faculty members today who are going to be joining us, not only from the US, but this is an international meeting. They're going to be joining us from abroad, which is really great to have them participate, thankfully, respective of their time zone. So we're going to have them be able to talk to us from their regions live to you all today. And we also had some wonderful abstracts. We want to thank these both medical students, fellows, or residents in training who were able to submit these abstracts, which we're going to have them speak on during today's webinar as well. I want to also thank our sponsors for today's program, Regeneron, Genentech, Boehringer Ingelheim, Apellis, Bausch & Lomb, and Eyenuk. This is a live program, so feel free to use the Q&A at the bottom of your screen. We're happy to take questions. We have a panel discussions at the end of each session, so definitely have time for your questions and be able to talk to our faculty panel today through the webinar. And let's get started. So today I'm going to turn it over for the first section on AMD, and that's going to be led off by Dr. Alam, who's going to speak on the self-supervision for domain adaptive macular degeneration.
Thanks, Dr. Singh. Hello, everyone. My name is Minhaj, and today I'm going to talk about our research on self-supervised domain adaptive federated learning in application of AMD diagnostics. All right. So we all know that advances in artificial intelligence methodologies, they have made huge impact and they have huge potential in ophthalmic diagnostics. Integrating AI into clinical workflow will enhance diagnostic accuracy, increase accessibility and scalability, monitoring disease progression, even at some point, it's cost effective to some point. However, the current methodologies that we see now are mostly utilized in triage. So what is the current need in ophthalmic diagnostics and what is the limitation? A major limitation for this kind of clinical deployment of AI algorithms is the need for a large amount of well-curated data sets. So we all know that a deployable generalizable AI model needs large amount of data, and it has to be there should be appropriate labels, well curated, etc. There are numerous barriers to building and hosting this kind of large central repositories within multi-institutional data because of compliance and patient privacy issues. So there is a clear clinical need for a robust, not just AI model, but a robust AI model training framework that can leverage this multi-institutional data without compromising the data sharing concerns. So federated learning is a machine learning technique that can address this bottleneck. So federated learning is where multiple decentralized nodes, or in this case can be clinics or hospitals, they collaboratively train a model while they keep all the training data local. So there is a central server that aggregates the weights. So the server has only access to the weights or parameters of the model, not the data itself. So each institution keep their own data, train their own local model. But as you know, in AI and deep learning models, there's a model update happens as time goes by, as at each iteration. So in this case, each iteration, the server updates the model and has access to this global parameter. So at the end of the day, the model that we get is updated and optimized based on all the local parameters from each local sites. So we get a more robust model. Federated learning can provide data privacy and security. It can provide diverse data and model access. So by just being part of this consortium, even a smaller institution with smaller data sets can actually have access to this large, robust data set a robust model that can have access to, that can give very high performance. Federated provides collaboration with the data sharing, resource optimization, real-world application, and scalability. So very quickly, how Federated works is, as I mentioned, there are multiple local institutions. They have their own local data. They share the parameters globally. The parameters are updated with different strategies like federated average and different methods. And this optimizes the model. And at the very end, when the model is optimized, the weights are shared to the local institutions, and then they can have their own fine tuning on their data. For example, each institution can fine tune their model on different applications like AMD, non-AMD, or progression of AMD, etc. So our first study is where we integrated self-supervised learning and federated learning for binary AMD classification. The main objective is very simple, like AMD versus normal. We utilize public and private data sets, simulate 4 federated learning nodes with about 300K OCT images, 70% training, 10% validation, and 20% testing. So we integrate self-supervision, which is basically an unsupervised method, which is used for pre-training your model. The idea is we provide the model a certain task without the label, and it learns the nuances of the image. That's the idea behind self-supervised learning. So in this case, what we do is we have an OCT here, example OCT. Then we do some augmentation, and then we actually mask a certain portion of the image, and this is called mask image modeling, where we ask the model to learn about the loss function, learn about the image, and try to predict the masked places. So basically, it's trying to reconstruct the image. So by doing this, the model learns about the OCT, learns about the OCT layers, learns about the pathologies that's identified in the OCT. Although the loss function is different, the loss function here is the objective here is to reconstruct the OCT. But just by doing this, it actually has to go through the learning, self-supervised learning of the OCT image itself. And we do this with all the data set without any label. So this is a great way to utilize even unlabeled data in clinical institutions. And by doing this, we have a very strong encoder, and we use this encoder for our next task, which is AMD versus normal. So let me see. The encoder learns representative features from OCT images through this SSL process. So how we integrate this into federated learning framework is that the federated learning nodes send the encoder to the server. They each do this MIM within with their local data, and they send this to the global server. The server aggregates the received models, and then reciprocates the global model to each local node. And for example, after this, the fine tuning happens. For example, in this case, AMD versus normal. So after receiving the like updated encoder, so think of it like a transfer learning, right? Where in general cases for transfer learning, we just use ImageNet weights. So in this case, we just use our encoded weights and then start from there. So the model is already advanced enough to converge very fast. So yeah, so we found that our federated learning model outperformed each local model for binary class classification, while guaranteeing compliance, regulatory, and privacy. And self-supervision improved the federated learning performance compared to the baseline aggregated method. So federated learning methodology performed similarly to a centralized model. And in terms of aggregation and federated learning approach, the self-supervision actually improved the model performance to some extent. Our next study is basically multi-class classification, which is where we mimic a real-life scenario where each institution might have different label dataset. For example, some has control DR DME, some has control DMR AMD. So that's what so we try to do a multi-class classification. And in this case, I ran out of time, so I'm just gonna be quick. So we do a domain adaptation to align all the intensity and contrast of the images. For example, we have a target image from a dataset, for example, from the first institute, and then we align all the data set towards that to compensate for the difference in protocol and of imaging. And we found that in our results, the federated learning model performed really well compared to local model, and it performed really close to the centralized model. And for example, you can see here the multi-class classifications are normal Drusen DME CNV in first institution, normal AMD DME, normal AMD DR CNV others, normal Drusen CNV. So each institutions or node have different label dataset, some common, some unaligned, but still our model was able to perform really well in terms of classifying them. I think the table is missing a row here, but we found out that the model performed almost close to the centralized model in this case. So thank you, everyone. That's all I have for now, and really happy to answer any questions at the panel discussion. I thank my collaborators and our funding support from different agencies. Thank you.
Great. Yeah, thank you, Dr. Alam. We're going to get to questions. I definitely have some questions about your presentation, so we'll be able to answer those at the discussion. So now we're going to hear from Dr. Vasada, who couldn't be here today live, but he has sent a video for his project on deep learning approaches for the assessment of AMD biomarkers. Vas?
Hi, I'm Vasada. I'm going to speak on deep learning approaches for assessment of AMD biomarkers. So these are my disclosures. So I think we all recognize that there's been quite a revolution in ophthalmology with regards to AI, more than 3,000 publications in AI applied to ophthalmology. And so this is obviously an exciting area because ophthalmology is actually, quite frankly, at the tip of the spear, with 3 recently cleared FDA approved systems for automatic diabetic retinopathy screening. So when we think about deep learning, of course, an important aspect of the process is training, where you take essentially an untrained model and you apply the training data, and then it kind of learns the training information reflected in the weights of the model, and then it's able to actually make an inference. For example, in this case, identify that a cat is a cat. And of course, there are many pitfalls in training these AI models in that they require very large annotated training data sets. And sometimes you have to play this trade-off between quality and quantity of data. You have to deal with possibility of underfitting versus overfitting data. And obviously, there are methods with validation to try to identify the optimal fit. Also, you have to worry about limitations of frame in the sense that you can really only apply the AI model to a particular area or specific type of problem of interest. And just an example, like for example, if you trained an AI model to recognize a type of a dog and doesn't know that muffins actually exist in the world, it could confuse muffins that happen to resemble dogs as being dogs. And of course, another issue is explainability. How did the algorithm actually make its decision? This is the classic example of a detection system to try to distinguish between a wolf versus a husky. And it seemed like the model was working pretty well, but then they looked at the model failures, like in this example, where it was predicted to be a wolf, but it was actually a husky. And it turned out when they actually interrogated the model to find out what it was using, it turned out that actually it was actually picking up on the background snow. And anytime it saw snow, it called it a wolf. And so it was really a snow detector rather than dog detector. So these are all the problems. But really, I think the one that's really holding us back the most in ophthalmology, and in particular developing models for AMD, which is my topic, is really having these large annotated training data sets. So how can we overcome this need for very large annotated data sets? An important aspect is something we call transfer learning. And the concept here is, and actually I should point out that this aspect of transfer learning has been used in many areas of medical imaging in order to actually do important deep learning tasks. And this is an example of transfer learning. Let's say that you have a model that you want to be able to detect tigers or distinguish tigers from particular types of dogs. Well, ideally, you'd have a lot of different examples of tigers, but maybe you don't have that many examples of images of tigers. But maybe instead of that, you have many examples of cats, because they're just cats are much more frequent. Well, you can use that to kind of pre-train the model. Maybe even use images that have nothing to do with dogs, but are other inanimate objects. But in any event, the model learns something. At least it learns maybe how to identify that there's a structure even in the image at all. And that sort of gives you a leg up, if you will. So that's really what transfer learning is all about, of course, is that you take advantage of this kind of pre-trained model weights, and then even with a smaller quantity of data, you're able to actually get an effective model that, for example, can identify or discriminate dogs and different types of dogs and tigers in this case. So again, this really works well for 2D images because there are a lot of 2D annotated data sets there, not just in ophthalmology, but in many domains, like, just in general sort of Google space. But the challenge when you're dealing with volumetric imaging like OCT is that there are few three-dimensional OCT data sets or three-dimensional imaging data sets out there. And so that is a challenge. And of course, it takes a lot longer to annotate these data sets as well. And most previous AI algorithms, because of that, they've sort of done things on a B-scan by B-scan basis, so treating each B-scan as an individual 2D image. But I think that we have to recognize that there may be some features on OCT that are three-dimensional, and the three-dimensional characteristics may actually be important. So we sort of developed a foundational approach to try to deal with this, something initially published Nature Digital Medicine called SliverNet, which again was based on transfer learning. So we did the transfer learning from B scans, but what we did was we used a 2D tiling approach to convert 3D volume to a stack of 2D images. But then we used the model architecture to be able to preserve the 3D spatial relationships, and that allowed us to be able to actually do these kind of classification tests. For example, we were interested in a variety of AMD biomarkers such as hyperreflective foci, hyperreflective drusen cores, SDD, and the like, which we know increase our risk for progression to atrophy. And we developed, we've shown this in several publications, that these biomarkers are important in terms of risk factors for progression. And what we did using SliverNet is we were able to demonstrate that it could outperform both two-dimensional and three-dimensional convolutional neural networks for this classification task of identifying these particular biomarkers. Now, one of the things, SliverNet, obviously we applied it, designed it specifically in ophthalmology, but obviously there are other three-dimensional imaging technologies like 3D ultrasound, also, of course, MRI and CT, and there are many models that have been developed in those different domains. And we wondered, can we actually take one step back and develop a foundational model, that could be broadly applicable to any 3D imaging technology? And so we modified SliverNet to integrate essentially a vision transformer. So we still use the 2D tiling approach, but we used a vision transformer to help with the feature extraction and the relationships between the different slices. And basically, again, we used a pre-training approach to train the backbone of SliverNet using these 2D tiled images. And then again, we used SliverNet trained on a very small amount of annotation data for this purpose. And what we observed was that this model, again, this was a model trained in only 587 volumes, but we found that in terms of predicting these different biomarkers, high central drusen volume, hyperreflective foci, SCD, hyperreflective drusen cores, it actually outperformed, you can see Slivet in blue here, our previous models, including the best that we had seen described in the literature, again, with a very small training data set. And again, a lot of this was for binary classification: is the feature present or not? But overall, we saw that it achieved the same sort of performance as a retina specialist annotator, as you can see in these ROC and precision recall curves, but obviously at a much faster speed. But then really our real long shot sort of hypothesis is, can we apply this to other domains, to cardiology for 3D ultrasound or echocardiograms, and to MR? Because again, there are a lot of similarities in these different domains. And again, what we found was that Slivet, sort of out of the box, just trained on the same data that was used to train a 3D resonant model in cardiology, actually outperformed that state-of-the-art model. In fact, you can see the prediction of ejection fraction based on Slivet, and you can see its model performance compared to EchoNet, which is the industry standard. And again, we're able to do that with a much smaller training set. That's actually the real key here, as shown here. And I also found that it also did very well, for example, in MRI, for example, in detecting the percentage of fat in liver MRI scans. Again, did better than the existing sort of industry standard. So to summarize, we were able to develop a deep learning model that could actually preserve the 3D information that we use to do these AMD biomarker detection tasks. It's a foundational model that could potentially work in image spaces outside of ophthalmology, and seemed to, so far at least, do better than some of the domain-specific state-of-the-art methods. And we do think this kind of AMD biomarker assessment could be of value in future studies identifying high-risk patients. And these are my collaborators, and want to acknowledge them, and thanks very much for your attention.
Thank you, Vas. I appreciate the ability to present today. And again, we'll take questions at the break, so please feel free to submit those questions. We have a panel discussion coming up very shortly. And now I'm going to turn over to Dan Ting. He's going to join us very, very far away. Dan, sorry, I hope it's a good time for you over there. I'm not sure what time it is, but thanks for joining and talking about Gen AI and ophthalmology.
Thanks, Rishi. Well, it's 8:30. It's almost 8:30 here in Singapore in the evening. Yeah, thanks for having me here. Yeah, so yeah, thanks for the kind invite to share. So I think Gen AI is currently like the really hot topic in the world, not just within the medicine and outside the medicine, medical, the field. So I'm going to talk a little bit about the regulatory ethical considerations about Gen AI in ophthalmology. Let me see how I could potentially advance my slide. There you go. Yes. So, I mean, just in a nutshell, we see like the really huge change of the AI landscape over the last 10 years, right? Coming from structure-based to pixel-based and, to now text-based and multimodal. And of course, the multimodal not just, consists of the text and the image, but also the audio and the speech. And we also see like the changing landscape of the AI computing power, because without like, we go from CPU and now GPU. Of course, we know the GPU kind of, has enabled like the deep learning work to be done. And now, I mean, of course, Google came up with the tensor processing unit, the TPUs, and now we're talking about quantum computing as well. So irrespective of any AI algorithms that we are talking about in healthcare, we all need the trustworthy, safe, responsible AI use. So when we talk about that, we need to talk about safety, responsible AI. How do we actually do the last mile implementation? How do we actually standardize the reporting, the guidelines, the evaluation matrix, and of course, the AI can be also used in the drug discovery and clinical trials phase. ChatGPT, I think, no one, I don't think anyone in the room don't know what ChatGPT is about. And this is the single most powerful engine that mankind has ever seen in the, in a history. Essentially, it takes like 2 months to hit 100 million users. And it's currently, I wouldn't be surprised that it's currently hitting, 500 million more, right? And if you look at the landscape, the large language models, sorry, I think there's some timing issues, but I'll just describe here in the landscape. So basically, in the large language model engines, we can actually broadly divide them into, the open source versus the closed source. The closed source, of course, three big tech companies right now as we speak. We have Microsoft, OpenAI, we have, AWS and Cloud3. And of course, we have, Google and Gemini 1.5, now Ultra. They're all using like, more than 1 trillion parameters to actually fine-tune the large language models. Of course, the open source, the large language model, as we know, is on Llama, and currently Llama is on the third version, Llama 3. We have two different the models. One is big, one is small, one's on 70 billion, the range, and one, of course, in the 8 billion range. And if you actually were to use all these different large language model engine, then you have to kind of know what large language models techniques that you want to optimize your engines. So we go from the lowest level one, which is a prompt engineering, then we go for RAG, retrieval augmented generations, to fine-tuning and pre-training. And of course, with the compute power, you actually have to use more if you actually were to go from the right to the left in a presentation slide that I show here. So A100 140 gig can allow you to do a lot of things. But right now we talk about A180 gig, H180 gig, and of course B200 is coming out like later part of this year. So retrieval augmented generation, just as an example. So what this do is you actually are training a human brain to actually look for the source of the dictionary, so that when a question is being asked, you know where to actually look for the answers. That's in RAG in a nutshell. So if you were to fine-tune an algorithm, so essentially you need to actually train the algorithms with a set of dictionaries that you have. So this is something that we really are doing in the pixel-based, the CNN world, and now currently in the text-based AI algorithm, you can also do the similar. So we published this paper. Okay, we already published this in Nature Medicine last year in
Bonjour, I'm Dr. Daniel, Retinal consultant. Today, we'll
how
discuss
when the
diabetic
three Daniel things are trying to correlate each other. Not sure how someone's website can turn up the timing for me on the back end. So this is one of the things that we published in Nature Medicine to illustrate the opportunities to to use large language models, the engines to organize, summarize the medical data, to kind of help to actually proofread the scientific content, of the publications. And of course, the highest hanging fruit is to actually build like the clinical triaging tool. As you can, tell from the last 30 seconds, like three Daniel things with the AI avatars is trying to like speak each other. If you don't actually play them well. So it's actually in this slide, I won't actually play again to avoid the similar phenomenon, is to actually illustrate if you actually were to actually use Daniel Ting in an AI avatar manner to actually describe what diabetic retinopathy is, you can actually do it in English, Chinese, and French. And of course, the command, we can actually just try to actually type in like 2 words command. You can actually already convert 30 seconds or like a 1 minute, the conversation just within the less than 2 seconds. So essentially the English, Chinese, and French, this is what you can do.
Hello, I'm Dr. Daniel.
Okay, anyway, I'm going to skip that. So, vision language model is when we start combining the text-based AI algorithms with the image-based. So just imagine if you actually, upload retinal imaging, right? Or FA imaging. And then the AI agent can actually start telling you, describing like the early phase to late phase, and to describe all the normal or abnormal findings all the way, and then to create you a report. So this is essentially what the visual language models can actually help you to do. And multimodal, so essentially if you actually feed like the AI a bunch of text, and potentially it can actually help you to actually create a video. So I mean, right now the technology is not there. Our lab is currently trying to build that. But essentially, if you actually, hopefully one day, if you can actually tell you, hey, run me AI videos, to illustrate like postural capsular rupture in a cataract surgery. So hopefully by just putting a simple command like this, the AI engine can already generate like a videos to demonstrate how a PCR or postural capsular rupture can actually look like in a video. And of course, we know the big tech leaders is always, have a divided thought, like when it first came out. That's why we actually published this paper to highlight the importance of the data privacy, the rights of use of the data provenance, which also means that the data origins and the potential IP contamination, and the broad applications of large language models does actually need, a larger governing framework to actually, the government to use. So data privacy, right of use, there's different levels of data sensitivity, different countries where different data privacy law, and of course, rights to the data access, the data erasure, and limiting the data processing is actually the key. And this is what some of the things that the developers and researchers have to actually be aware of, right? The data breach, adversarial attacks, balancing between the privacy and utility. And of course, this is some of the things that the regulators, the governing bodies have to actually be aware of. And in terms of data provenance and IP infringement, this is a big thing that's happening in the US for both the New York, the Times, and of course the Huckabee et al. The law. In terms of quantifying the data sources, quantity, and diversity as well. So this is the two examples that I actually highlighted before, the New York Times and the Huckabee et al. Cases, which is still ongoing in the lawsuit of the US law. And of course, unauthorized use of the copyrighted material, right? So how do you define a fair use? So this is the statement that all the different technology companies are currently using to actually defend about to defend against the claims. So this is the statement from the US copyright law. What constitutes a fair use of doctrine? So you have to actually depends on the purpose and character of use, the nature of the use, the amount of the data that you use, and of course the impact and of course the implication that of the use at the eventual site. So large language models have broad application. It's very different from medical imaging AI. So this actually really need many different individualized governing framework to actually govern that. So, I mean, this is just some of the, the ways that we actually highlighted in the paper. Those of you who are interested, please look it up. And yeah, so this is just a holistic view of how large language models and generative AI that I think can actually be of a great value coming from triaging, analysis, diagnostic, and the surveillance too. And yeah, with this, thank you.
Great, thank you, Dan. We're going to get to some questions in the panel discussion in just a moment, so hang on for that. I believe there's one more talk before the panel discussion, and the next talk will be by Dr. Kong, who's going to speak on artificial intelligence analysis of baseline fundus photographs to predict the effects of aflibercept treatment on best-corrected visual acuity.
Thank you, Dr. Singh. It's my great pleasure to share our latest funding on behalf of my co-authors in School of Medicine and our, let me advance my slides, and our collaborators from Applied Physics Lab, Johns Hopkins University. I don't have, Oh, it doesn't work very well. Okay, so we have learned that artificial intelligence make it possible for machines to learn from experience, adjust to new inputs, and perform human-like tasks. So starting from several years ago, our research group started to question, can we train artificial intelligence to do something that we human beings, or specifically we ophthalmologists, cannot do? For example, can we determine the best corrected visual acuity from AI analysis of the fundus image? The answer of this question was the predecessor of today's topic. So we started our exploration by using fundus photos from VISTA study, a randomized clinical trial comparing aflibercept to laser for diabetic macular edema. More than 7,000 images were used for training AI and used for validation of training and used for testing algorithm to estimate best corrected visual acuity from fundus images. So this is an illustration of how deep networks were built with multiple hidden layers to accomplish sophisticated tasks in our study. And 10 architectures were used in our study. And by using ResNet 50, the mean absolute error among testing group, which was 641 images, was 9.66 letters. And 33% of the values were within 10 to 5 letters, and addition 28% of the values were within 6 to 10 letters, which looks very promising. And as we learned that greater accuracy can be obtained among eyes with visual acuity 28 or better, it probably partially due to we have very limited eyes with vision worse than 28 to train or to validate the algorithm. So we published this paper last year in JAMA Ophthalmology, and then we decided to use this algorithm to explore the potential of AI determined biomarkers for predicting treatment outcomes following anti-VEGF therapy for DME. The objective of this study was to evaluate the ability of AI analysis of fundus images to predict changes in BCVA at 1, 2, and 3 years after initiating aflibercept for DME. So due to time limitation, I'm not going to go through all methods. So basically, we use the same data set from VISTA study, but this time only participants who were enrolled into the aflibercept arms, either Q4 follow-up intervals or Q8 weeks follow-up intervals were included in this study. And the participants were excluded if they were missing any of one of every 24-week visits when fundus photos obtained. So de-identified baseline fundus images of study eyes after dilation were used post hoc to train AI system to determine BCVA changes of greater than or equal to 10 letters on an ETDRS chart, or CST changes greater than 10% or equal to 10% on OCT macular thickness map at 1, 2, and 3 years after baseline. And baseline image only method, which labeled as IMG only in the next slide, use ResNet 50 architecture-based evaluation of multiple algorithms we published previously. And baseline BCVA only method, labeled as BLV only in the next slide, was a logistic regression using only actual BCVA to predict changes of vision at 1 or 2 or 3 years. So among the 164 participants, which was like about 328 images, training, validation, and testing was partitioned by a split of 80%, 10%, and 10% again, respectively. There's a delay. So during the VISTA study, we approximately 55% of the participants in the aflibercept group gained like 10 letters vision at year 1, 2, and 3. But for the testing set, among the testing set, the percentage of those vision gain was lower. Basically, almost 95% of those participants can have like a more than 10% OCT CST change at 1 to 3 years, and the testing set, the percentage among the testing set was similar in this study. So how about the prediction accuracy of the artificial intelligence? From this table, we can tell the IMG only method resulted in accuracies, sensitivities, and FE scores that appear similar to values obtained with like a baseline vision only method, with little improvement noted when combining MG and BLV. The accuracy, but unfortunately, the accuracy was a little difficult to evaluate for changes in OCT CST from baseline based on AI analysis of the baseline fundus photos compared with using the OCT CST baseline value, since almost all eyes had improvement of the OCT CST of at least 10% from the baseline. So in conclusion, these findings support pursuing AI analysis of fundus images as a potential biomarker to predict the likelihood of a change in BCVA of at least 10 letters from baseline at 1, 2, and 3 years after initiating aflibercept for DME. This prediction was similar to that obtained using actual baseline BCVA from a protocol refraction and the protocol VA measurement on an ETDRS chart. But by using AI analysis of a fundus image, result obtained a protocol refraction and of a protocol visual acuity measurement from a patient using an ETDRS chart with trained visual acuity examiner. Additional training, validation, and testing could be needed among eyes with 10 letters better change or greater than 10% change in OCT to determine more accurate sensitivities and the specificities of these results, and potentially expand the application of those results. So nonetheless, these results provide additional support for pursuing AI evaluation of fundus photographs as a biomarker for BCVA or OCT CST outcomes in clinical trials and in the clinical practice. On behalf of my co-authors, thank you for your attention.
All right, thank you very much, Dr. Kong, for that presentation. So we're going to have all our panelists join now for the Q&A. Thank you all for those wonderful presentations. So I just thought we'd start off and talk a little bit about each of your presentations, a little bit more in depth. Dr. Alam, when you presented on the federated AI approach, I wanted to hear kind of any drawbacks or any other thoughts you had about drawbacks to such an approach.
Yes, absolutely. That's a great question. So there are multiple drawbacks for sure. One of the main drawbacks, as you mentioned, is the risk to the cybersecurity risk. So ideally there would be cybersecurity risk, but like a hacker would have to have access to the exact model parameters that each of the local nodes have, because we're essentially sending the encoded parameters to the server. So if you think of an image, then it goes through the whole deep learning network, and we have a vector at the end. And even we're not sending that vector, we're adding a noise on top of it and then sending it to the global server. So a hacker essentially would have to have access to the exact noise that we're sending to decode, and also the exact model with the randomized neurons, because the neurons function like in the neural network, the neuron activates randomly. But still, that's not theoretically impossible to hack that. So actually, there are a lot of research going on we are also doing some research on identifying the trade-off between how much layer of privacy we should add versus, because if we add too much layers, then the accuracy would drop. So it's like a trade-off on like how much privacy and like how much security layers we should add before the accuracy actually drops down to like which we don't want too much. So there's a lot of theoretical research going on that aspect. Another main drawback is the domain adaptation that I mentioned, is basically each institution have their own subpopulation data. So basically that model is trained on the data. So there is like a data heterogeneity that actually prevents the model to converge very fast or have high performance. So there there has to be some sort of domain adaptation methodology that helps to make it closer to a homogeneous. But then you don't want to be a total homogeneous data set. Then it kind of doesn't serve the purpose of having a diverse model. So it's also a trade-off on like how much adaptation you should do versus you should let the model be independent and unbiased. So yeah, so this is just like a tip of the iceberg that we are just starting the feasibility of seeing the federated learning. We're just starting to publish some papers on like actually see, because if the model performance is really, really low, then it doesn't make any sense for us to work on this. But now we're finding different limitations which we have to address. Hopefully other researchers in the field will also address some aspect of it. But yeah, there's definitely some drawbacks, and this is very early stage, I think, I'd say.
Great, thank you. And for Dan, Dr. Ting, you've talked about generational AI. What are some of the limitations to widespread adoption? I think you mentioned some of the computing issues. Is that really the only limitation, or are you also finding, some countries or differences? You have such a worldwide view of this because you work in so many different areas. Are you finding some data governance or data or privacy issues, or even, for lack of a better term, shyness around AI in different countries that might limit its overall applicability?
Yeah, thanks, Rishi. I think like the compute power that you mentioned, like I just wanted to also kind of dovetail to one of the limitation of the federated AI that Minaj just mentioned, right? I mean, for federated learning as a start, and I saw like there's also another the chat about is federated learning, is that a way to kind of address some of the data provenance issues as well. I think like first is the compute power, right? If you don't have like the AI expertise, you can't do federated AI. No matter how much you think you're going to protect your data from individual countries, if today I want to do from the site A versus site B, if site A have the lots of compute powers, AI capability, but site B doesn't have, federated AI is not a go. So that's number one. Number two is like for Gen AI, I think compute power always is going to be a key. So if you don't have the compute power, and if say your countries, right, not US, not Europe, not Singapore, but some of the countries like they don't even have a presence of say Microsoft, the cloud, they don't have AWS. You can't do chat GPT or large language model related the exercises. So that's number two, right? Compute power. But if you don't have a lot of compute power, can you still do some Gen AI work, right? So that's the third question. Yes, the short answer is yes. Then one slide that I show, you can start with prompt, because prompt require the least amount of compute power, right? Prompt engineering, it's like no different from how the doctors speak to a patient. It's about the art of asking a question. So if you know how to ask your large language model a question, or you know how to structure your questioning to the large language models, actually the large language models can give you a very, very good answers. So that's a start. Of course, if you have more compute power, right, then you can start going for RAGing, right? Retrieval augmented generations. Then you can go for fine tuning. And if you have a lot more resources, you can do foundation models. So that's the third point. The fourth point is, can we actually then, is there any other challenges, right? Apart from compute powers, like data and things, data provenance, huge issues, right? Like what I said, New York Times, Huckabee, and there's going to be more that's going to come up, right? There's going to be more of the lawsuits, more of the legal exercises that we're going to see around the world, not just in US. And how do we actually going to win this? How is the tech company is going to defend against themselves? I think, it's all boils down to what is a fair use. It's a very simple definition, but to different people, fairness and unfairness it means a lot of different things. It's a very gray area if you look at it, right? So then it goes down to like the basic principle of what how we define the copyrights issues. So I think this is some of the things that we are, the lawsuit is going to take a couple of years before like, one one party or the other party is going to win or lose. So I think this is a space that, many countries should actually look into. But I think the last point that I wanted to make is that Gen AI, when you're actually trying to use the training data to actually train a model, make sure that the data at least is being de-identified. This is one of the very, very key issues that any hospital who wants to touch about Gen AI stuff, please make sure that you erase your patient's name, your date of birth, or like the identity, because once you put it into the large language model, it's very hard to actually retrieve it. It's like a black hole, right, in the universe. So once something goes into it, it's very, very hard to retrieve it. So I mean, this is the 5 points that I actually wanted to share about that question. Yeah. Thanks.
Yeah, great question. Great answers. Thank you for that. Dr. Kong, let's switch gears and talk about your presentation a little bit. I was intrigued that you chose fundus images as a predictor and not OCT. Can you give us a sense of why that was chosen? I guess I know fundus images are widely available, I guess is maybe the reason why, but I just kind of want to get your thoughts on that.
Yeah, that's a very good question. So because usually when patients walk in clinic, we will order like a fundus photo for each patient, and so that's why we start to look at like if we can use fundus photos to predict BCVA or even to predict the visual outcome after initiating an anti-VEGF treatment. So, and the more application of this study is actually in the future, if we can do home monitoring for AMD and DME patients, it's easy to get a camera to take a photo, a fundus photo, probably by connecting with an iPhone. So and then, but patient they don't know how to measure their visual acuity accurately. So if we can predict visual acuity just based on fundus photo to let us know the visual acuity, then we can tell the patient, do you need to visit to make an appointment to see a doctor, or it's okay to observe, to stay at home. You don't need to make an appointment. But it's always difficult to have a home monitoring OCT available for all the patients. So that's why we chose fundus photos to do all this prediction. But meanwhile, so the accuracy was not too bad. The accuracy of predicted visual acuity based on the fundus image was within 1 or 2 lines, according to our study. So we also want to learn if we can predict central subfield thickness by let the machine to learn from the fundus photos. But unfortunately, the results was not that promising. So the mean absolute error could be as high as 190 micrometer at this time. So we don't know will that accuracy be increased if we train the machine with more images, or it's just cannot to predict the OCT precisely. So, but we do want to take a look to see if the fundus image, but by using AI, can give us the idea of the central subfield thickness in OCT.
Wonderful. Okay, thank you for that explanation. And I appreciate you, the panelists, they're answering some of the questions in the chats as well. So thank you for doing that. And with that, because we're a little bit over time, we're going to conclude this session. Thank you to you all speakers for this AMD session. We're going to go on to session number 2 now.
Thanks, everyone.
Thank you.
All right, so we'll start off section number 2 with our first speaker. And it's going to be Sophia Frank. Dr. Frank will speak on AI-supported treatment in neovascular AMD, retinal fluid correlation with photoreceptor condition, and visual function.
Thank you very much.
Yep.
So today I will be speaking about fluid volume correlation with photoreceptor condition and visual function. So we all know neovascular AMD, and we keep treating our patients with anti-VEGF treatment, although still up to 80% of them develop fibrosis or like this patient of mine, she developed degenerative processes. She developed atrophy just within 9 months and lost 15 letters. So we don't keep injecting our patients, and the numbers are rising, especially with the introduction of complement inhibition for geographic atrophy. And this can represent a burden not just for clinicians and patients, but also for healthcare systems. So we also see another paradigm shift towards OCT imaging. Up to 40% of clinicians decide if a patient should be treated or not just by using OCT without a clinical examination. And why do we use OCT? Because we can actually differentiate between fluid types. And from previous research like this post-hoc analysis, we actually know that different fluid types have a different effect on our patient's BCVA. So here they found that the highest effect on BCVA was intraretinal fluid, followed by PEDs, and then subretinal fluid. When looking at data from the real world, from the Fight Retinal Blindness Registry, only intraretinal fluid significantly reduced BCVA. So we don't only want to differentiate between fluid types, but we would like to also quantify it, because high fluid volumes have a higher effect. And we cannot do this in a busy clinical practice by hand, so we need AI to do this for us. In Vienna, we use the fluid monitor by RetinSight. And when we want to look at my patient from earlier who lost 15 letters, she actually presented with over 140 nanoliters of intraretinal fluid in the central millimeter alone. But not just that, she also had a huge subretinal fluid edema in the parafoveal region. So for this study, we wanted to correlate fluid volume with not just visual function, but also with photoreceptor integrity at the EZ level. And furthermore, we also wanted to investigate differences between M and B types. And for that purpose, we included 290 patients with subretinal fluid or intraretinal fluid present at baseline. They all received anti-VEGF injection, as well as functional testing, BCVA and microperimetry testing, and retinal imaging. So they got an OCT and OCTA imaging. And then they came back after 4 weeks and again received functional testing as well as retinal imaging. Then further along, we automatically quantified SRF, IRF, and PED using the fluid monitor by RetinSight on the baseline OCT. In the second step, we then automatically quantified the photoreceptors at the EZ level, so EZ thickness and EZ loss at month 1. And then in a third step, 3 expert graders determined M and V type using OCT and OCTA data. And lastly, we were able to correlate fluid volumes for each compartment separately with our respective parameters. To point out here on baseline characteristics, I would like to say that we had around 2/3 of our patients with a type 1 MNV and 1/4 of them presented type 3. And when looking at fluid volume here on the right-hand side, you can see that for the central millimeter disc, subretinal fluid and intraretinal fluid were quite evenly distributed. But in the central 6 millimeter, we can see that there was a large portion of subretinal fluid located in this 6 millimeter area. Please keep that in mind when I am talking about the results. So let's come to the results. We correlated fluid by separating our cohort into quartiles. So we compared the highest quartile of fluid volume with the lowest 70% fluid volume. And here we found that we have a lower BCVA in the high fluid volume groups for SRF and IRF, but we also wanted to look at the extent of this effect. So we also looked into multivariate regression models. And here we found the highest effect for intraretinal fluid, where up to 3.4 letters were lost with an increase of 100 nanoliters IRF. We did not find any significance for PED. Next, we looked at mean retinal sensitivity in microperimetry testing. Yes, and here we found that in the high fluid volume groups of all 3 fluid types, we had a significantly lower mean retinal sensitivity. And again, in the multivariate regression models, we saw the highest effect for intraretinal fluid, and up to 5.6 decibels were lost here with an increase of 100 nanoliters of intraretinal fluid. Then we also looked at the effect of fluid volume on the ellipsoid zone. Here, for ellipsoid zone thickness and subretinal fluid in the central 1 millimeter, we found a protective effect, meaning that the ellipsoid zone got thicker. And however, when looking at the 6 millimeter disc here on the bottom, we can see that we have a significantly thinner EZ layer as compared to low fluid volume groups. For intraretinal fluid and PED, the high volume groups showed a thinning of the EZ layer. And in the multivariate regression model, again, we found the highest effect for intraretinal fluid, where almost 5 micrometers were lost with an increase of 100 nanoliters IRF. Next, when looking at EZ loss, again for subretinal fluid in the central 1 millimeter, we found a protective effect, so less loss of this layer. However, again, I want to point out that more of the subretinal fluid was located towards the 6 millimeter area, where we did find a significant loss of the EZ layer due to subretinal fluid, as well as IRF and PED. And here, again, highest effect for intraretinal fluid. Lastly, we also looked at effect of MNV type, and we found lower IRF volumes in the type 1 MNV group and lower SRF volumes for type 3 MNV. To conclude, there is an effect of high fluid volume on the functional impact of our patients for BCVA regarding IRF and SRF, and for retinal sensitivity for all 3 fluid types. And we found the highest effect for intraretinal fluid. Also, for photoreceptor condition, we did find a protective effect of subretinal fluid in the central 1 millimeter. However, we did see for all 3 fluid types significant thinning and integrity loss with increased fluid volume. And lastly, intraretinal fluid does have the highest effect on the photoreceptor condition as well as the visual function. MNV types also show differences in fluid activity, which you might want to keep in mind when treating your patients. So lastly, high fluid volumes do have an impact not just on the retinal function, but also in the EZ and photoreceptor structure. Fluid volume is therefore the most important biomarker for disease activity in neovascular AMD, but we can't manually annotate it in a busy clinical practice, so we do need AI to actually quantify fluid for us in order to support personalized treatment decisions for our patients. So thank you all very much for your attention, and a big thank you to my team who supported every step of the way. Thank you.
Great. Okay, Dr. Frank, and join us for the panel discussion shortly, and we'll get to questions. There's some really great questions coming in the chat already, so thank you for that presentation. The next presentation will be by Dr. Rajiv Mooney. He'll speak on the prediction of visual acuity response to ranibizumab and AMD using AI-based analysis of fluorescein angiography.
Thank you, Rishi, and every organizing committee for this invitation. So I'd like to describe some of the work we've been doing at the University of Toronto. So the control is not allowing me to advance the slide. Okay, all right, here we go. So neovascular age-related macular degeneration, as we know, is a leading cause of vision impairment, and anti-VEGF therapy has revolutionized our treatments. But we want to identify predictive indicators of treatment efficacy through AI to allow for us to personalize our therapy more. So this comes from a data set, a prospective single-center trial in Toronto from 2017 to 2023. And this is a part of another study where we were collecting aqueous cytokine or aqueous fluid samples to determine the association with outcomes in AMD. But in this study, what we were doing is taking the IVFAs, the ultra-wide field fluorescein angiography from this cohort. And these patients were all prospectively treated for 12 months with a treat and extend dosing regimen. And we wanted to look at the changes in best-corrected visual acuity here. So we used ultra-wide field fluorescein angiography analysis, and we were measuring three quantitative variables. We were looking at quantitative measurements of the blood retinal barrier permeability, as well as perfusion and blood flow. And this was done by extracting fluorescein leakage and flow data from sequences of ultra-wide field fluorescein angiography using a Reticad software that we were collaborating with a company that has this software that can quantitatively measure these parameters. We then did a univariable and multivariable analysis. So here's just a visual description of the automated analysis of vascular function that we did. So essentially, they took a time series of fluorescein angiography images, and they looked at the per pixel change in the fluorescence. And from that, they determined the rate of vascular leakage, the rate of blood flow, and the rate of perfusion. So how did we calculate blood flow? So that's the rate of fluorescein accumulation within blood vessels between the choroidal flush phase and the arterial venous phase. Perfusion was the rate of fluorescein accumulation in the non-vascular tissue between these same two phases. And then for blood retinal barrier permeability, it was the rate of fluorescein in the non-vascular tissue between the start of the recirculation phase and the late phase of the angiogram. And a positive BRB permeability indicated increasing leakage, whereas a negative permeability indicates that the fluorescein was washing out. So the algorithm, as we mentioned, it performs a per pixel analysis of the fluorescence intensity over time. And so here you can see examples of cases where you have fluorescein washout as the fluorescein intensity decreases over time, or cases of fluorescein accumulation as it increases over time. And then for blood flow, similarly, you can see the fluorescence intensity in the vessels over time. And this was used by the software to perform AI-assisted, like a regression analysis, to look at the rate of change in these parameters to develop these quantitative metrics. So this was our baseline characteristics, a predominantly Caucasian population with phakic and pseudophakic patients more or less balanced. So what we found on multivariable analysis was that the central blood retinal barrier permeability measurement was associated with the change in BCVA from baseline to 12 months, as well as the number of ranibizumab injections. So here, when we look at patients who had improved BCVA versus no improvement in BCVA, there was a significantly lower baseline values of central BRB and peripheral BRB permeability compared to those with no improvement. So essentially, the amount of leakage correlated with this change in vision. Our ROC analysis showed an area under the curve of 0.81 for the central BRB permeability and 0.76 for peripheral BRB permeability. Now we've looked at, we have other data sets similarly where we've collected prospective data with IVFA longitudinally, and we've also looked at this association of fluorescein leakage with adaptive optics changes, and we found better photoreceptor spacing in areas without leakage and worse photoreceptor spacing in areas with leakage. We also showed that leakage in DME is associated with higher macular volume on OCT and worse visual acuity. So in conclusion, baseline AI-derived ultra-wide field parameters, particularly BRB permeability, was predictive of BCVA improvement following ranibizumab. And in future work, we want to explore other disease pathologies and also kind of follow these patients longitudinally, because we were taking imaging every 6 months to try to see, how we can better personalize our treatment. But, we were quite impressed with the AI-assisted software that really gave us really good quantitative measurements that, otherwise we're just looking at qualitatively. And so we're going to continue studying this to see if we can get some predictive ability. And as I mentioned, this was part of another study that is looking at cytokines in the anterior chamber. And so we also want to look at the association of those cytokines in the anterior chamber with the extent of leakage. So perhaps, we can get some baseline parameters that can, predict how we should treat our patients. Thank you very much.
Great. Thank you, Dr. Mooney. We're going to get back to you in the panel discussion in a few minutes. And with that, I'm going to turn it over to Dr. Dambapalli. She's going to speak on the real-world deployment of GA screening models in clinical trials.
Thank you, Rishi, for the introduction and the amazing talk so far. I'll be talking about real-world deployment of GA screening models in clinical trials. And okay, I have no conflicts to disclose. We all know the pathway for developing algorithms. We've all done this: curate images, train tune models, test them. And if the model works and if the reviewers are kind enough, we publish our research. But what do you do for implementation of AI algorithms? I think we need to take it a step further, test in multiple environments, and if possible, and this is highly recommended, to do at least a small prospective study, because that's kind of the trial by fire for AI algorithm implementation. The FDA has a beautiful total product life cycle that outlines this process beyond their clearance, into deployment and what you need to do, but most importantly about how do you have good machine learning practices for performance evaluation and clinical evaluation. Moving on to GA, this is an advanced form of AMD. For those of you who are not ophthalmologists, the image shows an autofluorescence image, and the black patches are the areas of GA which grow over time and need to be measured because GA area and progression are important endpoints in clinical trials, and currently there are no tools to measure them clinically. So a lot of clinical trials use GA area as a screening criteria. Usually these images are sent to reading centers for measurement, and screen failure rate based on area alone is about 50% in clinical trials. So that's a lot of financial burden and time for the patients too. So we developed a model that can measure this black patch from these images. Many people have done this. This is a beautiful model. It works well in many researchers' hands. We published this. The first one is the ground truth, and the second is the AI prediction. Okay. And we even went ahead to see which kind of architecture would work best, traditional CNN versus vision transformers. We found the vision transformers really do well in this situation compared to traditional model CNNs. And so we selected our best model and said, okay, we're going to use this for our multi-testing process. And for the testing environment, we wanted multiple environments, so clinical trial, real world, retrospective, prospective, reading center labels, non-reading center like clinical labels, and a geographically diverse data set. Apart from just the trial set, the test setting, we wanted different phenotypes, incident, prevalent, foveal, extrafoveal, because in the real world, you have all kinds of GAs, a big range of area. So going back to the implementation pathway, what we did was we trained and tuned on the ARIDS2 dataset, tested on a GSK dataset, which is a clinical trial. So the ARIDS2 is all comers for GA because it's an intermediate AMD study, incident, prevalent, everything. But the test data was purely GA trial. Then we packaged the model, sent it across to Moorfields Clinic, where Dr. Shiv Prasad and Dr. Chandra tested it on their clinical data retrospectively. And then we also tested within our University of Wisconsin eye clinic. We ran it on a prospective study called COCO-GA, which I'll get into next. So these are the results of our train test, and you can see the difference between AI and ground truth is kind of minimal, and with high dice in the train-tuned data, the difference widens in the first test data set, which is a clinical trial. Dice drops a bit. Real world, difference widens even more, dice drops further, but still within acceptable range. And if you look at the data distribution, everything looks pretty good. Its distribution is all tight and to the center. So we are like, okay, this model works. Let's go ahead and implement it. So the COCO-GA was just a comparison of device studies. So it's not therapeutic. It's Claris, Optos, and Heidelberg comparison of GA area. There were screening criteria similar to a therapeutic study. So what we did was use so the retina specialist would find a patient, eyeball the GA and say, yeah, looks good. And then the image would be sent to the study coordinator and the model was locally deployed in the clinic. The study coordinator would take the image, use the model, send the report back to the retina specialist real time, who would then make a decision if the model works or not. So the model does give the area and the mask to the retina specialist. And here's an example. Clinician agrees with the AI mask, area fits the criteria, enrolled, additional images acquired, patient is ready to go. Here's another example, clinician agrees, but the area is 0.42 below the minimum criteria. So patient is not enrolled, but images are sent to reading center for confirmation. So we had about 33 eyes that have gone through so far, about half enrolled, and the retina specialist agreed with the AI report, about 73% of eyes, and 10 eyes excluded as out of range. Whereas when they came to the reading center for a reread, the criteria are a little more stringent at the reading center, and they agreed 67% of the time. So this is an example of real world. You don't get those beautiful cases in the real world. There are issues. GA is not well defined. No idea what's going on there. And then, of course, sometimes you don't get a GA in there, and you're like, okay, there's no GA, but the model worked. Sometimes, even though their instructions put Heidelberg, there are non-Heidelberg images submitted, and you have to remind this model works only on Heidelberg autofluorescence. And this was an example where the clinic said the model isn't working anymore, and we're like, okay, what happened? We see there's a grid that's on, take off the grid, and the model works again, and we don't know why. So in the clinic, a step towards deployment does include real-world testing. So robust testing and prospective testing is required before you know your model is ready, trial by fire for real-world implementation. Clinic workflow and getting clinician trust and their adaptation towards AI is a whole field by itself. And generalizability and bias need to be at the forefront all the time when you're developing these AI models. And that's all I have. Thank you to the whole team for participating in this project and helping us get it to where it needs to be.
Thank you. Thank you for that wonderful presentation. Really appreciate it. And keep the questions coming in. We have some wonderful questions in the chat. For those panelists who have just finished their talks, if you don't mind answering some of them, we'll actually get to some other ones in the chat as well during the panel discussion. And with this, I'm going to turn over to Dr. Ladd, who's going to speak on unleashing the power of ophthalmic imaging and AI for AMD and in glaucoma.
Thank you so much, Rishi. It's a pleasure to be here. And this is a broader talk linking AMD with glaucoma. The prior beautiful presentations were on AMD. These are relevant disclosures. But I'll talk to you a bit about two unmet needs today: irreversible degenerative eye diseases, geographic atrophy, and glaucoma. So for GA, and you've learned a lot about GA today, until February of last year, there have been absolutely no treatments approved to reverse or prevent its progression. Glaucoma has different challenges, yet similar. The early detection is challenging, and glaucoma generally remains asymptomatic in its initial stages. And this is what happens to the patients over time. they develop constriction of the field. And it's debilitating, just like geographic atrophy is, just from a different perspective. It has high rate of undiagnosed and untreated advanced disease. So we need to do better. And this is where AI can help. So I wanted to talk to you a bit today about the future state of AMD and glaucoma using AI. And you've seen beautiful talks on the state of the art where we are. You hear more going forward in this session alone. But we like to get to an aspirational, audacious future for the treatment of clinical patients with AMD and glaucoma, and also for clinical trials of these important diseases. How do we do it? What is it needed for this? So I'll begin by telling you where we are, AI and dry AMD from my perspective. I spend a lot of time treating dry AMD patients. So currently we have no FDA-cleared algorithms. However, quantitative algorithms require no validation, so perhaps the bar is lower. I'll talk to you a bit more about those. Predictive algorithms need to become software as medical device and require validation. But AI in ophthalmology has been in the mainstream and quite popular. And in diabetic retinopathy, we actually had made huge strides forward. We haven't gotten there in these two important diseases. I'll start first with the quantitative algorithms in dry AMD. And these are just a few examples. So on the left, you see this nice paper by Roy Schwartz from the group of Adnan Tufal and colleagues. It's a deep learning framework for detection quantification for reticular-pseudodrusen and drusen on optical coherence tomography. The data were obtained for over 1,200 participants in the UK Biobank with a self-reported diagnosis of AMD and 250 controls. The drusen and reticular-pseudodrusen were manually delineated by 5 retinal specialists, and the classification models performed strongly at their respective tasks. The models achieved high classification segmentation performance, similar to human performance. Now, here's another beautiful example done by Dr. Smits-Erfurt and colleagues. And this is on the role of deep learning quantified hyperreflective foci for prediction of geographic atrophy progression. And hyperreflective foci are the #1 predictor of progression to disease. So these were the hyperreflective foci were quantitatively measured during the progression of geographic atrophy, and local progression speed of GA correlated positively with local increases in these biomarkers. Now, photoreceptors and RPE loss can also be measured using automated identification of Ellipsoid Zone, and you'll hear a lot more about this from Dr. Ehlers in the next talk. Also, in a treatment paradigm, in a clinical trial, we use Ellipsoid Zone attenuation measurements to study the progression in non-exudative AMD. And this showed you here that the report describes a novel high-risk performance deep learning-based model for detection and measurement of EZ at risk. In a clinical trial setting, in both the phase 2 and 3, this can show the effect of treatments such as pegcetacoplan in preventing disease progression. Now, predictive algorithms are more involved. And some examples here. These are machine learning examples that predicted individual disease conversion in early AMD using artificial intelligence, also by Professor Smits-Erfurt, and also prospective longitudinally evaluated nascent GA in AMD. Now, you can construct an encyclopedia of biomarkers that predict progression over time. And we've used these biomarkers in machine learning studies to develop classification tree to predict progression to geographic atrophy at 1 year from intermediate AMD. You can follow the branches of the trees to detect the patients that have the highest risk of progression all the way to the right. That's a 75% risk using the combination of biomarkers here. At 2 years, you see a different classification tree using 2-year intervals. So you can construct a 2-year study or 1-year study depending on the needs. Now, our next challenge was to develop an algorithm that could use the retinal images alone. We call this deep gaze. It's a multi-scan position-aware model for GA prediction. The data used here was the AREDS2 data set, but this wasn't sufficient. So we used the publicly available data set by Kermani and colleagues to train the algorithm. This was based on individual OCT scan, unlike the AREDS2, which had the high resolution 100-line scans. We trained the algorithm using the 2 data sets and obtained a high-performance multi-scan position-aware model trained with PPI, and you can see the AUC here, 0.937. Importantly, when we added the results from human graders at the top, which is model number 1, you get very little benefit, only an incremental increase of 0.08. So this was very interesting to me as a clinician, that really the machine was able to outperform most of the tasks required here. Now, what I was most pleased about this algorithm is that we're able to develop saliency or attention maps, and we're able to show the patients with intermediate AMD that converted to J in 1 year. The algorithm delineated areas of importance. Some were well understood to us from prior biomarker work, and some were totally new in the choroid or near sensory retina. So more knowledge is needed in this disease to elucidate what is happening, and I think AI can help us. We validated the deep gaze model in standard of care Heidelberg OCTs. The ARES2 data set were actually bioptogen OCTs, so in a different device, we're able to obtain high performance metrics for this validation, and we're very pleased with this and hopeful that it can be implemented in future clinical trials. Now, what's the future state of dry AMD using AI? Where do we need to get to? We need to screen AMD stages for referable pathology. You've heard a bit about this. We can diagnose things that mimic AMD. We can predict stages, and we can monitor the disease using devices such as home OCT. And there's a lot of benefit for this clinically, as you can see from these images. Now, also, the goal is a clinically meaningful software as a medical device and also use in a clinical trial environment. What do we need to get there? A lot of things: large labeled image data sets, solutions for data sharing, improved knowledge of machine learning, and benchmarking, and FDA clearance and approval. Now, glaucoma is a parallel degenerative disease, also very challenging. Where we are today, we have a lack of a unified gold standard of glaucoma diagnosis, which is one of the biggest challenges. Each test focused on a different aspect of the disease, and no AI systems are FDA cleared for glaucoma diagnosis. Felipe Madeiras and colleagues did innovate in this space by using OCT and color fundus autofluorescence, and they're able to use color fundus to predict OCT findings in this disease, establishing a new paradigm, and this will be very helpful. We can also use AI for diagnosing glaucoma using all these other imaging modalities. Future state in AI, we need physician cognitive support in this disease, promoting health equity, bringing AI to patient clinics, incorporating the patient voice, and resolving ethical concerns related to AI. And what we need to get there, a whole bunch of items listed here and great resources. But my last slide would like to tell you a bit, as clinicians and clinical trialists in the audience, about whether deep learning and AI will replace human experts. And Garry Kasparov, one of the most intelligent people in the world, world chess champions, longest lasting so far, had said that this is not the case. In the past, our tools made us stronger and faster, capable of lifting mountains and rocketing into space. Our new tools, like AI, will make us smarter, enabling us to better understand our world and ourselves. And we may not comprehend all the new rules the machines invent, but will benefit from them nonetheless. The biggest challenge for all of us here in the audience is to still keep thinking up new directions for AI to explore, and that's a job that can never be done by the machine. That can be true in GA, glaucoma, and other diseases. Thank you so much for your attention.
Great, thank you, Nora. That's a great presentation. So we're going to get to some questions for the panel, and please, again, feel free to enter questions in the chat. We have lots of room in our panel discussion to get to them, and we have some great questions coming in already. So. And with that, I'm going to turn over to my colleague at the Cole Eye Institute, Dr. Justice Ehlers. He's going to speak on assessment of ellipsoid zone integrity in retinal diseases from biomarker characterization to approvable endpoint.
Thanks so much, Rishi, and it's really an honor to be part of this great meeting. Let's see if I can advance here. These are my financial disclosures. So as we've heard today, dry AMD has really entered into a new frontier in terms of our therapeutic options. With recent approvals of new treatments for geographic atrophy, there's really a new focus for expanding our opportunities into the intermediate AMD space, as well as being able to better predict geographic atrophy progression, as we've heard from many of our speakers already today. But one of our biggest challenges has been identifying those endpoints and biomarkers that are potentially approvable and achievable for clinical trials. Traditionally, we've looked at things like visual functions or fundus autofluorescence, geographic atrophy change. So when we think about intermediate AMD as well as OCT progression risk, we really need to define for us what defines progression. Is it progressing to GA? Is it progressing photoreceptor loss? Or is it progressing for hypertransmission? We know from multiple different groups there's OCT features that have been linked to progression, like hyperreflective foci or drusen features, as well as iRORA. When we think about biomarker progression in dry AMD and the sequence that we see here, we think about drusen initially, as well as then subsequently ellipsoid zone loss, the development of hyperreflective foci, hypertransmission defects, and then iRORA preceding geographic atrophy development. When we think about how we can look at this in terms of OCT endpoints, we then need to understand how can we translate that into a clinical trial. For key needs for clinical trial endpoints, we really want them to be functionally relevant. We want them to be minimally disruptive to our trial sites in terms of the testing that's needed, as well as scalable both at a site level and at a reading center level. These need to be interpretable and able to be validated for accuracy and not just solely black box. And then we need to link this to key disease underlying pathology of interest. So one of the areas that we've been particularly interested in is quantitative ellipsoid zone integrity and being able to use this in multiple different retinal diseases, including age-related macular degeneration. One of the key reasons is that ellipsoid zone integrity has been linked to visual acuity in multiple different retinal disorders, from macular holes to diabetic macular edema to degenerative outer retinal diseases such as dry AMD. The early studies really focused on qualitative assessment or just single B-scan lines. But now with new technologies through AI enabling, we can look at this across the entire macular cube in ways that weren't previously possible. One of the big questions that we get is, can we apply this technology to intermediate AMD? And there's some very specific challenges that are in place. Confounders that we need to consider, such as the complexity of drusen anatomy and variability, the impact of directionality on the changes to the retina and the visualization of the EZ band, as well as optical artifacts and other changes that may be occurring. So one of the opportunities with AI that we know is that it augmenting our segmentation accuracy, as we've seen, to allow us to go from just qualitative to quantitative. And some of the really early work that we saw with using automated OCT segmentation and deep learning was that this could really enhance our accuracy to near the levels of what clinicians are able to do. This has been done by multiple groups. This was work done there at Duke that showed that using AI-based segmentation, we could actually achieve near similar levels to what we can do with human readers. So does using this technology now open the door to new measures such as ellipsoid zone integrity quantification? What we've been doing at the Cleveland Clinic is explored multiple different approaches, including initially just image processing algorithms, but now more recently in the last 5 to 7 years, using machine learning enhancements in multi-layer segmentation, as well as multi-architecture systems using things such as GA detection and hypertransmission detection to have an interactive feedback system to allow for using multiple different disease features to interact with what we're segmenting and hopefully enhance accuracy. One of the other areas that's been really important for clinical trials is to be able to use this on multiple OCT devices. Using this in only a single system really restricts which sites you can use, as well as potentially the number of patients and the rate of enrollment you can have for a clinical trial. We also want this system to be interpretable. When we look at our current regulatory bodies, we need certified reader objective assessment for validation unless we have an FDA cleared or agency cleared system. For us, we've also used a high intensity training program for readers to really elevate consistency and reliability across the platform. So what are we evaluating here for ellipsoid zone integrity? When we look at this, we have a few different definitions. One is complete absence of the ellipsoid zone, which is termed total EZ attenuation. And this is where, when we look at the B-scan, the ellipsoid zone is completely gone. When we also look at this, we can measure areas of early damage, such as partial attenuation as well. We can look at this zonally, which may have implications for visual acuity assessments. And when we evaluate this both at a purely manual level, as well as when we use deep learning or deep learning assisted, we see that there's significant consistency across the board between readers as well as between systems.
So one of the exciting things is that we've seen through multiple different groups a therapeutic signal in complement inhibition for dry AMD and geographic atrophy. In the phase 2 Reclaim 2 assessment from the Stealth trial, EZ was actually pre-specified as a secondary endpoint and showed that elamipretide reduced progression of EZ loss compared to placebo. In the phase 3 programs, both assessment in the GATHER program as well as in Oaks Derby from 2 different groups have shown that complement inhibition can reduce progressive EZ loss over time, again, signaling an importance of photoreceptor targeting in our clinical programs. Work done by the Vienna team also showed in the Derby and Oaks program that those eyes that had a greater excess in photoreceptor loss had a faster growth in terms of geographic atrophy compared to those eyes that didn't. And similarly, when we looked at this in the GATHER program, we found very similar findings, and that is that we could potentially identify those eyes that could be enrolled earlier into trials and have a faster rate of growth in terms of geographic atrophy over time. One of the big questions is there a functional signal for ellipsoid zone integrity and macular degeneration? And studies are giving us more and more information with this. This was recent data from a cohort analysis we did at the Cleveland Clinic showing that visual acuity was clearly linked to the amount of EZ loss in eyes with intermediate AMD, both in terms of within the central subfield as well as when we looked across the macular cube. When we looked at this in the GATHER program, we also saw that those eyes that went on to develop vision loss had progressive photoreceptor loss over time. This correlates with what we see from a functional standpoint. And when we also look at those eyes at greatest risk for vision loss over time, we see that those had much greater compromise in the central subfield of their ellipsoid zone status compared to those eyes that maintain vision over the course of the clinical trial. What about treatment response prediction? This was an analysis that we did independently from the Cleveland Clinic as well as with the Duke Reading Center to evaluate rizatigimab response from the Allegro trials. When evaluating this, we wanted to know which eyes actually responded with visual acuity gains. And what we found was that those eyes that responded to the therapy had much better EZ preservation compared to an example here with an eye that didn't respond at all with near complete ellipsoid zone wipeout. What was exciting about this was done with 2 independent reading centers with 2 completely separate evaluation systems, really honing in on the importance of ellipsoid zone for treatment response in this therapeutic. So overall, in conclusion, really AI-based platforms and computation image analysis are likely to play a major role for us in clinical trial enrollments in developing new key endpoints for the future. Additional research is really needed to better understand the role for these systems in the field and the opportunities for acceptance of these parameters by various regulatory bodies. But the emerging technology related to this field is likely to provide a major inflection point for us in disease characterization, feature detection, and really being able to have better precision medicine in the way we manage these diseases as well as these clinical trials. I want to thank my team at the Cleveland Clinic, and again, I want to thank the organizers for the opportunity to be here.
Thank you. Thanks, Justice. That's great. So we're going to get to some questions for you. And again, I see some questions coming in the chat. Encourage more of those to come in because we're going to be able to get to them at the break and the panel discussion very shortly. Our last talk of this session is by Dr. Zhang on adaptable GA segmentation using deep learning approaches from different imaging modalities and scan patterns. Dr. Zhang, are you muted or can't hear you?
Okay.
Yeah, we can hear you now.
Can
Go
you hear
ahead.
me?
Yes, perfect.
Oh,
Yeah.
sorry. Yeah, thank you, Dr. Stan. Yeah, so today I'm going to present our recent work for the adaptive OCT segmentation using deep learning approach for different OCT imaging modality and scan patterns. My slides can't work. Okay, yeah. I'm from Carl Zeiss. This presentation, this slide deck is on my own. Do not represent the company. I would like to thank our colleagues in our AI team at Dublin, and also the CRT and the Indian team from Zeiss, and also our external collaborators. So for the motivation for this project, as we know, the GA is a condition of present of the advanced dry AMD, and GA is kind of a huge impact to patient lives and progress over time that can lead in irreversible vision loss. And also GA can be realized in the FAF images that can be shown. Does not work. On the FA image shows dark signal caused by the loss of autofluorescent signal. And as we know, OCT is a 3D image modality that can provide additional information to reliable and identify GA and segment GA. So it is also referred by the camp meeting. This is the preferable image technologies for GA disease monitor and detection. Until last year, there's no FDA-approved treatment to reverse and prevent the disease progression. And although the recent FDA-approved drug, it only can slow the progress of the GA. So it's kind of essential to monitor and treat and detect the GA over time. For the clinical value, for the clinician, the ability to reliably and automatically outline GA from different OCT device and scan patterns, and also to measure its property is kind of important. It can advise for treatment responsibility and also to monitor the treatment outcomes. And for pharma company, the ability to quantify GA appearance and growth to define clean outcomes of their drug study without any manipulation of the data is also essential. And for researchers, the ability to automatically measure growth and the presence property in large dataset that can accelerate the research on GA appearance and expansion. So therefore, to better monitor and the progress of the disease and its treatment, there's an immediate need to reliably and accurately segment and quantify GA lesion based on OCT image modalities. So the solution from our side is we want to develop an automatic segmentation and quantification algorithm using OCT technique. And as we know, according to the camp meeting, there's a different property has been identified for the complete RP and autoretinal atrophy. One is the loss of the retinal autoretinal layers, and another is the RP loss, and the third one is the choroidal hypertransmission and defect with the size of 250 microns. So our solution, we want to combine all these three features from the one single 3D OCT data and encoded into 3 color RGB channels to get this precise color image as an input for the deep learning model. Before train the model, we want to ask questions about whether we can integrate different OCT image modalities. As we know, OCT has spectral domain OCT and swap source OCT, and they have different features. For spectral domain OCT, we have a shorter wavelength and cause a higher lateral resolution. And due to the infrared camera, with the scan speed is can up to 100 kilohertz. For swap source, across the scan speed is can be up to 200 kilohertz, but it has a longer wavelength, so has a kind of relatively lower lateral resolution, but has a deeper penetration. So due to all these kind of features, the OCT signal appearance is different. And also the penetration is also different, as I just mentioned. So may we ask the question, is there any difference of the GA or hypertransmission defects measurement between this SD and SSOCT. According to previous publication, we found that there's a high correlation between the hypertransmission defects error measurement between SD-OCT and SSOCT. So the answer for this question is yes, we can use SD and SSOCT to measure G size and also use it interchangeably. And the second question is because the G can grow over time, so we cannot like fix one scan pattern like one field view image modality to monitor all the disease progression. So with the second question we want to ask is other G area or growth rate measurement on small field view on large field view is interchangeably. So according to the publication, this answer is yes. Yes, we can use different scan patterns like 6x6 or even larger to 12x12 to do the G segmentation interchangeably. So in our solution, we use data patching to do the machine learning algorithm to patch different size images into the model, so we can train a more complicated model by feeding different scan patterns and different image from different OCT image modality to train a refined UNet do the G segmentation. So we collaborate with different clinical site and academic site. We collected over 400 images from different sites using spectral domain OCT and source source OCT with 6x6 scans and 12x12 scans to train the model. All the data was divided into 8% training dataset and 20% evaluation dataset. So the training performance shows a very high sensitivity up to 0.95 and specificity up to 83%. And we also have the very high dice accuracy up to 91%. To test our model, we use an external dataset contains 30 patient, including both spectral domain OCT and the source source OCT, and to measure the absolute error difference, compare the algorithm output to the manual grader, and to measure the absolute error growth of absolute error growth, and to measure the correlation between the manual and the algorithm output. So here shows the example that we ask 3 questions: how good is the algorithm to finding GE and non-GE regions using sensitivity and specificity? So we can achieve 0.99 sensitivity and 0.93 specificity on the test dataset. And we also have a very high accurately segmented GA. The dice is over to 9.2. 9.2. And the second question we asked is how compared to other G area and the growth measured from the algorithm compared to the manual graders. So we have the absolute error difference with the manual mask can less than 0.56 millimeter square, and the absolute error growth per year difference is also less than 0.124 millimeter square per year. We also achieved a very high correlation coefficient. R square is up to 0.986. So this all the results shows in the slides. And this kind of example that our algorithm can segment the GA from the source OCT and also from spectral domain OCT with a very high dice score. Of course, no algorithm cannot be perfect. So there's something need to consider on this algorithm that we do need an editing tool for clinical use to get rid of the absolute error caused by like disc atrophy or other kind of artifacts. And another thing, this algorithm is dependent in the layer segmentation algorithm. We extract 3 features using different layers. So if there's a layer has a segmentation error, then definitely will affect this algorithm. So in future, we may get rid of the layer segmentation, they get rid of the dependence that we can train a 3D model to do the GA segmentation, may improve the performance of the future clinical studies. And that's all from my today's slides. Thank you.
Thank you. All right. Well, I appreciate that talk, and we're going to get to the panel discussion now. So I'll have everyone join us again, and we have a wonderful amount of time here now to ask the questions that were asked by the audience members. And again, please feel free to enter those in the chat. I'll start off with Dr. Ladd. You know, you presented on glaucoma, and I just I'm always impressed by, at least from my standpoint, how little has been done on glaucoma, because there seems to be, you know, obviously a great amount of predictive factors, predictive studies out there. There's a great amount of progression. We have, you know, GPA, which we've known for years has been valuable to the glaucoma community. Why haven't we seen an algorithm come out? Because we've seen it for DR and we've seen it for other conditions, but for glaucoma, it seems like it's still a little bit in the dark ages compared to the retinal community. Is that my assumption, or is that reality?
Well, the truth is, it probably would take hours to talk about what's been done in the glaucoma. A lot has been done, but you're correct at the same time. So currently, AI research has been focused on a few things: disease screening, diagnosis, and progression. So we looked at optic disc characteristics on fundus images, retinal layers, and patterns of visual field loss. But we need a lot more research to look at treatment response prediction to facilitate personalization of care and improve clinical trials. So yes, there are no FDA-approved AI tools, as I mentioned, in glaucoma. There are a few companies that reported development of ongoing AI products for glaucoma screening. So we're focusing on screening here. iHealth Screen, iNOC. In addition to use of imaging, there's ophthalmic therapy innovation that has technology that looks at diurnal IOP variation for 24-hour IOP monitoring. And that will be important because it leads to glaucoma progression, and that's an early signal. But there are a lot of obstacles. And again, it would take an hour to talk about all of them in glaucoma. There are two. The main ones are there's no consensus definition of the disease, whereas we have it in AMD, so we're far along there. And then there's no standard diagnostic algorithm for glaucoma screening so far as we have for diabetic retinopathy. So that will pose challenges for regulatory approval. So we are ahead in AMD because of how the disease is defined. A lot more work to be done in glaucoma to get there, I think.
Yeah, and that's great. Do any other panelists have any comments on the glaucoma side of things? I know you're all retina people, but I think it's a really interesting phenomenon that we haven't come to that same consensus we have with macular degeneration in many ways. All right, Dr. Mooney, you presented on the study on ranibizumab, and I wonder if you look at your data, and I know you did this study obviously with your data set in Toronto, I believe, is where you had the data set locally. When you look at Ang2 inhibition, or other anti-VEGFs, the newer agents, the higher dose agents, do you expect to see some differential responses? Have you kind of thought about how that might look like, or are you planning on a study in the near future for that?
Yeah, so actually, this is part of a large prospective study where we are looking at AMD, DME, and RVO, and we are following patients prospectively on ranibizumab or aflibercept. We haven't initiated the study with faricimab yet. But essentially what we're doing is we're hoping that because we've taken aqueous cytokines at every time point over this 18-month prospective study. And what we're hoping is that we can utilize the baseline cytokine values as well as the change values and the rate of change to predict their outcomes in terms of the number of injections, visual acuity outcomes, and so forth. So, what we're hoping is that using all of these different things today, we just showed you the quantitative IVFA parameters, but also we're also quantitatively looking at OCT, and we'll also have the cytokine biomarkers. We're hoping that we will be able to use all of that to predict the response to different treatments and hopefully tailor our treatments. So, do I expect a different response? I mean, I think, we may expect more durability perhaps with the newer agents, but we're really hoping that we can personalize even just the interval, like how often someone will need an injection, for example, based on their baseline VEGF level or Ang2 level or placental growth factor level and so forth. So,
great. Dr. Donapalli, there's a question from the chat about what would it take to make these models useful for clinical trial grading as opposed to screening only purposes? What are your thoughts on that?
Yeah, that's a great question. So these GA segmentation models, whether based on autofluorescence or OCT, they are very useful in clinical trials. None of these models are, and in reference to your questions, how do you see this being widely used? They're all augmentative. So they come as a package with a human. So they're not independent autonomous algorithms. And so establishing these in reading centers with a grader just becomes a tool, just like how currently Region Finder is used by the graders. This becomes another tool, a deep learning tool, and an editable platform is very important because the AI makes mistakes. And so that comes as a package. These are no way to be used autonomously out in the wild. Just put the data through this and extract it and use it without any human oversight.
Yeah. Yeah, and I had a question for you about this. There's so many algorithms coming out now. There is obviously the ones that we heard from Dr. Frank that she's using obviously in her practice and her research work. We heard some of yours. We have, companies like Retinal AI that have their own as well. So in this consumer world, how do you see these being adopted or used? Maybe this is a broader question, but I'll start with you, Amitha, and kind of ask you the question. Like you're obviously a clinician, you potentially may use these. How would you end up choosing which one to use?
That would be a great problem to have, right? To have multiple AI models to choose from and make the decision. Currently, in the regulatory landscape, we cannot have these tools for clinical decision making without FDA clearance. So right now, we don't have anything ready to use. But the day will come, as we saw recently, a fluid segmentation algorithm got approved, cleared. So the day will come when we will have all these tools available. And fortunately for us, the radiologists in their consortium, huge consortium, have just come up with guidelines on what do you use to implement, purchase, monitor AI once you have these commercially available entities. And there's a checklist for them, your strategic planning, your IT environment, your workflow, explainability of the model functionality, and how much money can you afford to implement it. So there's a huge checklist and it's beautifully being laid out. So when we get there, we will have a pathway to follow.
Great. Dr. Frank, I was intrigued by the type of lesion and the fluid. I always assumed that there were differential fluid assumptions, right? With occult lesions, you may have more subretinal fluid, not as much intraretinal fluid. With obviously type 1 or classical lesions, you may have more of or RAP lesions for type 3 lesions, you may have more intraretinal fluid. But you didn't show that. Were you surprised by that finding as well in the research work you presented?
Well, I agree for intraretinal fluid and the RAP lesions. We also expected this result that you just said. We expected the highest volume here. Although we did find a higher volume of intraretinal fluid in the type 3 compared to type 1, we didn't find a significant difference to type 2 MNV. However, also due to the location of the subretinal MNVs and the type 1 MNV, we did not expect too much of the intraretinal fluid in this type MNV. But there were some surprises within our results. However, results are results. We have to present them as they come. One result that we were expecting here was the intraretinal fluid in the type 3 MNV. However, the lowest was for type 1, which does make sense here. And for the lowest amount of subretinal fluid in the type 3 MNV, we also could expect that due to the localization of the movement towards the choroid from the CNV. So we were not surprised by that, but it would be interesting to also look into the effect of the MNV type on the photoreceptor condition. So one study from 2022 actually showed that type 1 MNV also had a protective effect for atrophy, and type 3 had more atrophy. So this might be something that we could look into in the future as well, to also complete this circle of how does fluid affect photoreceptors, and how does the MNV play into this function and pathophysiology of the disease.
That's great. No, thank you for that. That's great insight. Justice, you presented on some of these endpoints for clinical trials, and I know that you're involved in some of the newer drugs that are being investigated right now for clinical studies. And I wonder if you might want to comment on sort of, the mechanics of this, so is this something that's automated? Is it quick? Are clinicians going to be in the people that are in this trial that are enrolling? Are they going to have to, is this something they're going to actively have to use as part of the study, or is it just going to be an endpoint that we get at the end as a secondary readout, and that's going to be kind of the endpoint readout for the study?
It's a great question, Rishi, and it's something that a lot of the companies are exploring, of doing things like pre-screening before you put a patient entirely through all of the workup that's needed to decide on whether they're eligible for randomization. I completely agree with Amitha's comments and love all these packages come with a human. I think that that's a really important piece of the way we're looking at this from the clinical trial side right now. And at least from the regulatory side, we still need to know what's the interpretable outcome of it. They are now, what these systems, as we've seen from many of these presenters, are allowing is much more rapid scalability. And, I'm not going to say necessarily, all the key things impacted that we know it impacts our segmentation algorithms currently, image quality, overall complexity of pathology, all can make an impact on the amount of work that goes into validation at a given B-scan level. But the performance of these are really becoming quite good. And that's allowing us, to look at 10,000 time point trials and be able to scale that type of technology, looking at everything from whether it's fluid, segmentation to ellipsoid zone segmentation. So I think that what we will see is many of these, at least in the dry AMD space, they are using these as either inclusion or stratification. But we're finding, at least with our experience, this can be turned around very quickly and be able to be used very similarly to what we might say of what current screening and inclusion exclusion are, like amount of hemorrhage, that's in a CNV lesion. So I think that the beauty of what we have now, technology, is it's just opening those doors in ways that it wasn't previously.
Yeah, I like that a lot. That's great. Dr. Zhang, this question is for you, actually from Dr. Damapalli, about hypertransmission being an overwhelming feature of GA, and the models tend to be biased toward detecting that. How do we assure that really we're going to be sticking with the CAM criteria of IRORA and CRORA as part of that process? You're on mute, Dr. Zhang.
Me?
Yes, I can hear you now. Yeah, perfect.
Yeah, that's a good question. So we do consider other features that are recommended by the CAM. So like the loss of the autoretinal layers, IP loss. We use the retinal thickness map as kind of indicator of the loss of the retinal layers. And we use the optical attenuation coefficient values that extracted to represent the RP loss. So those features are considered in our model, and also well balanced with the called hypertransmission defect that we can fit into the 3-channel color image for the model. The question is how to ensure this. I cannot ensure, but it's we extract all the features and do our best to balance all the features in the model. So yeah, that's kind of question that I can answer for now. Thank you for the question. Yeah.
Yeah, thank you. Great. Okay. More to come on that, I guess. So with that, we're going to turn over to the sponsor presentation. But before I do, I just want to, again, promote the first talk that's going to be happening just after the break. It's actually by Dr. Malvina Edelman. She'll be speaking on the future of this device approval kind of area and what's happening in innovation. She's also the director of the product evaluation and the FDA for technology. So really great to hear her insights on the future of this development and the regulatory pathway that may occur. And with that, we'll turn over to our sponsor presentation. Thank you.
Thank you so much, and it's a pleasure to be here and to speak on behalf of my research group and my collaborators. And I'm going to discuss the use of artificial intelligence for biomarkers in geographic atrophy, but specifically in the context of drug development. And those are my disclosures. So, of course, the first task in a clinical trial for geographic atrophy is to measure the geographic atrophy lesion as the primary endpoint. And our group, just like so many other independent groups worldwide, have been developed GA segmentation algorithms for FAF and optical coherence tomography using or not fundus autofluorescence. So what we see here is different efforts in delineating the GA area as the primary endpoint. And a couple of take-home messages here. First, now what we're doing is enabling the mining of historical data sets to help us design better future clinical trials with refined inclusion-exclusion criteria and with refined overall clinical trial design. Now, I want to say there's definitely a role for human experts, and we continue to count on our expert manual graders because no algorithm is perfect. And what we have seen is that some GA segmentation algorithms, they do fail when the image quality is poor. So similar circumstances and challenges that the human would find for grading. A second main task in the clinical trials for geographic atrophy is the ability to predict the GA progression over time. So we developed in our research group deep learning and different models to predict not only GA area, but GA growth rate over time. Our group, like any other independent group involved in drug development, does use baseline characteristics to help us understand the future GA growth. So what we know from the legacy trials, as well as multiple studies in the literature, is that there are some baseline characteristics that do predict future GA growth. But what we'll also learn is that the GA progression predictions of each individual patient is actually the best predictor for future GA progression. So in our last two recent phase 2 trials, we have been using the growth rate before treatment as a parameter to predict future GA growth treatment. Why that matters? Because now when we look at the standard statistical models that we use in clinical trials, and when we use the baseline benchmark characteristics that I listed in my previous slide, or when we use the running, or when even combine both, we see that the prediction value measured by the R-square is favorable, but is not stunning. So it's around between 0.3 and never gets close to 0.5 in our observations. So then we move to use machine learning-based models to try to improve the capacity to predict GA growth, but without much success. What we did next then was to use raw images to predict not only GA area, but also to predict future GA growth rate. And what we find using OCT or fundus autofluorescence or a multimodal approach is that the deep learning based on raw images prediction is much, much better. So very promising R-square. And we can even predict the regions to where GA is going to grow, not only the area, but also the temporal and topographical progression. But why does that all matter for clinical trials? It's because in a pathology such as GA, we understand that the interpretation of clinical trials result might be challenging, and especially when we have imbalances across arm or when we have a very heterogeneous population. So any drug developer has been using prognostic models to increase the confidence in the interpretation of the clinical trial results. And that's what we have been doing as well. So as I mentioned, as a field, we have been using prognostic models for clinical trial adjustment. And as a field, we have been using mostly the baseline non-prognostic factors or the baseline clinical characteristics. And as I mentioned in our recent trials, we have been combining those with the running. But of course, observation before treatment is burdensome for patients and investigators alike. So what we learn now is that using our deep learning-based model, the prediction for the prognostic model is much better, and we don't need to submit patients and physicians to an observation period. Why that matters so much is because of a concept that is called the effective sample size increase. And that's a very heavy table, but I'm gonna guide you through. In my first row, you see the R square of the traditional models for prognostic and covariate adjustment, as I mentioned before, the benchmark or the benchmark plus the running observation. And you can see in the multiple data sets, either the independent holdout or a couple of clinical trials, independent clinical trials that we use to also validate those models, and the R square is very stable. When we compare the effective sample size versus an unadjusted clinical trial result, we can see that by adjusting with the deep learning fundus autofluorescence model, our effective sample size increase is above 90%. That would be equivalent of having a clinical trial with more than 90% patients without actually enrolling any patient. And even when we compare to our standard best practices, which are the benchmarks, we have better than almost double of the effective sample size increase. So I'm going to finalize this concept by showing a historical clinical trial, which was one of the largest phase 3s ever conducted for geographic atrophy. What you see in the first graph is our clinical trial phase 2 that seemed to show a positive effect, which we know now that was a false positive effect. And we know that because very large independent combined phase 3 trials shown that in reality there was no positive treatment effect. Now, what you see in my third graph is that when we deploy the phase deep learning fundus autofluorescence model as a covariate adjustment, the false positive treatment effect vanishes. So therefore, the use of deep learning as covariate adjustment truly increases our effective sample size estimate and our ability to interpret the clinical trial results. Thank you very much.
Thank you so much, Daniela. That was great. We'll now have a video. Thank you so much again to our sponsors, Genentech and Regeneron, for which we really would not be able, without which we would not be able to do this program. So let's go on now to session 3. which is on age-related macular degeneration. I'm Jennifer Lim from the University of Illinois, Chicago, where I serve as the Marion Schenk Chair of Ophthalmology, Vice Chair of the Department, Director of the Retina Service, and UIC Distinguished Professor of Ophthalmology. And it's really wonderful to be here with all of you today and with our distinguished speakers on AI. Our first speaker of this session is Dr. Malvina Edelman, who is Director at the Office of Health Technology 1 at the Food and Drug Administration. Dr. Edelman will speak on paving the path to global ophthalmic AI innovation, the CCOI. Malvina?
Thank you very much for your introduction. It's a pleasure to join you today. As we heard so far from all of the talks, AI/ML-enabled medical devices allow us for tremendous opportunities to have a significant positive impact on healthcare across many medical fields. Unfortunately, there are still a number of challenges. There's issues with fit-for-purpose data sets, identification and minimization of bias. There's issues with opacity of some of the algorithms. And we always want to make sure that we provide enough oversight for an adaptive system. We at FDA have been working for over a decade now to advance AI regulatory science to help advance innovation and protect public health. Our goal is to come up with a tailored regulatory framework for AI/ML-enabled devices so that we can enhance patient access to high-quality digital medical products while maintaining a reasonable assurance of safety and effectiveness. Starting with 2013, we have published a very significant number of foundational policies on digital health. Each one of the little boxes on the slides represents a different guidance that we have written to convey our thinking about a particular aspect of regulation of AI/ML. And the link at the left bottom provides access to each one of these. In addition to coming up with regulatory policies specific to the United States, we have done extensive work with International Medical Device Regulatory Forum in order to accelerate international regulatory convergence. Back in 2013 was the first key consensus on SAMD definition. One, as you know, unless we have consistent terminology, it is really hard to come up with consensus for anything else. So 2013 key definitions paper was truly a foundation that allowed us to proceed. And as you can see, in 2014, we came up with a SAMD risk framework. In 2015, it was followed by quality management system. Then in 2017, recommendations for SAMD clinical evaluation. In 2020, we focused on cybersecurity principles and practices. In 2021, we had a unique collaboration between FDA, Health Canada, and UK in order to come up with 10 good machine learning practices for medical device development guiding principles. In 2022, we published Machine Learning Enabled Medical Devices, Key Terms and Definitions. And while the rest of the documents aren't finalized yet, I want to assure you that we are continuing to collaborate with our international colleagues to advance harmonization and drive shared best practices so that all the developers around the globe can have clarity on expectations that are aligned across the globe, and in order to promote the development and assessment of safe and effective digital health devices. In 2020, we at FDA formulated a Digital Health Center of Excellence. Now, this entity has three main goals. One is to innovate regulatory approaches in order to provide efficient and least burdensome oversight. We also aim to share the knowledge to increase awareness and understanding and drive synergy and advance best practices. And very importantly, this center aims to connect and build partnerships around the globe in order to accelerate the digital health advancements. Since its inception, we have had quite a number of significant milestones, which I clearly don't have time to summarize in a 7-minute talk. So I decided to just highlight three of the milestones summarized on this busy slides in the next couple of slides. This is something that has been proven to be an incredible tool for all digital health sponsors around the globe. We put together something called the Digital Health Policy Navigator, and it's a very easy, stepwise, interactive questions that help product developers around the globe to see if a software function is a potentially subject to or the focus of FDA's regulatory oversight as a device. And again, the links below on each of these slides will take you to this, which will provide you much more information. The next one I decided to highlight is our draft guidance on predetermined change control plan for AI/ML-enabled device software functions. It's key in that it clearly says that an authorized PCCP, which specifies plan modifications that, if not included, could otherwise require new marketing submissions. But however, that the modifications can be implemented to the MLDSF without triggering the need for new marketing submissions, and that modifications that are not specified in authorized PCCP could require a new marketing submission. The reason I wanted to highlight that is we're currently working on final guidance for PCCP, and hopefully you should be seeing it soon. Another guidance that we're currently working on was informed by the responses to the discussion papers that we published last year on using artificial intelligence and machine learning in the development of drugs and biological products. As all of you know, ophthalmology is and has been at the forefront of AI/ML devices. I'm sure everybody in the audience knows that IDX-DR was the first FDA AI device in any subspecialty that reached the market that performed diagnosis without physician input. And we have stayed, the ophthalmology has continued to lead AI/ML regulatory framework in many ways. One of the key aspects of our success is our close participation with a collaborative community on ophthalmic imaging, or CCI. For those of you who are not aware of this organization, it was formed in 2019 with a mission to clarify challenges, best practices, strategies, and standards while advancing innovation in the ophthalmic imaging space. Since then, it has become a self-sustaining entity of 501c3 status. It had partnered with 16 collaborative member societies around the globe, implemented 6 working groups, which are delineated in the current organization picture on the right. And I just wanted to highlight that a lot of the talks this morning touched on aspects that are covered in each of these groups, such as PHI, PAI, foundational principles, macular degeneration, ROP, ocular oncology, and glaucoma. we have published 7 articles that delineate consensus and areas of lack of consensus and areas where consensus needs to be prioritized within each of these groups, by each of these groups. Now, within the last year, CCI has also been awarded by FDA a contract to do a study assessing enhancing visual health equity via novel real-world underserved population health data sets utilizing ophthalmic imaging and artificial intelligence. CCI hosted 4 annual conferences so far that have drawn tremendous interest from around the globe. As you can see, this year's conference, we had over 1,100 registrants from 49 countries and 6 continents. For anybody who is interested in AI ML in ophthalmology, I strongly recommend you save the date for our next meeting in January 23-24 of 2025. Now, encouraged by the enthusiasm around the globe about the work that we have done thus far, we as an executive committee of CCI are planning to expand significantly in the next few months. And this picture summarizes the expansion areas. So we are still keeping the 2 horizontal groups, one focused on PHI, PAI, and the foundational principal subgroups is going to have a subgroup underneath it that will be focused on imaging standards interoperability. The AMD group that is being led by Emily Chu is expanding its scope to encompass all of fundus and retina. The ROP group that is chaired by Michael Chang is expanding its scope to encompass all of the pediatrics. The ocular oncology and glaucoma groups are going to continue as they have been at the moment. And we are currently in the process of adding 5 more vertical groups, 5 more vertical groups. One is cornea and cataract. One is going to be myopia. And next one is neuro-ophthalmology in orbit. We are adding also something that is generating enormous amount of excitement, which is oculomics, and a group on profound visual loss. We are aiming to expand the executive leadership of these groups, and many of the leaders are going to be OUS. So previously, the 6 working groups have been led by US based, and now the new groups are going to have co-leads from all around the globe. We also have starting a stakeholder council, and we are going to be inviting all industry, all patient organization, and all academicians who are interested to participate actively in the planning and conducting of CCI annual conference, including addressing real-world and relevant challenges via the industry panels and sessions of the conference. We're also going to be asking Stakeholder Council to contribute with input on priorities of CCI as an organization and what should be next as we move towards our mission. The Stakeholder Council will also be asked to join one of more working groups if interested. So with all of that, I hope in my very short talk, I was able to give you a brief oversight of how FDA is contributing to global ophthalmic AI innovation. Thank you.
Thank you so much, Malvina. That was wonderful. Thanks for all you're doing in leading the FDA regulations and for leading the CCOI and all the excitement related to it. We look forward to the discussion. Our next speaker is Simrat Sodhi. Simrat is a 4th-year medical student at the University of Cambridge in the UK, and she'll be speaking on clinic-ready OCT, Bridging the Gap in GA Segmentation for Precision Management. Simrat?
Thank you so much, Dr. Lim, for that introduction. My video is lagging a bit, so I'm going to turn that off for the rest of the talk, just so we can focus on the data. But hello, everyone. Like Dr. Lim said, my name is Simrat Sodhi, a final year medical student at the University of Cambridge, and I'll be sharing results from our recent GA segmentation study. I have no financial disclosures. So the approval of GA therapeutics has made it more important than ever to accurately measure the area of geographic atrophy. The motivation behind our study was to develop an automated algorithm that can be used to reliably track the progression of patients receiving therapy. On-FOS visualizations of hypertransmission defects in OCT is now an accepted structural endpoint in clinical trials, and patients are already followed clinically using OCT, so we focused on this modality for our study. And there are three things to keep in mind as we move forward from more of a technical aspect. One, all existing methods use some form of prior segmentation before generating an output. We'll be going through this in the next couple of slides. The second thing to think of is that fixed offsets or parameters don't always give you optimal segmentation or slab generation. Again, I'll talk about this a little bit later. And finally, we inherently work with 3D volume data. And so we have to keep this in mind. And, there's no shortage of algorithms as we explore. We just wanted to develop another strategy and maybe design another algorithm that uses a different principle. As I mentioned, all existing methods will have some form of layer segmentation. We've tried to summarize these in two main approaches. In the first approach, you go through each B scan and segment the hypertransmission. This is what the second image is showing. The red line is where you can see hypertransmission. Once the 1D segmentation is completed, you combine these to form a 2D result. As you can see in the output, this generates a few defects because we're going from 3D data to 2D data to 1D data and then back to 2D. So groups like Retinal AI use this approach or some form of this. In the second approach, you segment the actual volume so it focuses on a specific area. This means you trim the volume to exclude things like the vitreous. In the figure here, the red segmentation in the volume is focusing specifically on the choroid to track hypertransmission. You then take this new volume and you collapse it to form the 2D on-FOS image. Now, this method does make sense. If you trim the volume, you focus on an area of interest, but when we do any form in segmentation, it does add another step in the process. And anytime you add an additional step, there is an opportunity for error to be introduced. So our thought was to create a single step approach to minimize error. Another thing to just mention is there can be other approaches that use a hybrid of these methods, but from what we've seen, all groups use some form of layer segmentation. So we wondered if there was a way to kind of make a different method. So this figure is showing our approach. We created an architecture that allows you to generate a GA segmentation output in one step, thereby reducing the places where error can be introduced. We use the quote-unquote raw 3D volume without any segmentation to keep this data as close to its native state as possible. Our study was part of a multi-center study between VRMTO and RCTX, but this specific data set is from RCTX. As mentioned, the input was 3D OCT data, and the output was 2D GA segmentation. One thing to note is that in our patient pool, all eyes only had GA. There was no neovascularization in the eyes used in this study. And this was purposely done to train the algorithm on GA only first before moving on to include other pathologies. We looked at 160 subject eyes, and the table shows a high-level summary. The dissimilarity coefficient, or DSC, gauged the accuracy. This table shows the type of segmentation in the first column and the DSC average in the second, and whether the approach is different to 3D in the final column. The key here is that when comparing 2D without layer segmentation and 3D without layer segmentation, the 3D approach wins out. There was a statistical significant difference between these two approaches. The other key is that with optimal layer segmentation, you actually get similar results. So we're not saying that these approaches don't work, but the caveat here is that layer segmentation does need to be optimal. So that's why the asterisk is present, because this means you need an expert to go through the scans and manually review or correct them. And we wanted to create a method that doesn't rely on graders or reading centers to make the approach more clinic ready. And our reason for trying an algorithm without layer segmentation was based off of previous study data that we presented at URetina. And in that study, we found that susceptibility to layer segmentation does exist. We compared differences in outputs when you use specific layer segmentation, such as Brooks to choroid, and it showed us that when volume scans are used, the algorithm actually performs better. So this made us realize that automated layer segmentation without optimization can fail. And so that's why we didn't want to rely on that approach moving forward. These images show an example of a longitudinal analysis with this one-step approach. This is a case from a patient where we tracked 2 areas of GA from December 2022 to May 2023. The output GA segmentations are overlaid onto on-phos images first, and then onto IR images. And these show that the segmentation is accurately measuring the area of atrophy. This is better seen on top of the IR images. And we did also analyze if the addition of these IR images helped with the DSC, but it didn't add anything. And by not using IR images, you have the ability to use this method across more devices. So we left it out for this specific study. And so in conclusion, using 3D native data may offer a quicker and accurate solution to GA segmentation. IR images added no benefit in our approach, which allows you to use this method across more devices. And as we heard from Dr. Zhang as well, issues with layer segmentation could impact your output. So this method that doesn't use any segmentation could be beneficial moving forward. A limitation of our study was that the 160 subject eyes were GA-only cases, but this positive signal warrants further analysis. In the future, we're going to be using this approach in patients with GA and neovascularization to more accurately mimic a patient that you would see in your clinics.
Thank you so much, Simrat. That was great. And it sounds like you really are getting the OCT clinic ready with this automatic segmentation. And I look forward to the discussion.
Perfect. Thank you so much.
Thank you. Our next speaker is Dr. Javier Zarranz Ventura, who is from the Hospital Clinic Barcelona, University of Barcelona. And Dr. Zarranz Ventura will be speaking on clinic-ready OCT, bridging the gap in GA segmentation for precision management. Javier?
Thank you very much. Thanks, Jennifer. So, hello, everyone. I'm Javier Zarranz Ventura here from Barcelona. Let me see if I can have control from the slides. Yeah, so my topic is I'm going to be speaking about nascent GA. So there was a mistake in the title of the previous talk. But I'm going to be speaking on the idea of using AI to identify nascent GA in OCT scans. So these are my disclosures. Let me see. Okay. So why this is a hot topic? I mean, GA is a hot topic because it is no longer an orphan disease. I mean, we do have approved drugs. In the US, you've been using Syfovre and Izervay. In Europe, we don't have it yet, but we want to have it soon. And the main thing is that since we have a treatment, we need to identify those patients that are and that can be treated with these drugs. And in this particular field, we have a paradigm shift because the aim is not to improve the vision, it's to have a reduction of the progression of the GA lesions. Now, the place of these drugs in the armamentarium, it's kind of needs to be elucidated. There is a risk-benefit ratio that needs to be discussed with each individual patient, but it's an option that we didn't have in the past, and now we have, and we need to know how to deal with the patients with these treatments. The point is that AI can also help us in this field because so far what we could identify in the OCT scans, the outer retinal atrophy changes, the RPE atrophy, it's a qualitative assessment. So if these images can be evaluated by the expert physicians like us, but it's quite difficult to standardize this type of analysis. However, if we use this type of algorithms, we move from a qualitative evaluation to a quantitative evaluation. It's critical to have a good AI-based OCT segmentation, for example, to estimate the extent of the photoreceptor layer loss or the RPE layer atrophy loss. Since we can measure this, then we can monitor these patients and see which patients are progressing, which are stable. There are many companies working on this. These are some of the few commercial software that are available to do this assessment of OCT scans with quantifying these different status, but there is a clear link between the ability to measure accurately all these lesions and the treatments that we're going to be using in the short term. Why? Because since we can measure, we can monitor disease progression. This is one example of how these authors have done this to monitor the evolution of lesion in time. And if we can monitor this disease progression, we can also identify and predict areas where the lesion is going to grow in the next future. Similarly, we can measure the treatment effect. So since we can monitor the evolution of the lesions, since we have done an intervention, then we can estimate if the treatment is being effective or not. What is common in all these studies is that all these trainings have been done using scans from clinical trials. Here is the Philly, the previous one is the Chroma, the Spectre, and the Mahalo trials. We always need a big data set to be able to use our algorithms to identify these lesions. But the point is, how can we identify early GA? Because all these trials have been done in scans from patients with existing GA and are being monitored to assess the extension of these GA lesions. The point is, how can we identify these nascent GA cases? There are two ways of looking at this. First is to look at functional changes, like with microperimetry, to see if an area that doesn't have an anatomical defect yet is going to progress in the short term. Other authors have looked at flow with OCTA. Other authors have identified choriocapillaris flow voids that could predict this apparition of geographic atrophy in the short term. And the point is, we need to look at this specific type of patients. So patients with intermediate AMD that can progress to nascent GA, so very early GA. Where can we look at these patients? I mean, we may have to look for them in existing datasets, and probably the RS2 is one of the largest studies that has been done in the past to look at AMD patients to try to identify in these early stages which are going to progress to a greater extent. Here we have our recent systematic literature review and a meta-analysis that has identified that these 7 features are predictive of progression to GA, to atrophy. The next question is obvious, is can we use AI algorithms to predict these conversions based on these grounds? This same idea is what has been done so far as per May, June now, 2024. But every time we do predictions, we need to base these predictions in previously collected data. As I always tell my residents, it's like watching a movie. So if you have seen a movie, you know what's going to happen in the movie. So you can somehow predict what's going to happen at the beginning of the movie. With data, is the same. If we have a full data set of patients that have been monitored in time, then we can train algorithms to predict in the baseline images which are going to progress and who of them are not going to progress. This parallelism can be used also to our field. So this is what has been done by the RS2 investigators in the same dataset. They have used machine learning analysis predictors. They have published this paper with several decision trees that have incorporated all these clinical features to try to identify patients at risk of progression. And they have created like a model with OCT-derived features, age, gender, and systemic variables to identify those that are going to progress. In this same study, they also suggest that these features can be used as inclusion criteria for future trials to try to see which patients are going to progress. Again, we need prospective datasets. So we need to have data to be able to create AI models that can predict this progression in very early stages of the disease. This was the rationale for the Pinnacle trial. The Pinnacle trial is a multi-center international collaboration that has two parts. One, a retrospective study with the collection about 500,000 OCT scans from these centers. And the second part is a prospective study that is ongoing now and is trying to identify how these patients do down the line. This is the report 2 that is basically a systematic literature review of what has been evaluated in the past. You can see that they started from 5,000 studies and end up with 6. This is an example of how poor this area of research is still as per June 2024. And this is a very early report that they have published to identify this progression to both types of advanced AMD, macular neovascularization and macular atrophy. This same approach is what we are doing now in our study in the iScreen project. This is a European Union funded study that also is led by the Vienna group, but we are part of the consortium. We have 7 clinical centers across Europe, and we are going to be monitoring these patients at the very early beginning to see how they do down the line. And this is my last slide. So again, GA is not an orphan disease any longer. Now we have treatments and we need to know how to use them. We need to have objective evaluation of OCTs using AI. Then there are many softwares for this, so we need to evaluate them all and use the one that we think fits best our needs. And definitely we need other new data sets that can be trained to assess this early detection of GA lesions and this early prediction to do the best for our patients. Thank you very much for your attention, and I will be looking forward to the discussion time.
Thank you so much, Javier, for that wonderful overview on the predictive power of AI to predict nascent GA. And we look forward to hearing more from the iScreen study and to the discussion. Our next speaker is Dr. Robert Slater, who is the senior scientist in the Department of Ophthalmology and Visual Sciences at the University of Wisconsin-Madison of the AI Research Unit. And Dr. Slater will be speaking on geographic atrophy enlargement using manual, semi-automated, and deep learning approaches. Robert?
Thank you for that nice introduction, and it's a pleasure to be speaking to everyone this morning. Let me try and get my slides advanced. There we go. So first, I'd like to acknowledge all the people who helped me with this. We don't have any financial disclosures, but these are the co-authors who did a lot of the work with this. So I'd like to acknowledge their input here. So as you may have seen, geographic atrophy it's a advanced form of AMD, and it's important to look at the area and progression for our clinical trials as we develop new drugs and treatments. We need to understand how are these lesions growing. So the primary way we assess this is on FAF images, so fundus autofluorescence. So you'll see these black and white images. And so our research will focus on measuring the size of these lesions on these fundus autofluorescence images. So there are a couple of ways to measure it. I work in a reading center, so the primary way that graders do this is they put this in an imaging program, software, something like Photoshop, and they annotate, fill in. It's kind of like a very advanced fill in the blank or color inside the lines. And so it requires very intensive training. It's very time consuming. We focus a lot on intergrader agreement. There's a lot of details because we're looking at down at the pixel level, and is this included or not? So there's a lot of very subjective criteria, and it's very time consuming. One of the tools that's come out is Heidelberg Region Finder, and so that gives us some improved agreement, and it's generally much quicker. The other thing is it allows you to register your images. So those of you who may not be familiar, you're looking from one year to the next, the eye doesn't appear in the same position. So you have to have an algorithm that basically aligns the eye so that you can make sure that the size is, of the background is the same and you can accurately measure growth. Region Finder is a tool that uses kind of the screen intensity. So sometimes, because we're looking at black and white, it can't distinguish between the optic nerve or arteries and veins. And so sometimes you have to tell it, or you have to block it off, say, nope, you can't go here. And we'll see some of those blocks. So, and a third way that we've been working on at the WRC is artificial intelligence. And it is extremely fast. And the nice thing is we don't have to do blocks. It's not time consuming. The problem is it's AI. So unless we're trying to bring the implementations to make them more user friendly, but a lot of times you have to have programming skills and it's very specific. So we're trying to open that up, but those are kind of the barriers for the artificial intelligence. So, you know, what we're trying to do is we have these three methods. So how can we make sure that if we use different methods, do they actually agree? And the real bottom line is, what are the results so that we can treat the patient? I mean, it's great to have the AI and the different versions, but we really want to talk about what's happening to the patient. So what we did is we had a test trial. And so we had these fundus autofluorescence images. So they're from Heidelberg Spectrolysis. So we had a number of patients and we measured them both with the graders and our region finder. And then we took a model that we have previously published and we tried to validate all of this data and see what is the agreement between these three methods. And so we're looking not only at the area, but the growth rate longitudinally over time. So it's not enough to say, oh, we're measuring this. This is 5 microns, 5 millimeters squared. It's what is it year over year? And that's the important thing because it really is about treating growth or preventing the growth of these lesions. That's what causes the impact to the patient. So we do see here that the region finder on the left and Emmanuel, we have good agreement between our graders. And so this is our Bland-Altman plots. And you can see very, very close agreement. It looks like the region finder might be a little worse, but I'll just point to the scales on the left. You can see that the manual area is zoomed out a little bit, but we have very good. If you look at that correlation coefficient, it's basically 0.99 for both. So we get very good agreement for both. So when we start to look at the area, what we do is we treat region finder as sort of the gold standard. So there's two graphs here, but we're actually comparing three methods. We're comparing the AI to region finder, and we're comparing the manual to the region finder. And you may ask, well, what about manual versus AI? And we'll discuss that shortly. But you can see we've got a very nice trend. So it's a little bit hard to see, but there's a dotted line which represents kind of that perfect one-to-one agreement. And you can see there's a little bit of, I don't want to use the word bias, but there is a systematic error. But it is systematic, so we can correct for it. So we see that this area, we are accurately able to measure the areas and correct for any differences between the methods. So there's this nice systematic distribution. So we still have very good integrator correlations, and we see a nice trend between the various methods. So the important part is we look at year over year, the longitudinal area. And we can see, again, we see a little bit of a systematic error or a bias. Now you'll notice that the AI and the manual are very close together. And that's because the manual areas were the annotations used to train the AI. So the AI is going to mimic the manual very, very closely. You may say, well, manual and AI, there is, full disclosure, there is an inherent model bias there because that's what we use for training. But what we see is that the trend does not change over time. So even though there's this systematic difference between them, what's happening is this growth rate, and that's what's really important is it a fast grower? Is it a slow grower? It doesn't matter which method we use. So we can use all three of these methods and we are getting the same results. So this is a very, very positive development that even though there are some differences between the different methods, when it comes down to what we actually care about, that growth, we're finding a very, very good trend. And if you look at the progression rates, all three are showing the same across all methods. So we see that this growth works, and our ability to measure growth really doesn't depend on our method. So we can use Region Finder, our manual annotations, and importantly, with that increase in speed for AI, the AI is able to keep up with Region Finder, which is the gold standard, and we're able to look at those progression rates. So if you remember, it took an hour roughly in a bad day for a manual. It takes a couple minutes for Region Finder, and the AI is giving the same results, and we are on the order of seconds, so or even under a second. So that is very, very promising. So I'll just finish up here. Just real quick, we do see some differences. So the AI, one of the things is it does look at its intensity. Manual graders, they will fill in the whole thing. So you'll see some differences here. Region Finder displays the same characteristics as the AI. And then I kind of highlighted that there's the fill-in. And then one of the things is with large areas, we call it rounding. But one of the nice things is that both the AI and Region Finder are able to get into some of the details, whereas the manual, we get into this trying to fill, is this part of the pixel, is it not? And so the details of both AI and Region Finder work very, very well with large areas. Just trying to advance to my conclusions here. So, I've kind of highlighted all of this along. We got similar growth rates and consistent monitoring. So we've got, AI manual methods are working great. We're able to compare with our gold standard in Region Finder. And so that's what we'd like to highlight with this talk. So, Region Finder was our gold standard. We really think that AI is showing significant potential. And so now it's not so much we've got the measurement down, it's the implementation. How do we make this easier for the average clinician to use? How do we make it kind of essentially user-friendly? And so we can help with integrating these predictions. And we're not making clinical decisions yet, but what we're trying to do is speed up the process so that when a clinician looks at it, they can look at the report. Yes, this is good. No, it's not. So we want to make sure that the clinicians have support and we're not taking that decision out of their hands. So with that, I'll thank you for your attention and thank you very much.
Thank you so much, Robert, for this work that really increases our confidence in the use of AI in determining rates of growth of geographic atrophy. It'll be really useful in the future. It's my pleasure now to introduce our next speaker, Dr. Michael McConnell, who is Chief Health Officer at TOKU and also Clinical Professor of Medicine at Stanford. Dr. McConnell will speak on deep learning for hypertension risk prediction from retinal images. Michael?
Thanks, Dr. Lim. Thanks for the invitation to speak today. A little bit of a shift in topic. I'm a preventive cardiologist by background, and titles as mentioned there. And let's see, I'm getting slides to advance. There we go. Okay. So as mentioned, little lag on the slide movement. As mentioned, I work at TOKU as Chief Health Officer. I'm on the Health Tech Advisory Board for the American Heart Association, the Board of Directors for the National Fitness Foundation, and recently published a book, Fight Heart Disease Like Cancer, that actually includes some of the topics we're talking about today, or I'll present, though the proceeds for that go to charities. So we're going to shift and talk about hypertension, something that many of you appreciate from seeing through imaging the retina. But from a cardiovascular and sort of global health perspective, it's still a huge unmet clinical need. It's a #1 contributor to the global burden of disease. Over 1.3 billion people worldwide have high systolic blood pressure, and it accounts for about 20% of global deaths. Unfortunately, this situation has not improved much as we have awareness about the problem, and that it remains undetected and untreated in about 50% of adults, and only 21% of those with hypertension globally actually have it under control by guidelines. Importantly, the retina can play, and retinal imaging can play, a valuable role because evaluation of hypertension-mediated organ damage is recommended both for risk assessment and for guiding therapy. I've mentioned here ESC guidelines actually recommend a fundus exam looking for retinopathy. AHA guidelines more broadly recommend assessment for target organ damage. But this is where there's an opportunity, given that, unfortunately, many of us, while we learned how to do a fundus exam in medical school, if we're not still in the field of doing it regularly, this is not something we're very good at doing anymore. So the use of AI to sort of broaden access to this kinds of technology and information has a lot of opportunity. I was working at Google back in 2018 and helped contribute to this initial study where we used retinal imaging and AI and trained it against multiple cardiovascular risk factors. And as part of that, was also able to then demonstrate that putting these risk factors together could predict future cardiovascular risks similar to the existing risk score in the guidelines. I've tried to highlight, though the slides show up a little differently here than on my original screen, but as you can see in the, and I don't know if my arrow shows up, but in this image here, this was trained against systolic blood pressure. You can see the attention map highlights the vessels. So this was an example of being able to train against individual risk factors and then putting those together to a broader risk score. This has certainly been, a number of investigators have been able to demonstrate this as well. I highlight a paper here from Dr. Rim and colleagues in an even larger study that demonstrated retinal AI being able to predict not only systolic blood pressure, but a wide array of systemic biomarkers. So clearly this has been demonstrated as a strong opportunity of retinal AI. At Toku, we've expanded on this concept. And so you can see in the lower figure, as well as in the images, that we've trained AI models against multiple risk factors. Again, blood pressure highlighted here, but also against multiple retinal image features that are associated with risk, and put those together in an overall cardiovascular risk predictive model. And we got interested in this topic around the blood pressure part of it, but broadly, this CLAIR AI, our broader cardiovascular risk model, we recently published. This was developed and validated on over 100,000 images from 50,000 people across both UK Biobank, actually, and US, the IPEX 10K data set. And this we recently showed at ARVO in doing a pilot prospective study with Moorfields in UAE, that using this to detect whether an individual has an elevated 10-year, what we call ASCVD risk score, which is the acronym for atherosclerotic cardiovascular disease, so future heart attack, stroke, or cardiac death. So that had a sensitivity specificity of 89% and 87%. We've have CE and UK regulatory clearance for this, and we appreciate the FDA recognized this for FDA breakthrough device designation. So we're working in the US to bring this to patients. Going back to the hypertension question and systolic blood pressure, we were interested in looking at how does systolic blood pressure predicted from retinal AI correlate with future cardiovascular events. I won't go through too much of the details here, but again, this was from UK Biobank, large number of individuals and macular-centered retinal images, and then randomly split into a 70%, 15, and 15%. And then importantly, we not only looked at the correlation of the AI predicted systolic blood pressure against future events, but also cuff measured, so standard measurement of systolic blood pressure. And then the main findings were that the AI predicted systolic blood pressure actually correlated, that's in the orange, and you can see more monotonically keeps going up as you go from the lowest quartile of predicted systolic blood pressure to the highest quartile. And that correlation was stronger than actually the measured blood pressure, and that was significantly different. We did some subgroup analysis. The event rate was higher in men than women, fairly substantially. Men typically get cardiovascular and ASCVD events about a decade earlier than women. And so there was an even stronger difference between the AI predicted systolic blood pressure compared to the measured systolic blood pressure. And in the lower event rates among women, the correlation difference was not significant. Very interestingly, and more hypothesis generating at this point, there are only about 10% of the UK Biobank population indicated they were on hypertension meds, but they had a substantially higher event rate. And then you can see in the lower graph here, had a negative, fairly strongly negative correlation with future events. So having a low measured blood pressure in this group actually indicated higher event rates. And so it brings up very interesting questions on measured blood pressure versus using the retinal changes that the AI is detecting. And then one last other interesting aspect, and really highlighted the variability of our standard measurements of blood pressure, even in this rigorous UK Biobank study, when there were repeat measurements of systolic blood pressure, they were different quite substantially, over 8 millimeters of mercury. And this actually shifted almost 6% of the participants into an elevated ASCVD risk score if you use the initial systolic blood pressure measurement, which is typically what we do in clinic. So it raises interesting questions on the limitations of our current clinical methodology. So to conclude, so retinal AI predicted systolic blood pressure across this general population was better predicting future ASCVD events than cuff measured blood pressure. The study is limited by using a single data set with limited demographic diversity. So certainly further analyses of additional more diverse data sets are needed. And really given this global health imperative to improve the detection and treatment of hypertension and the variability and limitations of our current cuff measured systolic blood pressure, retinal AI really is a promising approach as a more reliable biomarker for hypertension risk prediction and management. Thank you very much.
Thank you so much, Michael. That was great, very interesting work, and look forward to the discussion and hopefully future implementation in clinics. It's my pleasure now to introduce our next speaker, Dr. Leila Vajlovic, who is an associate professor of ophthalmology with tenure and director of the Vitreoretinal Fellowship Program at Duke Eye Center. She will be speaking on improving pediatric retinal disease using AI screening tools constrained by limited data using synthetic generation of Optos photos. Leila?
Thank you, Jenny. It's a true pleasure to be here with all of you. And thank you for the opportunity to share my group's work. And we are diverting a little bit from the general topics of GA and others that have been discussed. So we're diving into pediatric retina world. These are my disclosures, not really relevant to this presentation. Our funding has been very much the support from Duke Department of Ophthalmology, as well as Vitreoretinal Surgical Foundation and in-kind equipment from Optos. I would like to thank all of those for their help and support in funding this project. So I'm going to first share with you a little bit of a data of our ongoing study. So really the idea of using ultraviolet field imaging, specifically Optos machine, to help diagnose conditions early in pediatric retinal world has been born really because we continue to have struggles with identifying diseases earlier, but also I think in this day and age where understaffing is very much prominent in every specialty, but I think pediatric world is in general, we struggle finding really physicians, nurses, and really staff to help us kind of take care of this patient. I think that will be a recurrent problem in the future. So why not use technology to help us diagnose things earlier? So we are piloting a prospective study where we are using wide field technology to image patients in really non-ophthalmology setting. This is a pediatrician office where a non-expert or non-trained staff are using these technologies to help us image periphery or posterior pole as well, and help us potentially diagnose retinal condition and maybe other conditions that we're finding out earlier. So this is just a little pilot study that will be presented by Dr. Xu at Retina Society, sharing that we very much can, with a non-trained staff, use fundus photography as a way to screen for conditions. The imaging is quite doable, it is comfortable to the patient, and the imaging session is fairly brief, and we're finding that 1 in 10 of patients can have referable pathology, not necessarily retina alone, but other conditions as well. And what are some of the things that we're seeing on the images? You'll notice that, first of all, and I'm having a little bit of issues advancing, so I may just say next slide, and thank you for helping me advance then. So ultraviolet fundus imaging results, you'll notice that we successfully can very much image posterior pole, but not only posterior pole. When we image periphery and ask the patients to look in different directions, we're very much getting successful images and finding even in these ultraviolet field images, we can get even further to the periphery very successfully. Next slide, please. So next, the question is, what are we exactly seeing? And I think this is skipping a little slide, so I'll go back. We are very much picking up retinal pathology that is found in these pediatric patients, but also very frequently myopic findings, which I think with this boom of myopia, one will very much understand that we will likely pick up these findings as well. So here are some of the examples of the current things that we see. So myopic fundus with peripapular changes, some pigmentary changes you'll see in a patient who has ROP history, and then non-specific peripheral changes as well. So this is overall summary of some of the changes that we have picked up on this prospective treatment or prospective imaging test. So now we are generating quite a few images. We are really creating a large database of images in normal and abnormal pathology patients. So you'll notice that in my last session or presentation last year at the summit, I was able to share with you some of the algorithms, artificial algorithms that we have used to really screen this data we're generating. And we found that RedFound was very much the most successful in helping us diagnose or pick up things prospectively in these images. But clearly 81% of AUROC is quite low still, and we have struggles in a real world setting in general in using algorithms to help us screen for conditions. So how can we potentially, even with this large database that we do have of images, how can we potentially augment this and create even a better artificial intelligence screening tool for us? So one of the solutions that we propose, and thankfully we have been able to generate and work on this prospectively now, we're proposing using GANs to generate synthetic optos images of diseased and normal pediatric patient eyes. You'll notice this is an example of a pilot study that we have recently run, where we're using healthy and diseased optos images to generate synthetic healthy and diseased images as well. And the pipeline for normal kind of screening or creating out AI type of algorithm is listed here, which I think all of us are very well familiar with. And this is really a pipeline for synthetic images being augmented and really included in the pipeline. The GAN really allows us now to not only use the normal, but these synthetically generated images to augment our pipeline and create potentially even better results. So here are the results in this initial early pilot study. You'll notice I shared with you previously some of the common models and how they performed with our data. RetFound was the best kind of performing out of all of them. But now when we augment with GAN, you'll notice that really AORC curve much improved to 93% with DenseNet and 88% with RetFound. So we are quite encouraged by this, because clearly this may help us augment the current data we have and help us understand and really create a better algorithm to continue to screen patients and identify pathology. So we believe by really the thresholding of this model will potentially have even a better performance in the future. So what are the conclusions from this really pilot study? We know that GAN can generate synthetic ultraviolet field optos images, as we shared with you, and clearly can improve our performance as a screening tool for pediatric retinal diseases. We hope to obviously to further analyze this and train further this data set and hopefully improve even better performance in the future. As some of these future directions, what we hope to accomplish is really do some more k-fold cross-validation, bootstrapping, as well as really understanding how this GAN augmented can improve our classification. Clearly, adding to the data set will help in normal and synthetic images, and we hope to do that in the future. With anything, it takes really a village to accomplish some of these goals. So I would very much like to thank my entire team who has fiercely been taking care of these pediatric patients, imaging them as well in general and pediatric retinal clinic, but also Daniel Wang, one of our stellar medical students who is applying for ophthalmology this year, who has really helped generate these GAN in images and help us really further improve our algorithms to screen prospectively. Thank you so much for your time.
Thank you so much, Leila, for bringing this futuristic development to pediatric retina and bringing AI into the field. Look forward to the discussion.
Thank you.
Thank you. I will next present the next talk on the collaborative communities on ocular imaging in regards to the age-related macular degeneration, CCOI. I'm Jennifer Lim from the University of Illinois, and these are my financial disclosures, none of which are relevant for this talk. The CCI AMD group was created in 2020 and is led by Dr. Emily Chu. And our group has come together with virtual meetings to delineate a roadmap for the development of AMD AI systems. And we published this report shown here with the first author being Elliot Dow. And the idea was to put together what is the current data for AI and AMD, what are the currently available standards out there, what has been achieved with AI for AMD, and what are the challenges to developing a screening AI system? And so when the group met, we looked at all the applications of AI for age-related macular degeneration and looked at all the papers which involve screening, diagnosis, prediction, and monitoring. And we felt that the greatest unmet need to apply AI to, for the time being, was to screen for age-related macular degeneration. We know because of the shortage of eye care specialists that it's estimated that about 25% of AMD actually goes undiagnosed in the United States. So a screening system would be useful. In order to have such a screening system, Obviously, this requires clinical standards or ground truths for comparison and validation of the system. It would also require multiple diverse data sets for training and for testing. And we reviewed the current data sets that are in existence, including the AREDS data sets and others, and found that these data sets are limited in terms of the collection of the patients. They don't necessarily have paired OCT data, and there are multiple hardwares that have been used and really non-standardization of the images. So a required data set diverse needs to be developed. In addition, benchmarking obviously is required to facilitate regulatory authorization and for subsequent clinical generalization. So we talked about these current data sets being limited in diversity and scope. In addition, they also lack the metadata. They don't have the clinical information tagged to the images. And then the images have various resolutions and inconsistent labeling. And again, no uniform imaging standard. So in addition to needing to create a quality large data set, obviously we need a way to securely collate this and to keep the information secure. And we thus need more infrastructure and an ability to share the data securely. In terms of the challenges for implementing an AI model for AMD screening, we realized that the cost of a clinical error is high. That is, if the system failed to detect neovascular AMD, that could have really significant consequences and result in blindness, obviously. So these systems will need to have very high sensitivity, and we would need to sacrifice perhaps specificity so that we don't miss early neovascular AMD. We also realized that we need to distinguish AMD disease mimics. For instance, some of the macular dystrophies can result in atrophy that can mimic geographic atrophy in late disease states. We would also want the system, obviously, to be autonomous to render a diagnosis and a recommendation for referral or follow-up for non-retina providers. The FDA then looked at our report and came up with these questions that the CCOI then addressed at this year's ARVO. The first question, what is the target population to screen? The second question, what imaging modality or modality should be used? Then, which AMD scale should be used as a reference standard? What data set needs to be developed to deploy such an AI system? And importantly, what is referable age-related macular degeneration? So at ARVO, our group met and said, well, the target population to screen for AMD are those over the age of 55 years. And we don't necessarily need to ask about family history or genetics, and perhaps the NHANES dataset can help inform some of the criteria that we'll use to select the population. We looked at the question of what is an ideal dataset. An ideal data set to catalyze the development of AI for AMD would obviously be one with millions of images from ideally 1 million or more patients with multiple follow-up points with greater than or equal to 1 year of follow-up. We'd want to have images from the right and left eyes of the same patients and keep this information paired. We'd obviously want images from a diverse patient population with regards to geography, with regards to demographics, and also with regards to practice settings. The ideal data set would obviously have a very well-labeled, validated process, and for obtaining these, and standard definitions would have been used for the labeling of the images. The metadata would be attached, that is, the demographics of the patient, the clinical data, visual acuity and outcomes, and device specifics that were taken or used for taking the images would also need to be attached. The data set should be freely accessible and transparent to those using it, so they would know what the inclusion and exclusion criteria were, and the patients who are in the data set should be informed that their information is in such a data set and should be able to opt out. We then tackled the question of what is referable AMD for screening. And it was decided that referable AMD for screening, I'm not sure where the slides are going forward there. Please go back one. Referable AMD for screening would be that of late age-related macular degeneration or intermediate age-related macular degeneration. And the group is using the Delphi process to further refine these definitions. And in terms of the screening output, we decided that we need at least 3 levels. So patients who have CNV detected would need an immediate referral. Patients who have intermediate AMD would need a referral, but not immediately. And then there would be those who have early drusen who are not referral, but need to be follow-up. And obviously, we discussed the performance goals would need to be high for the detection of CNV. Currently, there's also an AMD benchmark study going on. This is a multi-center study that is being done worldwide to look and establish clinical metadata and images attached to those to validate these AMD screening algorithms. And this will include patients who are healthy, as well as patients who have age-related macular degeneration. And currently, it's planned to have approximately 1,000 patients. And these patients will be gleaned 80% from the population at risk, that is over the age of 55, and then 20% from that population at risk would be enriched with regards to AMD. And within that AMD enriched set, we would have a balanced number of early AMD, intermediate AMD, and late age-related macular degeneration. And the University of Wisconsin-Madison would help curate these images. They would collect these curated, annotated, labeled, metadata-informed images and deposit them securely into a repository. And from this, then AI models would then be able to use this system to test their algorithms and derive sensitivity, specificity, and accuracy metrics for these. And the CCOI is planning on participating in helping create this data set as well. And hopefully by April of 2026, this will be able to have been tested using these AI algorithms, and we'll have some data available. So in summary, the CCI AMD group has addressed several questions of import in the terms of development of an AI screening algorithm with the results shown here. And currently, as I said, we're working on a Delphi process for the development of what exactly do we mean by referable AMD. And then the benchmark data set for AMD is ongoing. Thanks for your attention. So I'd like now to have all of the speakers join for the panel discussion. And we'll go ahead and start the discussion first with the question to Dr. Edelman with regards to the digital health policy for FDA guidelines. So Malvina, that was really wonderful that you're working with all of the places throughout the globe. And a question is, how are you trying to weigh the development of these AI systems for countries that are low to middle income, say, countries, as opposed to the United States, in terms of getting these standards out there and working with the different regulatory organizations?
Thank you very much, Jenny, and thank you for a lovely presentation of the AMD working group at ARVO. It was very well done. So as I tried to summarize, we have been working mostly on SAMD via IMDRF, the International Medical Device Regulatory Forum, and that's the body that has focused on advancing regulatory consensus. As you remember, I presented a slide of the regulatory bodies that are currently part of IMDRF. Unfortunately, it doesn't include every nation around the globe, but who the World Health Organization is at the table. So while not every country is capable of participating, it obviously requires a lot of resources to participate in these meetings and dedicate time to do so. When we develop consensus standards, we try to make sure that we address health equity as a priority in our consensus statements. And then we hope that what we come up with as a consensus statements can help expedite a safe AI around the globe, irrespective of whether that country, usually a smaller country, had or didn't have the capacity to be at the table.
Great. Thank you so much. Exciting to see how this will all play out in the future. Simrat, a question for you. When do you think this system will be available, or will it? Are you working with companies? And how does it compare with the 3D analysis that Dr. Sada presented this morning?
Yeah, so sorry, I'm going to turn my video off so it doesn't lag. But I think the acknowledgement slide of my presentation was missed, but that was one of the points that I wanted to bring up was that Jonathan Oakley from Voxeleron and Voxeleron as a whole has been really the key partners in all of these studies. So big thank you to them. And our study was, VRMTO and RCTX. So Drs. Netin Chowdhury and Drs. Wyckoff were the main ones that are in charge of this. We are hoping, like we said, this study was only done in GA first. So we're hoping to then focus a little bit more on neovascularization. So looking to see if the algorithm, is being confused or how it's kind of performing when you have a patient that is maybe more realistic to what's being seen in clinics. So I think there is a little bit of work there, but in speaking to Jonathan, I think this algorithm and other ones developed like Orion for segmentation are available. So I would say reach out to Voxeleron if there's any interest in using any of these. Also, feel free to reach out to us if you want to be a part of, the multi-center study. But I do think there are a couple more things we need to do to make it more kind of corporately available. I will say with Dr. Setta's study, I would have to talk to him a little bit more and also talk to Jonathan a little bit more, who is our technical guru, to see kind of how the differences are. But I do think that a lot more people are realizing that 3D volume scans are the way kind of forward. Even Dr. Zhang mentioned that there are issues with layer segmentation. And so you have to be really careful with how the layers are being segmented. So I think we are appreciating that there is maybe a little bit more work to do to make sure either that the segmentation is optimal or that we're using kind of inputs that are a little bit more raw and not more error prone. So I think it's all the groups that are kind of working on this are kind of forming into that same opinion. And that's also another good aspect of it, because it just shows you're probably on the right track if multiple groups are coming to the same conclusion. So I'll have to bug Dr. Setta a little bit more, and we'll have to also get Jonathan to answer that too, for anybody that's interested.
Absolutely. Well, good luck on working on that. And I think we
Perfect.
all agree 3D is the way to go.
Yeah, thank you so much.
Thank you. Javier, you were talking about using AI to detect nascent GA, and you were talking about photoreceptor detection. Do you know exactly what is it exactly looking at when you look at the saliency maps? Is it looking at the photoreceptors, looking at the RPE? Is it looking at all of the above? It's defined by the camper.
It depends on the approach that you take. If you are quantifying the layer, is what Simrat was mentioning now, the problems are linked to segmentation. So all the algorithms that we have so far for segmentation make mistakes, and it makes perfect sense. And here we don't have any atrophy yet. So the point is, I particularly like your presentation on COI. I think we need this type of initiatives to have prospective data sets that can be used in the future to train algorithms at baseline to try to identify things that we cannot see at the moment, to show where the lesion is going to grow, when the lesion is going to appear. Since we have these treatments for GA, we may need to work even more in imaging to try to identify suitable patients for treatment.
Yeah, it'll be very interesting to inform future studies, just like you showed with all these treatments for GA coming out there. If we can pinpoint it before we can actually see it at the very earliest point.
I think I told you, I really like the COI initiative with the Pinnacle trial in the past. Is pretty similar. The one we are doing with the AI Screen project is all the same, to have a good data set to be able to train algorithms in future when we have all the changes down the line.
Great, thank you. Robert, you presented a very intriguing study that showed that manual segmentation and then RetMarker and then the AI really give you the same information in terms of the growth rates out there. What's the difference in the cost? How much are we going to be saving when we do this, aside from the cost and time, but financial costs?
Sure. One of the things is that AI, once you train the algorithm, you don't need, we've talked about the hardware costs. We in our clinic, we will typically run that on a laptop. And that was Dr. Damapalli's talk. So that is one of the nice things about the AI algorithm, is that it can run locally and on what we would call kind of consumer hardware. The other thing is, because you can develop it yourself, you can get away from some of the proprietary. Whenever you have software, there's always a fee associated with that. And of course, with the manual grading, there's that human cost. It's just, if you look at the labor, it's very labor intensive. So I think in the long term for volume, AI is going to be much more cost effective. There are some startup, there's kind of that knowledge, but then once the algorithm's out there, it's essentially done and paid for, and the time is so quick. Like I said, it was under 5 seconds. You know, the ability to do volume and that immediate feedback, I think, is going to be very, very positive. So I think, you know, AI is also going to lower the cost and speed up the results. So I think that's going to be one of the big things. So there is a, despite, you know, we always see it in our large language models. Oh, you need so many thousand GPUs. A lot of these models will run in inference mode on your laptop, and we hope to eventually get it down to cell phone size. So that would be something that is very, very efficient, so that the inference is very, very cheap.
Are you envisioning it being open access then, the software?
Yes. And that's one of the things, one of the trends in AI that we see is that software tends to be more open access, you know, with the transfer learning and people sharing their models. A lot of these models, especially when you do transfer learning, you start from an original model and you kind of fine tune it yourself, but all those original models are available for download and review. And it also helps with the robustness that you can see when you're sharing these. You know, we have all these problems with, you know, does it apply in the clinic? Does it apply on the test set? By allowing these models to be sharing, it's just kind of the general trend. It makes them more robust because we see them on more and more problems.
Thank you. Dr. McConnell, that was really exciting work that you're presenting. I think a lot of us in ophthalmology went into retina because we always view the eye kind of as a window to the rest of what the body is doing. And indeed, your work shows that that is the case. Do you foresee that when you go into, say, your primary care office, you're going to get a retina picture, and that not only will detect whether or not you have diabetic retinopathy, but could also predict your stroke risk, et cetera, cardiac risk? How do you see this happening?
Sure. I mean, I think in many ways, right, ophthalmologists and optometrists have been seeing, you know, evidence in vessels and in the retina of the impact of risk factors, you know, for a long time, but that, you know, patients haven't typically had as broad access to that, and primary care hasn't had as broad access to that information. So I think a lot of our interest in where we think the field is going is very much that, you know, let's make every eye exam an opportunity to have more information around cardiovascular and other systemic disease health. So, you know, most of my academic career has been in imaging blood vessels, more in the heart and not in the retina. But that's where, you know, we often have the best evidence of where in you as an individual these risk factors are adding up. And, you know, as you can see from those, how we're not doing great on controlling blood pressure in many people. It's because it's a number. It doesn't, you know, it's not as meaningful either, I think, for the provider or for the patient, compared to saying, you know, we see the high blood pressure actually damaging your blood vessels. And so one of the hopes is not only to provide this information, but that would let, you know, more personalized and more impactful adherence to treatment and, you know, managing and adjusting treatment on that individual level, using that very personal information that comes from the back of your eye.
And are you looking to do longitudinal studies on these patients after you institute, say, the intervention, and then showing that, you know, further narrowing, say, doesn't occur, or using the AI to see how effective the medication is going forward? I don't know if it would be, but just curious.
Yeah, I mean, there's been interesting data around functional changes, you know, vasodilation kinds of changes with lowering cholesterol and other interventions in high-risk patients. But I think in a broader population, I think that's one of the goals as we can implement these AI tools and work with partners, is to form data sets, much as you've been doing, that over time we can then look for changes in how they relate to, you know, treatment. So yes, we're very much looking into doing some studies around how interventions can change or alter the course of retinal changes in at-risk patients.
Thank you. I feel like I need to get my retina image to know what my cardiac risk is or stroke risk is. So thanks for that work. Layla, along the same veins, you showed very intriguing work that in these children where you do the Optos images that you found a not insignificant proportion that have retinal findings.
Mhm.
Do you recommend maybe that these young kids, instead of getting an eye exam where, it's difficult to get a really good exam out of the periphery, that maybe you do a screening image?
Yeah.
How does that resonate with you?
Yeah. Thank you, Jenny. Now, thank you so much for asking that great question. I personally, and I think all of us in pediatric retinal world have seen a significant shift in us taking care of patients with the current technology and minimizing actually going to the operating room to do an exam anesthesia, because we have these ultra wide field images available that we can snap a photo in clinic and see what we are not seeing truly with a bright light shined while we're examining. So that's exactly why the idea was born is, gosh, we have amazing technology that's helping us examine kids in clinic. We use it routinely now in pediatric retinal world, and I'm sure every pediatric retina specialist will mention they are using this technology to help them examine and supplement their examination. But why not now use this technology to supplement general care of pediatric patients? We realize there's always limitation in cost and implementation of that, but we wanted to answer just a simple question like how could we place this technology in just general clinics? We are starting with pediatrician office, and how somebody who's not even trained in imaging can actually obtain these images with kids. I think we're all very familiar with smartphone technology, and we're all snapping beautiful photos because it's all automated, autofocusing. Well, all of these cameras these days are automated very much so. They're all autofocusing, and you can very much image, even if you don't have any experience, a pediatric patient. It's a moving target. So that's the initial pilot that we're excited to share our initial data at Retina Society coming up. But now we're challenging, what do we do with this data set, and how can we analyze it? How can we have even larger set? I think we have plenty of AMD patients that we're analyzing geographic atrophy, and these data sets are growing. But I think in pediatric retina world, we always struggle with having limited numbers of patients to really describe the conditions to the greatest detail or identify. So we are trying to come around or come with ideas how to supplement. And I think the synthetic data generation may be a solution to help us really equalize the field in terms of normal and pathology images. So we're excited about the work. It's very preliminary, but I think one that potentially could help us take care of pediatric patients in the future.
Great. Well, we look forward to that. Thank you all so much for your excellent presentations and for this discussion. I wish you continued good luck and success in your work in AI and look forward to the outcomes. Take care.
Thank you.
Thank you.
Thank you. All right, we will move on now to session 4, which is on retinovascular disease states. And our first speaker for session 4 is Dr. Paul Chan, who is my professor and head at the University of Illinois Department of Ophthalmology. And Dr. Chan serves as a John H. Panton Professor of Ophthalmology. He is also the Director of Pediatric Retina and ROP at University of Illinois at Chicago. And he'll be speaking on artificial intelligence and clinical practice, considerations for implementation. Paul?
Great, thanks, Jenny. And again, thanks for having me here. So I'm going to speak about something different than what I'm usually used to speaking about. Usually I speak about ROP and pediatric retina. I do want to mention my financial disclosures. I am a co-founder of a company called Salome Vision, which is a company that is focused on pediatric retina and implementation of artificial intelligence and screening programs for ROP, pediatric retina, and so forth. I just want to advance my slide. There we go. Okay. And want to acknowledge the group that I work with, which is the IROP consortium here, and also specific to this talk is the Institute for Healthcare Delivery Design, whom I work with at the University of Illinois. Great. So I think a lot of the talks this morning, we focused a lot on, okay, we're developing algorithms, We're looking at validating them, and then, and then what, right? And I think that Dr. Edelman, you mentioned that ophthalmology really was in the lead, back in the initial approvals of AI for diabetic retinopathy as an autonomous tool. So AI is here. But I think part of the question that I've been really grappling with, and I think at least in the US market, is okay, great. Now that we have AI and we've shown that it works for screening, how do we implement that into our systems? I like this. As I'm walking through the airport, I saw this Time magazine on artificial intelligence, and reading what Eric Topol mentioned. How do people feel about AI in general? And I love that it's the whole idea of bringing humanity back to medicine. And his commenting on, we can't get worse, we can only get better from these various technological advances. So in terms of clinical practice, and Dr. Aodol mentioned this already, when we think about these algorithms and what we do with them, I think it's very important that we also consider them as, to a certain extent, as therapeutics, right? And they have to go through similar approvals and make sure that they're safe and effective. And I love what's happening with the FDA in terms of software as a medical device, and really helping us in terms of how we look at getting artificial intelligence and these technologies through to commercialization. But what do we do when we actually have the algorithms? And this is a paper from the group out of Singapore. And I know Dan Ting, initially in the early talks, discussed data privacy and so forth. But the questions are, how do the physicians feel about using it? How do the patients feel about using AI? And the many considerations that Dr. Lim already mentioned as well. Are we using them in the target population? Are we using them on the right imaging devices? Do we have the right data sets and so forth? So there's a lot of considerations that we have to think about when we're implementing this technology. Just to share our personal experience at U of I, we've partnered with the Institute for Healthcare Delivery Design. So what this is trying to understand what is happening within our system. How do people feel about using AI for diabetic retinopathy screening? How do the patients feel about this? What are the pain points? What are the things that we have to do to get it implemented in our system? And of course, how do we make sure that our patients find this valuable and promote access to care? One of the interesting things that we found was that there was a little bit of not necessarily a disconnect, but there was some difference in how the ophthalmologist felt about AI implementation and its use, and how other specialties, specifically in our case, internal medicine and family practice, felt about the use of AI. One of the things that we had to make sure of is that people didn't see this as just a complete replacement of the eye exam. So that was something that was very important to understand, because I think initially our internal medicine and family practice colleagues thought that this would just replace the eye exam completely. Clinical workflows are really important. As we're implementing the technology, we all recognize that this can add more burden to our partners, right, to the physicians, to the MAs, to the technicians. So making sure that we get it right in terms of having the images taken, scheduling is appropriate, integrating this into Epic, into our EHR systems. So there are a lot of different things that we have to think about when implementing this in real-world clinical practice. And very importantly, making sure that the patients are engaged and that there's education. In terms of cost, that's another thing that we have to think about. Are we going to be budget neutral? Are we going to make money on this? Of course, there is a code 92229 that you can bill for, and that is being readdressed. And it's a different payer based on where you are in the region of the country. Here is some data. Sorry, this isn't showing up appropriately, but what I'm showing here is what we got paid for over the first month or so. And as we go through the course of the year, what we're showing is that what we get paid for doesn't necessarily support our costs. So one of the things that comes up is the HEDIS criteria, and it's been shown that the AI screening does support HEDIS criteria. And from an economic standpoint, looking at, at least what we've learned, and this was a nice paper by Mike Abramoff that came out recently, thinking about these AI tools, at least in diabetic retinopathy space, from more of a value-based care perspective. Very importantly, I think that if we think about the big picture, these tools are incredible tools for promoting health equity, improving access to care, especially in underserved communities. And the American Academy of Ophthalmology has been looking at different ways of implementing technology in our underserved communities around the country. Here's an example from Jeff Henderer out of the Temple University Health System. He's implemented the iNOOC system specifically to screen for patients with diabetic retinopathy and has been successful in this program. But of course, when we think about data and what we're doing, one of the things to consider is, okay, now we have these tools, how do we get real world data to support its use, right? And this is no different from therapeutics that come out to the market. Okay, we can show that they work in clinical trials, but as we move forward, how are we collecting real world data and coming together as a community to make sure that these are safe and effective? Education is also critical. So educating not just our patients, but our trainees, people straight out of training, new physicians to understand how to use these tools effectively. So in conclusion, I think AI is a tool, right? And it's been shown to be very effective in clinical practice so far, but there's still a lot of considerations that we have to think about. The financial model is still something to be discussed and refined. How we implement the systems is very important, and partnering with our primary care colleagues. Real world data is going to be very, very important going forward to understand its use and how effective it is in the real world. And I think very important that I didn't mention is advocacy as we look at payer models and making sure that we can make these sustainable as new technology comes out to the market. So thanks very much, Jenny. Thanks for having me, and look forward to discussion.
Thank you so much, Paul, for this very thoughtful discussion of considerations for AI implementation that go beyond the technical. I look forward to the discussion. Our next speaker, it's my pleasure to introduce Dr. Pierce Keane, who's Professor of Artificial Medical Intelligence at the Institute of Ophthalmology, also Faculty of Brain Science at the University College London. And he's also the Director of Insight, as well as an honorary staff member of the Moorfields Eye Hospital. Dr. Keane will be speaking on reinventing clinical trials with privacy-protecting AI. Pierce?
Thank you, Jenny, for the introduction. If anyone would like to get in touch with me, I've got my Twitter handle in the bottom right of the slide, and I'll also give my email address on the last slide of the presentation. And I'm just waiting for my slides to advance. Okay, so as Jenny said, I'm a consultant ophthalmologist at Moorfields Eye Hospital in London, where I'm a retinal specialist. And I'm a professor of artificial medical intelligence at University College London. And I'm funded by UK Research and Innovation. And these are my financial disclosures. In particular, during this talk, I'm going to talk about a collaboration that I have with a company called BitFound, and I do act as a consultant for that company. So where are we at the moment in terms of the widespread adoption of clinical AI systems? Well, with all the hype around these systems, you'd be forgiven for thinking that these are actually in widespread use. But in fact, we're still very much in the early days of adoption. And I would say probably 99 out of 100 ophthalmologists have never used any sort of medical AI system in routine care. And in fact, at the end of last year, there was a very nice article from James Zhou and others at Stanford, looking at the actual adoption of these medical AI systems through US insurance claims. So I thought I'd highlight a couple of things from the abstract for this slide, if it will advance in a moment. The first in this abstract that I want to highlight is that there are over 500 medical AI systems that are approved by the US Food and Drug Administration. And what they did in this study was they looked at a comprehensive database of about 11 billion CPT claims between 2018 and 2023. And of those 11 billion claims, there was only 2 of those claims that had more than 10,000 uses in the system. And the first was for coronary artery analysis, and the second was for diabetic retinopathy. And so it's great that an ophthalmic AI was the second most widely used of these systems. But on the other hand, it's clear that we're still in the very early stages of adoption. Now, I think that a lot of the challenges that we face are because of course, the need for clinical validation, the need for regulatory clearance, but also challenges around having the right business model and the implementation of these systems, as other speakers have talked about, and Paul in particular. And so I guess what I wanted to talk about was that I think that there are a lot of applications that are coming that could have huge value that may not require regulatory clearance. And I think one of those is around clinical trial recruitment. And can we aid in clinical trial recruitment prior to randomization in clinical trials? And we all know that this is a real issue. So in that regard, back in 2022, I established a collaboration with the startup Bitfound that I mentioned earlier, and we received a grant from the UK government from something called Innovate UK to begin to look at privacy protecting AI for clinical trial recruitment. Now, what do we mean by privacy protecting AI? Well, Bitfound are a company that specializes in something called federated learning, plus a range of other privacy protecting technologies. Now, Bitfound was founded by a guy called Blaise Thompson, and Blaise was previously the chief architect for Siri at Apple. And the nice thing from my perspective is that Bitfound are based just down the road from Moorfields in London. You can see me at the hiding at the back there of this photo. And the guy who's sitting on, who's sort of kneeling down at the front, that's Matt Siegel. And he was the head of federated learning at Apple. And so he developed the system for federated learning that Apple uses on millions of iPhones around the world to essentially train their algorithms on data from all these phones without having to centralize the data. Now, our idea in this grant was, could we send algorithms to clinics and run them behind the scenes on the databases within those clinics, in particular the imaging databases, to identify people that meet the inclusion-exclusion criteria for clinical trials without any data leaking, having to leave the sites and leaking to the algorithms, and without any intellectual property from the algorithms leaking in the other direction. So here's a typical algorithm. In this case, it's the algorithm that we developed between Moorfields and Google DeepMind, running on a patient with AMD, as we can see. And so the idea is that, could we run the algorithm? Could we segment the image? Could we then, on each image, give a kind of diagnosis, whether it's geographic atrophy or drusen or CNV? But could we run it in batch on a large number of patients and then shortlist patients for a clinical trial? And maybe that helps with pharmaceutical companies with protocol design. Maybe it helps with planning for site feasibility. Maybe it helps in particular with pre-screening for clinical trials. And then perhaps there's also applications for post-license identification. So imagine a new drug is licensed, becomes widely used. Maybe you could take some of these AI systems, you could run them on your imaging system, and it could identify people that might be suitable for the treatment. You can call them up ask them to come in, and then they're seen by the retinal specialist and assessed in the standard fashion. So what about something like geographic atrophy? I think a hot topic for the last year or two. And so to begin to look at this, we actually got a data set of about 100,000 eyes in an older population at Moorfields. And we ran the Moorfields DeepMind algorithm on those 100,000 images from those 100,000 eyes. And essentially, what we're able to look at, first of all, is that if we assume that there is no filtering, then we would potentially estimate about 2% of the patients in this older population might be eligible. But we do an electronic health record search, and in particular, a very kind of sophisticated search of the data warehouse using SQL. And we find that actually we can, just by looking for people that might have geographic atrophy in the electronic health record, plus a range of other parameters, we find that we can identify a lot more patients. But unfortunately, most of those patients are not necessarily eligible. However, when we combine running the AI algorithm plus the electronic health record search, we have a much higher rate of patients being eligible, and about 87% of the cases. So ultimately, from this approach, we identify over 600 patients that are suitable for recruitment into a trial of geographic atrophy. And we can do this, we could run this in one way, in one batch on all the trials, but we can find patients that are suitable for different trials with different criteria. So here's an example. On the top row here, we have a patient with where AI has segmented atrophy on OCT scans. On the bottom row, we have cases with fundus autofluorescence where humans have segmented the atrophy. And so on the left here, we can see here's a patient that is eligible for the Horizon trial, but not eligible for a range of other trials because the area of the atrophy is too low. And then here is a patient that's eligible for Derby and for Horizon, but because they have CNV in their fellow eye, they're not eligible for GATHER2 and the Janssen trial. And then lastly, we have a patient here which is eligible for all of the common trials, at least when we began to do this research. So just to finish up then, and I'm sorry for the slight delay on some of the slides, but if you want to learn a little bit more about this, we've published this work as a preprint. We've got a manuscript which is being revised, hopefully for publication soon. And lastly, if you'd like to get in touch with me, that's my email address. Thank you very much.
Thank you so much, Pierce, for sharing this novel work with us, and hopefully it will increase the clinical trials recruitment and speed it up. It's now my pleasure to introduce our next speaker, Dr. Elliot Dow. Dr. Dow is a retina specialist at the Retina Consultants Medical Group in Sacramento. And as you heard earlier, he was the first author on the AMD CCI paper that we discussed. He'll be speaking on multi-institutional validation of a deep learning algorithm for the prediction of hydroxychloroquine retinal toxicity. Elliot?
Thank you very much, Dr. Lim. I appreciate everyone tuning in today. This is going to be the first time that I'm presenting this data on a deep learning algorithm to predict hydroxychloroquine retinal toxicity. So apologies for any rough spots in the slides. Just going to advance here. Just to start this off, formatting is a little funny here, but I think we all know hydroxychloroquine, also known as Plaquenil, is an anti-inflammatory medication used for the treatment of autoimmune conditions. But a well-characterized side effect is about 7.5% of patients who use this medication end up having retinal toxicity involving loss of photoreceptors. Usually starts in the parafoveal area and expands outward in sort of ring-like distribution. That's often described as a bullseye retinopathy. Now, current guidelines recommend annual screening using OCT or visual field testing to detect this toxicity before there is advanced vision loss. But recent work has suggested that retinal changes can begin perhaps years in advance of the classic ellipsoid zone loss that we often look for when we're screening these patients in clinic. So one wonders if there's a better way, because of course a false negative screening error can result in a blind patient, but we're also sort of having an itchy trigger finger often when we see these patients. And we should remember that a false positive diagnostic error can also result in stopping an important medication for this patient's systemic health. So to that end, everything has gotten very small on these slides, but so I apologize for the formatting. But we basically wanted to develop a device to detect toxicity, ideally prior to the onset of ellipsoid zone loss. It should be simple and robust to different devices and imaging protocols, externally validated and fully automated. And so to that end, we developed a hydroxychloroquine classifier built as convolutional neural network, trained on OCTs from Bayer's Eye Institute, which uses Zyceris as a OCT device, as well as Duke Eye Center, which uses Heidelberg Spectralis, and then used withheld test set internally from Bayer's Eye Institute, and then external test sets from independent clinics in South Durham, Moorfields Eye Hospital in collaboration with Pierce Keane, as well as another UK hospital called Newcastle upon Tyne. And this classifier put out a likelihood value of toxicity. From there, the algorithm further truncated the OCT volume to B scans just from the central 1.5 millimeter area of the retina, macula, and it averaged the likelihood score across those B scans. And so these two steps helped to make this portable across different scanning protocols. Then we took a sort of naive threshold of anything, any average above 0.5 would be considered positive for that eye OCT volume. Anything below 0.5 would be negative. And the final step was kind of a binning step. If either or both eyes are positive in this patient, the patient is considered to be toxicity positive for that screening session. So the results in terms of the diagnostic performance are excellent with this algorithm. Diagnostic here means that the algorithm was able to identify toxicity correctly at the time of clinical diagnosis. Sensitivity for this was essentially perfect at 1. Specificity is 0.91, and this is at the patient level. And I'll just show you a few examples. So here we see classic parafoveal ellipsoid zone loss in a patient who's using hydroxychloroquine for 19 years to treat their lupus. And we see down here in the lower right corner, the p-value indicates that likelihood score very high. The model had no trouble recognizing this as a case of toxicity. And the 0 days here indicates that these images were obtained at the same time that the clinical diagnosis of toxicity was made for this patient. Here's another example without frank ellipsoid zone loss, but clear attenuation of the ellipsoid zone. And this right eye also has another macular comorbidity here, vitreomacular traction with foveal distortion. And this doesn't phase the model at all, which outputs very high likelihood score for toxicity in both of the eyes. There are more subtle cases of toxicity. So this patient, we can appreciate very slight interdigitation zone blurring, very subtle attenuation of the ellipsoid zone. But the diagnosis is mostly made on the basis of severely depressed multifocal ERG. And despite this very subtle presentation, the model recognizes clinical toxicity in both the right and left eyes. In terms of a few examples of true negatives, it could correctly screen this patient with macular drusen or extreme imaging artifact, both as being negative, patient with long-term hydroxychloroquine use. But a few errors that the algorithm did put out may shed some light on its inner workings. So one false positive example had an eye with large vitreous floaters that shadowed the retina in the parafovea distribution, actually in both eyes, sort of simulating the appearance of easy attenuation, and the model put out sort of a middling likelihood score, but just on the positive side of things. And again, this is a non-toxic patient called as having toxicity. Another example is a patient with age-related macular degeneration with a slight outer retinal irregularity due to these small drusen. Again, the algorithm put out very slight positive score for both of these eyes. And then a false negative, actually, in this case, was one eye, and this is showing the superior to inferior scans across a single OCT volume in this eye. And the superior scans show very nicely intact outer retina, superiorly and centrally in the scans. But as we get more inferior, we see focal ellipsoid zone loss. And the probability goes from essentially negative to positive. And when this was averaged, the average score came out to less than 0.5. So it was called as negative, even though this is a positive case of toxicity. But altogether, these false positive and false negative errors suggest the model is mostly attuned to changes in the outer retina, like we retina specialists are when we see these patients in clinic. So that does support the face validity of the algorithm. And another piece of supportive evidence is a very high correlation between right and likelihood values of right and left eyes. Again, hydroxychloroquine toxicity, as we know, is essentially a symmetric bilateral disease. But what we're really interested in is prediction of toxicity. And prediction here we're defining as about 1 to 18 months prior to clinical diagnosis of toxicity. On average, of these about 30 eyes are being assessed at 220 days prior to the clinical diagnosis. And when viewed at the patient level, again, the sensitivity is outstanding at 1, specificity is about 0.98. I'll show you a few examples here in the remaining time. And before doing so, I just want to also demonstrate that when we look about 5 years prior to clinical diagnosis and plot all of these eyes along those 5 years preceding the clinical diagnosis, the likelihood score steadily goes up in essentially all of the eyes, with toxicity predicted about 2 to 3.5 years on average in advance of the clinical diagnosis. Here's just one example where about 7 years prior to toxicity, the model correctly did not recognize any toxicity, but at about 3.5 years prior to the clinical diagnosis, we do start to see very slight interdigitation zone and ellipsoid zone blurring, and this progresses until about 1.5 years before the clinical diagnosis. We see very slight attenuation of the ellipsoid zone. This could almost be mistaken as peripapillary atrophy because, again, the diagnosis wasn't made for about 1.5 years, but the model caught it about 3.5 years out. Given the time, I'm just going to speed through these last few cases, which show prediction of very subtle early toxicity about 1.5 years before the clinical diagnosis. The prediction of rapid retinal thinning phenotype of hydroxychloroquine toxicity is described by Marmer and Mellis in their paper from a couple of years ago. And another important one about 2 or 3 year advanced identification of an East Asian patient with pericentral retinal toxicity, which wasn't caught until vision loss was pretty significant. So I'm just going to touch on, and obviously don't have time to go into the synthetic data work in this area. So we essentially reproduce the accuracy of this model using synthetic data here, showing one image of depicting hydroxychloroquine retinal toxicity generated with a denoising diffusion probabilistic model next to a real image. I actually forget which one is which, so maybe the viewer can figure that out. But in any case, this diagnostic model accurately predicts and diagnoses hydroxychloroquine toxicity across a variety of devices, protocols, and in US and international locations, and does so years in advance of the clinical diagnosis. It has essentially perfect sensitivity and high specificity, which makes it ideal for screening. Here are a few next steps, and I want to give a huge thanks to many, many people who have been involved in this effort for the multiple institutions. So thank you very much.
Thank you so much, Elliot. That was great. And it's exciting to see that the AI can actually predict the onset of Plaquenil, and look forward to the discussion. Our next speaker is Dr. Darvin Yi. Dr. Yi is the co-director of the Artificial Intelligence in Ophthalmology, or AIO Center at University of Illinois. He is also an assistant professor of ophthalmology and bioengineering, as well as the assistant director of the AI Health for All, or KIMA, at University of Illinois. And Dr. Yi will be speaking on towards solving the out-of-distribution problem in ophthalmology. Darvin?
Thank you. Hello, my name is Darvin, and today I have the pleasure of telling you a little bit about our work in identifying and addressing the out-of-distribution data problem. Okay, great. Here are all of my financial disclosures. And this is the agenda for my talk. First, we'll define out-of-distribution, or the OOD problem. We'll demonstrate what it looks like. Then we'll talk about detecting it and maybe approaching a solution to it. So let's begin by defining it. Today's summit has shown us many different models and data sets, all truly amazing for the field of ophthalmic AI. However, there's a key assumption we make when we build our algorithms. We're believing that the data in our training set will look similar to the data we'll feed our networks in the future. Here we show color fundus photographs from 3 different hospital systems, all differing in color, resolution, and ROI. These are shifts in the data distribution, and they can be caused by using different imaging devices, protocols, or even different patient populations. So that gives us the question, do these data distribution shifts matter? To test it out, we tested one of our in-house trained glaucoma detection models. You can't test for out-of-distribution effects if you only have one distribution of data. So we partitioned our data into 2 different data sets, our UIC data and a public data set, which was an amalgamation of 7 different public data sets. The total size and trained test split of the data sets were held constant. Our experimental setup has us train a network on each of our 2 data sets, but we'll test that network's performance on both test sets of both data sets. Essentially, we wanted to simulate training a network at one center and then handing it off to another. Here's our total results. There's a lot of numbers here, and we don't have too much time, so I just want to cut to the chase. When we test our performance on UIC data, we see that the network trained on the UIC data does better than the network trained on the out-of-distribution data. However, when we take a look at testing our network on the public data, we see again that the better performing network is a network that was trained on the public data rather than the UIC data. This is the out-of-distribution data effect that we are studying. Essentially, the fact that the models trained on the OOD data have a drop in performance when compared to networks trained on in-domain data. So, okay. Hopefully you can give me that OOD effects happen. But now we're curious, can these networks tell when a new image they get fed during inference is OOD or not? So you might think, luckily for us, these networks predict probability values, right? If a network sees an out-of-distribution sample, maybe it'll have a lower probability value. Well, to test this, we amassed many different out-of-distribution data sets, each one more out-of-distribution than the last. The first 4 rows here are 4 different public color fundus glaucoma data sets. The middle 4 rows are color fundus data sets, but not glaucoma related. And then the final 5 rows are just not even ophthalmic data sets. These are very out-of-distribution, mostly dogs and stuff like that. So we took our UIC trained network and we ran inference on all of the data from the previous slide. What you're seeing here are the histograms of the different probability values of the predicted class. In blue, we see the histogram of the UIC test data. Our network seems quite confident, as it should be. However, in orange, we see the histogram of predicted probabilities in each of the specific out-of-distribution data sets. And it seems just as confident for the most part. Even in the non-fundus images, which is the bottom row, we see an alarmingly high number of cases where our network outputs a meaningless prediction with greater than 80% associated probability. And this really isn't the behavior that we might want from our networks. To address this, we trained a new type of network that was shown distorted versions of the training images along with the clean original versions of the image, all during training time. We taught the network to hedge its predicted probabilities more when the images were the noisy version. This is just a method for making deep learning networks more comfortable with predicting the full range of probabilities rather than being overly sure of everything. And we can see this effect when we use our new network on the previously out of distribution data. Our network has learned to be more uncertain of its predictions the more our data is out of distribution. We can use this new behavior to now detect when a sample is OOD just by a network's behavior. Across every data set, we can detect out of distribution data better with our new network. And then we can use that information to self-censor, or as I like to call it, learning to shut up, a lesson I myself learned a little too late in life. Essentially, at the cost of not predicting 100% of our data, we can increase our accuracy on the samples we do indeed predict. An additional good sign here in this method is that for all of the non-ophthalmic images, we're correctly choosing to censor almost 100% of them. Also, one small little typo here for that UIC row at the top. For the final percent value on the self-censorship, that should be a 64%, not 18%. All right. Let me try to squeeze in one last hot off the presses result. Self-censorship is fine, but sorry, having trouble with the, yep. Self-censorship is fine, but it still doesn't make the network more correct. It just stops it from being very wrong. So this is where we attempted a technique called domain adaptation. Essentially, if during training we can get some unlabeled samples from other distributions, we can start to train our network to perform better on those distributions without needing to collect more labels. The way this works is that during training, we would give our network two tasks, in this case, glaucoma classification and also domain classification, essentially whether the input image comes from our UIC dataset or another dataset. For glaucoma classification, as everyone knows, we use gradient descent to learn what features most correlate with glaucoma. However, for domain classification, we'll use gradient ascent to unlearn features that are most correlated with distinguishing domains. Essentially, we're training our network to be blind to any feature that could help it distinguish between domains, which should remove any performance correlation with the domain as well. And here's our final table that shows that using this network, though not as good as training on the in-domain data in the first place, we can still help raise performance on the out-of-domain data. So that brings us to our conclusion. Overall, I hope folks who joined for this talk appreciate the importance of the out-of-distribution effect when it comes to trained models. From a clinical standpoint, I hope this motivates the need for more validation. If there's one message that I want to send, it's that maybe we shouldn't trust networks unless they were trained on either our data, validated on our data, or at least trained on so much data that we can believe that our data was represented in their training set. And with that, I want to thank everyone from the AIO Center and a very special thanks to our star graduate student, Homa Rashidi, who helped lead all of this great work for this project. And thank you for the opportunity to talk about this.
Great. Thank you so much, Darvin, for bringing this out of distribution network to our attention. It's really important. I'd like now to invite all of the speakers to the panel. And we'll start with our first speaker, Dr. Chan. Paul, you talked about considerations for implementation of AI. And in the real world, we've seen when ARDA was implemented in Thailand, say, and when in the Temple program, that there were images that weren't kind of up to snuff. They weren't able to be graded. And so there were many more images that were read as ungradable. How do you put that into the light of how we can implement the systems? What can we do to help decrease that issue?
Yeah, I think so. First off, I think we're still learning, and I think when you talk to Jeff and some other folks who've, had larger scale programs implemented, they still subscribe to the idea of, okay, you can take the image, but then you need some way to review the images, and which will then take resources, not just from the primary care physician, but also from our department in ophthalmology. We're facing the same types of issues here, which is we want to continue to make sure we quality check the images, that we know that there's nothing else going on, and make sure that the patients are safe, essentially, and that they're getting good care. And then there's all this other issues on the workflows. I mean, I'd love to hear Pierce Keen's experience with UHS and other countries, because I think that other countries and other systems seem to have gotten it, I guess, implemented in a more efficient way, or it's already happening. I think in the US, we are still learning and trying to figure out what the best way to do this is, especially also, as I mentioned, with considerations of the payer.
Right. Pierce, can you tell us how it's worked out in your area?
Well, I hate to disappoint, but I think I feel we're still learning as well, and we're not really using these systems widely. I think the people that we probably need to speak to are people like Karthik Srinivasan in Aravind, and the Aravind team have already got they've got it up and running. They've got it running at multiple sites around their hospital network. They've got these dashboards that Karthik will show these presentations of. And when I saw the presentation last year, they had run it in like 300,000 people. And they could see the adoption over time. And they could see, I think they were using the Google ARDA algorithm, but as part of that, they get quality metrics. And they get quality metrics from each of the sites within their system, so they can see that this site seems to be not as good at taking color frontal photographs as this site, et cetera, and then they can kind of react to that. So I feel like they're probably way ahead of people like us in this regard.
Yeah, I think, recognizing where the kinks are and then retraining to try to get rid of those issues, as has been published in some of the reports by other groups, is really important. Pierce, your presentation is really intriguing, that you could use AI to help sort out and sift out patients who may be eligible for clinical trials. So when you do that and you go into the record and then you find the record, how do you protect the PHI? How do you then identify that patient and let the investigator know?
Well, so I think I think a lot of the medical AI systems we're using so far involve sending the data to the cloud, and they often involve some kind of like price per click type situation, where I guess what we're proposing is you send the model directly to be hosted on the local server within the eye clinic. And also this is super important because we're interested in deploying AI in community and in like optometry practices and things like that. And they often have very variable IT infrastructure. They don't necessarily have high-speed connections, et cetera, et cetera. So if you can deploy the models on the edge, so no data has to leave, you don't need an internet connection, and then you can run sort of batch processing so that the algorithm will run on the database, like, for example, the Heidelberg imaging system or Top Gun or Zeiss or whatever imaging system. It runs overnight. It doesn't have to be super fast because it's not like a real-time kind of application, because maybe it's pre-screening or something like that. And then you can have additional technical sort of solutions to help with the privacy aspects. Like encrypted inference and things like that. And that can help address some of these problems.
Very interesting. Thank you. Elliot, you showed really interesting work in detecting plaquenil toxicity. And I think you kind of touch upon the question I'm going to ask, which is, in people who are of Asian ancestry, the toxicity is non-central, right? It's more of that pericentral. And I think that was one of the examples you showed where the model missed that. So how do you foresee, when you deploy this, working that? Are you going to increase the number of Asian patients to try to get these more atypical plaquenil types in?
Yeah, thanks a lot, Jennifer. And that's a good question. I just wanted to clarify. I know I was speeding through those slides pretty quickly, and the pericentral toxicity case in the East Asian patient was correctly detected. So by the model, it was unfortunately, I think, detected late by the clinician, but the model did identify toxicity about 3 years in advance of the clinician. And it can be a tough diagnosis to make. I think I saw this across most of the institutions where those patients who have ellipsoid zone loss outside of the parafovea are identified very late. I think Michael Marmer and some of his colleagues, delineated this different phenotype about a decade ago, and it does take a while for these kind of ideas to percolate out into the community, especially for rare diseases like hydroxychloroquine toxicity. So that's where I feel very heartened by the model being able to pick up these things. And I think the idea is what probably a lot of us see as the possibility of AI, despite all of these numerous implementation challenges that Dr. Chan and Dr. Keene and others in this conference have brought up. But the idea of being able to take some of the distilled knowledge that we've accumulated in our field as retina specialists, maybe a little bit of the wisdom that we haven't even managed to obtain, but the model does eke out, and then democratizing that, because this is the kind of thing that you could imagine certainly in an optometrist's office, or maybe someday at the CVS pharmacy. This can be implemented so that even the person behind the pharmacy counter can accurately pick up incipient toxicity in an East Asian patient.
Yeah, I think that prediction model is really, really strong. The fact that you can tell years ahead of time. And then I guess the question then comes in, do you stop it then? Or do you let it go another 6 months and see the progression, or what? And
yeah, so I've thought about this a little bit, and I just wanted to say, once again, Michael Marmer has been really foundational in this field, I think, as all of us know. And a couple of years ago, he showed that about half of patients who have retinal toxicity from hydroxychloroquine, about 4 to 6 years in advance, they start having sort of rapid retinal thinning phenotype. So this early prediction is sort of supported by previous work in the field. And what would happen if we saw this toxicity, years in advance, or the model said there was likely toxicity, but the ellipsoid zone looked totally intact? I think that's pretty simple. I would just have the patient come back in somewhere between 3 to 6 months for a rescreen, depending on how positive the model was. And then I would just very closely examine subtle signs like blurring in the interdigitation zone, very light ellipsoid zone attenuation or variegation, things like that, but well before frank ellipsoid zone loss and the resultant vision loss.
Great, thank you. Darwin, that was really an intriguing presentation on the out of distribution discussion for AI. How do you see federated learning as a way to perhaps overcome this issue?
I think federated. So I think for the out of distribution problem, there are a lot of these elegant solutions. Elegant in one way. Another way, I think it would be like sort of cutting the Gordian knot style. So if you have all the data, then you don't have anything that's out of distribution. And I think that's the federated learning kind of approach, and that's great. Another really cool, elegant approach is sort of the iNUC or digital diagnostics sort of aspect, where you control the hardware that it takes the image. So you can't control the patient population perhaps, but you can still cut out so many different factors that we know lead to out of distribution effects. However, I still think there's a good chunk of the problem that will remain, especially as we continue to develop new hardware, as we continue to innovate and bring new devices and update our systems. We'll always have the out of distribution effect. Every single time we could retrain our networks. It's the same problem. We can solve it with great infrastructure and collaboration. And I think that's where federated learning really sits and should be invested in further. But I think while clinicians and infrastructure people are turning their wheels, I think there's also room for algorithm folks to try to attempt to solve this problem as well, with more robust algorithms that could prepare better for more out of distribution data to happen.
Great. Well, we look forward to that happening with the algorithm improvements. I want to thank all of the speakers for your outstanding presentations and for sharing your knowledge with us during this talks and during the discussion. I wish you continued good luck in your work. And with that, we'll move on in the program. We're going to hear a message here from one of our sponsors, Apellis. Thank you so much for attending.
Hello, everyone. Welcome back. We're moving into our next session. I'm Theodore Lang at the Byers Eye Institute at Stanford, where I am a retinal specialist and also director of all of clinical and translational research, as well as a medical informatics director at the Stanford Healthcare for ambulatory specialties. We have a really exciting session coming up here, and I'd like to welcome to the stage first Mary Durbin, who is at Topcon Healthcare. And she'll be speaking about the curation of a real-world data set to support AI development. Mary?
Hi. So I'm Mary Durbin. I'm going to be speaking about curation of a real-world data set to support AI development. I'm trying to figure out how to use the slides. Okay, so I'll first talk about why real-world data is important, a little bit about the particular instrument that we are collecting data from, and then what I mean in this case by data curation, and then some next steps. So the value of real-world data, I think, is obvious to everyone. I found some really good quotes from this Khan et al. Paper. It's important for accelerating health data research, but to do that, we need meaningful data at sufficient scale, and real-world data is really the way that you can achieve that. A lot of times these data are inaccessible to researchers, even where there's an intention to make them available, so we want to work to help solve that problem. So the platform that we're concentrating on is our Maestro OCT, in part because there's like a great number of them out there. It's a device of choice for optometry practices, which means that we can really characterize normal eyes. The scan is automated. It takes about 2 minutes to scan both eyes. And most practices are using a standard scan, the 12:9 wide field OCT that covers both the optic disc and the macula, and then offers a 45-degree color fundus photograph as well. So this is this sort of standardization and common pattern allows us to pull together a lot of data from a lot of different places. But it's important to think about what we can do and what we can't do by aggregating this data. The data that's usually included when we take the OCT scan is people usually enter the age, they usually enter the gender. We get some ocular characteristics, obviously left to right. We can evaluate the images to figure out the fovea to disc distance, the angle of the fovea to disc, the disc size. There's also some interesting stuff in that how the device sets itself up, since it's robotic, to take the scan can give you some information that you may be able to use to estimate things like axial length, or at least to characterize whether the eye is long, short, or in between. But it's also important to know that there's certain data that's definitely not available. Most sites are not entering ethnicity. Most sites are neither measuring axial length nor entering it, and the same thing with things like corneal curvature, lens power, and thickness. So there's a lot that we have with the data, and there's a lot that we don't. So what I want to talk about next is the idea that we can then assign pseudo labels to this data that don't require human intervention to do these estimates. I already talked about using device characteristics to estimate the axial length. We recently saw this paper on retina pigment score, which is another way to characterize the fundus images. There's a number of tools out there that will help characterize the vessel information. We can use our own information to estimate the fovea to disc distance. We can perhaps estimate gender using some of the tools that people have talked about in the literature. There are tools such as Automorph and RetFound out there. What I like about them is that they're open source, so we can characterize our data this way and other people can characterize their data. The estimating of the axial length is something where we found that when we had this OCT data and we had a data set where the axial length was measured, we could observe a clear linear relationship between the mirror position that the device uses to set up the scan and the measured axial length. And we can apply it to independent data sets. The only tricky thing is that the offset, the linear relationship is always there. The offset may depend on the device, but that feels like a solvable problem long term. Another example of pseudo-label type things that you can apply is by finding the disc center and the vessel positions. You can perhaps characterize eyes according to how their vessels exit the disc. And we think this will be important for instance, setting up reference databases for large sets of eyes so that your own anatomy can match you to other people with similar anatomy. And this is an example of doing that, where you take a set of eyes that have sort of vessels exiting in a common direction. You take a different set of eyes, and if you construct a reference database that's specific to each eye's anatomy, you can actually improve the flagging in the reference data. Another potential use of pseudo labels is if you have something like, there was recently published from Fukai et al. A score that estimates the likelihood of having glaucoma. If you look at the outliers in scores like that, you can start to identify eyes that are in fact abnormal, and then you can make those available for greater review. So even though this data comes from a real world setting where the large majority of eyes are going to be absolutely normal, if you have a large enough data set, you can extract from that at the population prevalence data that can then be used for evaluating diseases. So the next steps on this is to continue to characterize these variations in and among the normal eyes. We really think there's going to be a good opportunity to identify rare normal variants in this large data set. We're going to be able to identify deviations from normality that may indicate prodromal disease. We also want to identify data paired with true labels so that we can validate some of the potential biomarkers that we identify. And then, of course, we're always looking for biomarkers that may be associated with traditional systemic health outcomes that could be targets for early intervention. So that's it. Thank you.
Thank you for that really interesting talk, Mary. Just as a reminder to everyone, please feel free to add any questions for the speakers in the Q&A, and we will address those when we get to our panel session. Up next is Aaron Lee from the University of Washington, who's going to be speaking about a very important topic, which is imaging standards. Aaron.
All right, thank you so much for this opportunity to give this talk. I care so much about imaging standards. I love the every opportunity to talk about it. I'm giving this talk sort of in the capacity of my AO position as chair of the steering committee for information technology. These are my financial disclosures. So just to give you a little bit of background, the AEO has been working very hard to promote imaging standards for a number of years. In fact, this editorial that's shown on the left, even though it was published a few years ago, there was a version of this where we were trying to promote imaging standards across the industry that was published in the 90s. unfortunately, between the first kind of version of this publication and when this editorial was released, there was not a lot of change that had occurred in the field in terms of adoption. The NEI and the AAO and a few other federal agencies kind of came together and had a workshop that really tried to promote this. And there were a number of further editorials that were released talking about imaging standards and trying to really promote the field. And this time, the call for standards really seems to be resonating with the community. There were sort of these two major recommendations that we put forward in terms of how to adopt imaging standards. One was really pushing and recommending that the vendors use machine-readable discrete data, so not numbers that are embedded in a PDF report or an image, talking about things like macular thickness or those kinds of data elements are not easily mineable, and so what we are recommending is that vendors try to use as much as possible discrete and machine readable data in standardized formats. The second is this idea that AI may discover new patterns hidden in the data. And it's very important that we don't lose a signal when we do compression of the imaging information. And so to kind of give you an example of this, this is an OCTV scan where on the bottom left, that's sort of a zoomed in uncompressed version of that image. In the bottom right is after JPEG compression, and you can see these sort of blocky artifacts that have occurred. And so some of the details of the sublayers of the retina would get obscured and potentially could lead to a future where we have all this data and then AI is unable to harness that information. So, the FDA actually did get involved with DICOM. And what was really neat is that in April of 2022, the FDA formally recognized DICOM as a standard for ocular imaging devices. And then manufacturers could attest and add DICOM standard compliance to the labels of their devices on the imaging instruments. And then the FDA also committed to having their staff attend and participate in the DICOM Working Group 9, which oversees ophthalmic imaging standards, so that they're part of the standards discussion and understand what the standards bodies are working towards. And then this is, in my opinion, sort of the linchpin of this involvement, in that the FDA is encouraging that the future AI models use DICOM compliant imaging as their input. And so this sort of creates both the carrot and the stick, in my opinion, of creating a very strong incentive for the community to adopt DICOM as their de facto standard for encoding medical imaging information in the field of ophthalmology. So I want to kind of also pivot here a little bit and talk about what we're doing in the Bridge to AI program. Our project is called AI Ready. And this is really the work of Nayun Kim in my lab, who's an MD PhD student. And one thing that she has spent a lot of time doing is trying to harmonize and bring together the DICOM adoption from these different devices. So one of the things that we're doing in our Bridge AI program is collecting tons and tons of data from all over from basically from head to toe in the participants that are coming through our protocol. But in the ophthalmic imaging section, we're not just getting like one color fundus photograph from one vendor. Actually, we have about 4 or 5 camera systems for each one of these modalities, so that we can try to overcome this device dependence in our field with AI models. But in order to bring that data together, you need to harmonize it. And so even though we have all these different protocols and these different devices in our study, we discovered that the implementation of the DICOM standard across these different vendors and devices are not always the same. And so to give you an idea of, all the different scans we're collecting, it's about 44 scans per participant. If you've never seen DICOM before, it's mainly different from something like a TIFF file or a PNG file in that it has this header information. And in the header, it has all the metadata attached to that image. So, when was the scan taken? Which eye is it from? Is it the macula or the optic disc? Which instrument was it imaged on? What is the registration of a B scan to a color from this image or an infrared reflectance image? So all that metadata is captured inside of that DICOM file. And so what Nayun has done is developed this compliance evaluator and a DICOM converter, so that we can understand how DICOM is being used across these different vendors. This is sort of an example report where we go through each one of the tags and look at the standard and see whether it was considered optional, whether it's required, and whether the correct kinds of values are being used in those fields. One of the challenges is that for certain standards, for example, OCTA, the standard is still being developed. And so we had to adopt sort of the draft, what we believe will be the final standard in this software tool. And then with FLIO, it's a relatively new imaging modality, so it doesn't have its own DICOM subclass, and so we've created one, and we're going to be working with Working Group 9 to try to make that an official standard. So what I'm sort of excited to share with you all is that we have actually released our pilot data. So there's lots and lots of B scans in about 204 participants from multiple different camera systems, as well as color fundus photos and two-dimensional imaging. All of this data is about 27,000 files of 311 gigabytes of data. And we have released this publicly, so you can actually go to our website, request access to it, and download it to your computers for AI analysis. And it is approximately 50 different groups have already downloaded it from our website. So this is our website with the QR code. Please go to it and try to access our data, and please let me know if you don't if you have trouble trying to get the data downloaded. I want to thank our industry partners that have worked very hard with us on this endeavor, and then the large team that is behind everything that we're doing. So thank you very much.
Wonderful, Aaron. Such an important resource that you have helped to curate for the community here. We're going to be shifting gears next into the world of ROP, and I'll invite Pete Campbell from OHSU to come up and give his talk on autonomous ROP screening. Pete?
Thanks, Ted, and thanks to the organizers for the opportunity to be here. These are my disclosures. The disclosure for Siloam Vision is relevant because we are in clinical trials to try and bring this technology to patients. Next slide. Just want to acknowledge my colleagues. I've really benefited from team science, working with a lot of really smart people, from Mike Chang to Jayashri Kalpathy-Kramer, who's really the brains behind the AI part of this algorithm. I'm sort of the clinical dummy trying to translate it into something useful. Want to start with sort of the status quo for ROP. There's a number of problems with clinical diagnosis for ROP. This is Yoshi Yonokawa, who's excellent, examining a baby at the bedside in the NICU. Most ROP exams use indirect ophthalmoscopy, scleral depression, and no imaging. This really hasn't kept up with modern medicine. This is the same way eyes have been examined since the invention of indirect ophthalmoscopy, and has not kept up with the standard of care for adult retinal practices. And so kids are really being left behind. ROP documentation is also descriptive, subjective, and varies from provider to provider. So it's very common for two physicians to look at the same baby and come to different answers. ROP examiners are also not equitably distributed around the country and around the world. There are significant care gaps, and I'll focus on the US for the moment, significant care gaps in the US in terms of where the babies are born and where the pediatric ophthalmologists, pediatric retina specialists live. Worldwide, the problem is much larger. This shows distribution of ophthalmologists per capita around the world. Image on the right is Coors Stadium. I borrowed this analogy from Army Harper, who's a retina specialist in Texas. This shows 50,000 people, and that's the number of babies that are going blind from ROP each year. The sad thing is that most of those cases are preventable. So I'm going to talk about technology that we've developed that may have an impact, not just in the US, but globally. So these are my colleagues, Jayshree Kalpathy-Kramer and James Brown, when they were at Harvard. We developed a plus disease classifier, trying to solve initially the problem of plus disease classification. But because of a number of different reasons, we turned this output into a continuous severity score. So that is a number from 1 to 9 that sort of reflects the overall level of vascular disease in the eye. And the concept is, as the level of peripheral disease increases, the level of dilation and tortuosity increases as well. So all this algorithm does is puts a number from 1 to 9 on the images in the back of the eye. It turns out that it's a really good surrogate for the overall level of disease. That is, the 1 to 9 output based on a single posterior pole photograph corresponds to the overall level of ROP in an eye, zone stage and extent of stage 3. And when you compare that to the actual categories of ROP, as shown on the left, it actually works as a good surrogate, which is the hypothesis that we're going to test here, which is, can we use that surrogate for a binary autonomous refer or not output, similar to what we're all used to in diabetic retinopathy? So that's the question we tested in this study. Specifically, how does a fully autonomous AI system perform in identifying more than mild and type 1 retinopathy prematurity? So again, we tuned an algorithm based on our current data to maximize sensitivity and specificity, and chose an output prior to looking at the eventual population-based test sets. We chose an algorithm point to balance sensitivity and specificity for more than mild ROP and ensure we don't miss any babies with treatment requiring or type 1 ROP. Here's the definition of more than mild and type 1. We developed a fully independent autonomous image pre-processing pipeline because in real-world data sets, as has been mentioned a lot of times today, the images aren't always standard. And so the algorithm identifies whether an image is appropriate for analysis. It then segments the image and then runs Monte Carlo ensembles to produce an image level and then an eye level output for a baby. As long as at least one image gets passed through the quality check, it outputs an exam, a refer or not label based on the cut point. If no images pass from either eye, the baby is referred. And we included all of these referrals in our sensitivity specificity calculations. These are the 2 test data sets we looked at. Thanks to Darius Mashfegi for sharing the Sundrop data set. This is about 9 years of data, 8 years of data, 1,545 consecutive infants, 6,205 consecutive exams from 11 different NICUs. And on the right, data from Aravind Eye Care System over 2 years, lots of babies, 2,699 infants, more than 5,000 exams. And that data set included both the RetCam and the Forus. So here are the results. I'll start with the Sundrop results. In the Sundrop US-based data set with the RetCam, you see we had 100% sensitivity for type 1 ROP and relatively high 82% sensitivity specificity for more than mild ROP. When you look at the confusion matrices, for less than more than mild and more than mild ROP in the 3 data sets, and I split the Aravind data set up into the 2 separate camera systems because that's relevant. We did not miss any babies with treatment requiring ROP in the US on the RetCam. We didn't miss any babies in the US or India on the RetCam. When you look at the exam level, there was 1 exam where the clinician decided to treat a baby, but screened negative. And so I'll show you that case. This was a baby that had screened positive in the 2 prior weeks, 35 weeks, 36 weeks. But at the 37-week exam, where you notice there's a little bit more peripheral disease shown, the clinician decided to treat that image at that day when they screened negative. And so this has implications for how we may recommend following babies once they screen positive, for example. And so the conclusion for this paper was, while we can't use this technology yet, it needs to go through regulatory approval, these results provide evidence that autonomous ROP screening may be effective in ROP telemedicine programs without substantial risk of missing severe ROP. One thing I didn't mention is that in both populations, if you were to implement this workflow, about 80% of exams could be read fully autonomously, significantly reducing the workload for the examining ophthalmologist, which, especially in other parts of the world, means that they can be doing other things which are a better use of their time than reading a bunch of images that show no or mild ROP. And so this is just one approach to using ROP, using AI to screen for ROP. I know Dr. Rao will be talking about another approach here in a little bit, and I think all of them may be useful for improving the diagnosis of ROP from being qualitative and subjective to quantitative and objective. I think all of them have potential impact for reducing the number of babies going blind from ROP. And I hope to bring this technology, and I hope others bring technology like this to the care of these babies in the US and around the world. Thank you so much.
Thank you so much for that amazing talk there. We're going to move on to Divya Rao from Remedio, who will be speaking also about ROP detection. Divya.
Hello, everyone. I'm Divya Rao. Thank you so much for joining us today. At the outset, would like to thank the organizers for giving me an opportunity to present our work. Dr. Campbell has really set the context for my talk as well, and I'll be discussing our work on evaluating an AI for ROP screening in India. Just waiting for the slides to move. Next slide, please. Okay. Here are my disclosures. I'm the Chief Medical Officer at Remedio, where this technology has been developed. I'd also like to thank our collaborators and my team, without which this would not have been possible, as well as acknowledge the assistance of BIRAC grant from the Government of India, who are funding this project. As we all know, and as Dr. Campbell has alluded, ROP is one of the leading causes of infant blindness worldwide, and globally there are over 15 million babies born prematurely who need multiple screening exams, and India having the highest burden of them. Compounding this problem is an acute shortage of ROP specialists, and additionally, each screening session is very demanding on these infants, causing significant alterations in their cardiac and respiratory status. So this motivated us to develop an AI-based screening solution, and where we envision a model where at NICUs, we have trained technicians and nurses capturing fundus images, and we have a hybrid AI tele-ROP model or an autonomous AI that can be used for screening and the referral being made to a specialist. So this has potential to not only improve accessibility, but also reduce the burden on ROP specialists by reducing the number of screening sessions required. So we developed a deep learning model using over 300,000 images over a 10-year period from the KidRock program, which is one of the largest tele-ROP programs in the world in South India. The solution uses a combination of models to provide both a screening as well as treatment triaging output. So when you have multiple input images that are fed to the AI, the initial step involves a pre-processing, and then you have assisted neural networks that sort of filter these images for appropriate fields of view as well as image quality. These are then in turn analyzed by the core engine, which has two models. One is an ROP detection model that uses temporal images to detect presence or absence of stage 1 to 3. And then you have the plus detection model that uses posterior pole images for presence, absence of plus disease. And the combination of these models is used to determine the level of urgency of referral. And so when you have a plus disease that is present, it's an urgent referral. And when you have no plus disease by any stage of ROP, then it's a semi-urgent referral, and the rest of them would require a follow-up as needed by the physician. So the idea was to use the least number of images without compromising on model accuracy and allow for efficient deployment. And lastly, we also use shallow architectures to enable offline deployment. So to test this model, we recruited So to test this model, we recruited 291 at-risk infants across 26 NICUs across 5 districts in state in southern India. And the babies were imaged using 3 wide field imaging systems, the NEO camera, the RECCAM 3, as well as the RECCAM shuttle. The operators capture 6 fields of view per eye. And then the reference standard that we used were 2 of them. One was field grading by the trained ROP graders with an ROP specialist confirming diagnosis for those required treatment. And the second was an adjudicated image grading, where we had 2 ROP graders give their consensus grading. And when there was a disagreement, we had an ROP specialist provide an adjudicated grading. All of this was obviously based on all fields of view. And this was compared against the combination of algorithms that we have. So these 291 at-risk infants led to 4,500 images being captured, and we had to exclude 30 infants where the AI protocol failed in terms of image quality or field of view. There was a good distribution of disease from across different stages, zones, as well as plus, with 22% of them having any kind of ROP. I'm sorry, it seems like the formatting has got messed up, but this was essentially when we looked at comparing the AI to field diagnosis, and we had a sensitivity of 96% and a specificity of 87%, with 2 cases being missed. One was stage 1 ROP and the other the stage 2 ROP. And this was comparing the AI against an adjudicated grading. And here we saw that no cases of ROP were missed with a specificity of 86%. What was also good to see was the agreement between the graders was good, as well as there was a good concordance between field grading as well as adjudicated grading. Now, we also looked at how the AI system did across different fundus camera systems. We obviously had the best representation across the newer camera being most portable, followed by the RECCAM shuttle and the RECCAM 3. And across all of these cameras, the sensitivity was really good, was near perfect 100%. And the specificity, of course, varied between 84 to 94%, depending on the camera. But we still thought this was acceptable given that you're actually trying to optimize the model in a screening model like ROP, you would want to aim for the highest sensitivity. So these are a few examples that are highlighted here. On the left are true positive cases across the camera systems. As you can see, the grad cams pointing to the areas of high probability. You can see how the image quality and as well as the color tint varies across camera systems. Then you have a false positive case where the grad cams are pointing to areas, to vascular changes which were non-existent. And the one on the right is a true negative case. So this is an example of a case with plus disease and AROP, the grad cams pointing to dilated and tortuous vessels and highlighting the areas correctly. And this is an example of a stage 2 zone 3 disease that, again, the AI picked correctly. And this was a case of no ROP where the classification by the AI was, again, correct. So the strengths are really real-world data with comparison against 2 reference standards, both clinical grading or field grading, as well as adjudicated image grading with 3 experts there, and we validated across multiple wide field systems. Of course, we did have challenges having equal distribution across camera systems given the portability of the devices. And what we're looking to do is explore camera-specific optimizations of the model, and as well as validate this in larger studies where we're looking at bringing this algorithm on a hybrid tele-ROP model and looking at how it does. And as for now, with the intended population is India, but Of course, moving forward, we're looking to bring in multi-ethnic data for use beyond the Indian population. So I think this shows that there is a path towards a device agnostic algorithm, and an AI for ROP can significantly improve early detection and management, democratizing screening and improve efficiency and access, and reduce the burden on ROP specialists. Thank you so much for your patient listening.
Thank you so much for your presentation there. Up next will be William Freeman from the University of San Diego Charlie Eye Institute, speaking about faricimab for highly resistant wet macular degeneration.
Well, good morning, everybody. Let me see if I can. It says I can't start my video. So, Clark, can you start my video? Okay, I'll go without my video. But okay, start my video. There we go. So we're going to switch topics a little bit to wet macular degeneration. I want to acknowledge my co-authors, particularly those in our engineering school. Dr. Tran Nguyen is in charge of the video AI group at the University of California, San Diego. Our motto is "Let there be light," and many of you are familiar with that motto. Faricimab has been released over the last year and a half, and it is a new way to treat age-related macular degeneration. Can we advance the slide? It's an interesting drug because it's bispecific and that it inhibits both Ang2 and anti-VEGF. Next slide. And we might expect that the drug would show different morphology changes or more rapid morphology changes in the abnormal subretinal neovascular network than those that occur with other anti-VEGF drugs. So what we did was we analyzed the therapeutic response and the OCT angiographic vessel morphology when we switched refractory, and this is important to emphasize, refractory patients who had been resistant to double-dose Eylea and switched them to faricimab. The idea was to see what would be the change in the vessels, and of course, what is the response in terms of retinal thickness. Next slide. So we looked at a series of 25 eyes. These were very, very poorly responsive to Eylea, including double-dose Eylea, and in some cases, the use of double-dose Eylea in combination with intravitreal steroids. They had persistent fluid before the faricimab was injected, and we had the usual outcomes. Next slide. So we looked at baseline and follow-up OCTs, but we used an artificial intelligence platform that was developed in Switzerland by a company called Retinal AI. And through this, there's automated retinal layer segmentation. And for the first times, we can accurately calculate the nanoliter volumes of subretinal fluid and intraretinal fluid, as well as using central retinal thickness measurements, which are the usual clinical trial outcomes in anti-VEGF clinical trials. Next slide. Here we see the internal segmentation algorithm of the Heidelberg machine, and it's very important to get the outer retinal boundary correctly because the neovascular membrane is between the RPE and Brooks membrane. And as we see in the panel on top, the Heidelberg internal algorithm falsely segments this, and so the OCT angiogram is not reliable. The Retina AI software correctly segments the algorithm, and in doing our work, we use the Heidelberg software, and then we manually correct it and use software to propagate that through all 512 images. Next slide. Yes, so here we see the clinical response of a patient, panels A, B, C, and D, have the patient with persistent subretinal fluid and a fairly large fibrovascular PED, despite being given monthly double-dose Eylea for several months. Starting with panel E, which is 1 month after the change to faricimab, and then panel F, which is 2 months after the change, you see a rather dramatic response. And we can measure central retinal thickness, but we can also look at fluid volumes with artificial intelligence. Next slide. So here we see another patient with a history of 13 consecutive monthly anti-VEGF treatments. Panel A and B show some shifting of the subretinal fluid, but the bottom panel, you see a reduction in fluid that's rather dramatic 1 month after the initial injection of faricimab. Next slide. So what we're able to do with the AI algorithm is we can segment all of the retinal layers accurately. And what you see is the PED volume in nanoliters goes down from 270 to 168 nanoliters. And the subretinal fluid disappears completely, going from 80 to 0. Nanoliters. And again, to do this, you really have to do an awful lot of segmentation. And the software we use, the AI software, seems to be very accurate in doing this, more accurate than the built-in algorithm in the Heidelberg, and probably more accurate than any of the built-in algorithms from any manufacturer. Next slide. Here's a case of a patient with resistant choroidal neovascularization. This is after numerous treatments with high-dose Eylea, double-dose Eylea. And then we can see that not only does the fluid reduce, but the PED begins to reduce even 1 month after the injection of faricimab. And again, you're seeing the volume of fluid either in the PED in this case, in all of the ETDRS standard zones. And obviously, you get much more dramatic statistical change when you look at the zone of greater involvement. And that's different than when you look at just central retinal thickness or central macular thickness, which also went down in this patient, but that's usually done with the standard Heidelberg software. Next slide. So our results show that there is a trend of some improvement of vision, but the amount of fluid volume goes down dramatically. And the AI algorithm that allows us to determine nanoliter volumes in all of the ETDRS zones seems to be a much more robust way to look at this than just the central retinal thickness. So my time is about up. We're going to just go to the next slide. And I'm going to just mention that here is the reduction of fluid using standard algorithms with the Heidelberg central retinal thickness. And that does show a reduction, but it's much more robust when we use artificial intelligence. We're also using AI now to characterize the choroidal neovascular membrane, and we're seeing some very interesting changes in that the AI can tell us which membranes are new membranes and which ones are persistent membranes but have a treatment response. And I'll conclude here. Thank you very much.
Really interesting results from this medication that's been out for about 2 years now here in the US. As a reminder, please enter any questions into the Q&A function on Zoom. And we're looking forward to our last talk of this session from Xincheng Chao at the University of Illinois, Chicago on melanoma detection.
Okay, thank you, Ted. Okay, so, the clinical, detection of the and choroidal nevus, can be important, for the clinical treatment. Currently, multiple immunomodality for the clinical assessment choroidal lesion. So that's because, both the lateral information and axial information, that the thickness of the choroidal lesion, can be important to differentiate the different choroid condition. Currently we can use the color-founded image, to map the morphological structure in the lateral direction. And if we want to, do the thickness measurement, we need to consider OCT and ultrasound. In principle, multiple spectral, founded image may also, carry some kind of depth resolved information. This is because, different light wavelengths, they, can reflect different penetration capability. For example, red light, near infrared light, they have the longer wavelengths compared to blue and green. So that means they can penetrate through the retina up to the choroidal layer better compared to short wavelength light. If we pay attention to the example image, this is, a color from the image, to reflect the choroid lesion in the central part. So we can see the location in the color-founded image. If we pay attention to the different, spectral image, that's mean different color, like the green color, red color, and red, a near infrared, image. We can observe different information. So that's why I said, the spectral information may reflect the depth resolved information in the retina and choroid. So this is a study, we want to test if we can use the color-founded image for deep learning classification of uveal melanoma and choroidal nevus. So the basic structure of the deep learning algorithm is a CNN network. So the input signal is the color-founded image, including RGB channel separately. And the image feature can be extracted by the deep learning algorithm, for following classification. So this is the basic information of the clinical data set we used, for this study. This clinical data set, is from UIC Ophthalmology. It was organized by Dr. Michael Hipperman. So we have, UV image, the number is 157, and the choroidal nevus image, the number is 281. If we pay attention to the bottom part of the, the table, we can also see, the subretinal fluid and the lipofuscin, marker can be frequently observed in but only occasionally, in choroidal nevus. This information, might be reflected in the color, found in the image, can be useful for deep learning classification. So we tested both the single color input, that means red, green, and blue channels separately for the deep learning training, and also we test multiple color fusion. For the early fusion, that means we combine, RGB channel directly, together first before the feature extraction. The intermediate fusion, that means the image feature, can be extracted from an individual color channel first. Then this, feature can combine together for the following, classification. For the later fusion, that means for both the feature extraction and classification, can be performed using individual color image first, then combine together at the decision level. That's why we call it later fusion. First, we test, a two-step classification strategy. That means, we try to differentiate the normal eye from the diseased eye first, and then, to separate, the diseased eye to either uveal melanoma or choroidal nevus. If we pay attention to the single color, deep learning, we can see if we compare RGB channel, we can see the red channel can produce the best, performance compared to green and blue channel. This is not a surprise because, as I mentioned, retinal light, has the longer wavelength compared to green and blue light. It may penetrate through the retina, to the choroidal layer better. That means red color may carry more information from the choroidal layer. For the color fusion options, if we pay attention to the accuracy, we can see intermediate fusion can provide, better performance to separate the from the NAVI. Yeah, we also, try to test the multiple classification, multi-class classification here. That means we try to use the deep learning algorithm, to separate the normal UM and correlated image, simultaneously. Again, for the single color input, the red channel show the best performance. And for the color fusion, the intermediate fusion show the best performance. But if we check the difference between the red, channel performance, intermediate fusion performance, so we can see the color fusion show, improve the performance compared to red channel only input. So that's mean, red channel can provide better performance compared to green and blue channel. However, green and blue channel may still carry some useful information, from the funded image. That's why, if we combine different color together, that can further improve deep learning performance, compared to single color input. Okay, in summary, deep learning of the color funded image, can be used for automated classification of UM and choroidal nevus. For the single color input, red channel provides the best performance because the red channel, can penetrate into the choroidal layer better. For the multiple color fusion, the intermediate fusion provides the best performance. So this is suggest if we consider, how to use the color information wisely, there are the different fusion option we need pay attention to, for the optimal performance. So currently, our study is based on the clinical color funded image available at OCT. But if we pay attention to the example image, the near infrared image may provide additional information, compared to the visible color image. So that's why currently, we are also working on multiple spectral imaging project, try to see if we combine color, funded image with near infrared funded image together, if we can further, increase the, classification or detection performance of the choroidal lesion. Okay, thank you for your attention.
Wonderful talk. If we could have all the panelists turn on their videos now so we can discuss the papers from this previous session. I'd like to first ask a question to, I don't see Mary here. Maybe Mary had to go. Oh, there you are. I think you've done a lot of really great work, with your 22,000 cameras out there to really generate a really nice normative data set. Have you guys thought of trying to validate this against potentially any clinical trial data that's out there, and maybe even leverage this into the use for control arms and for future regulatory endeavors?
I think that's a really great point, which is that it's great to have this real world data, but whatever you develop on it probably needs to be tested against either clinical trial data or prospectively collected data to be certain that the things that you find are going to be seen, even in a sort of validated sense, because you can validate against the data that you already have, but that ends up being a little bit circular. So you have to take it outside of itself to confirm how it works. So we do intend to test it against other data sets as well.
Thanks. I'd like to move over to the ROP folks, and maybe a question for Divya first. As someone that personally I've worked with a lot of algorithms that are FDA cleared for diabetes detection, and one of the key ingredients into that workflow is a quality module where the images are first analyzed to see if they're gradable or not gradable. And to someone who's done a little bit of ROP work myself, but not a lot, it often seems that these images are a little blurry to the naked eye. What kind of steps have you done in your program to do that initial screen to see if the images are gradable, and then what percent of images do you think will be thrown out due to just the difficulty with imaging these infants?
Great question, Dr. Lang. I think specifically to address that problem, because we know that images in ROP are challenging to get. And in fact, not just different cameras with varying image quality, but even different fields of view having varying image quality. Like, for example, posterior pole is always much easier to image, but the nasal retina is much harder to image. So the quality varies. So for that reason, we actually developed a specific quality model that is inbuilt in our solution to be able to filter out those with a minimum image quality that is required for AI analysis. So essentially, if the filter is crossed, then the image would be analyzed. And we also sort of balance this with real world data, because you cannot keep throwing out a lot of images as being ungradable. So we have to balance this out. So we essentially looked at a grading paradigm where we had acceptable, possibly acceptable, and unacceptable during the grading phase. And then we clubbed possibly acceptable and acceptable into one group, so that we did not have a situation where a lot of the images were excluded. So I think that was one of the things that we ensured during model development, to bring in this filter to strike the right balance between excluding and including images for analysis.
Yeah, no, I think that's a really important topic, just to get adoption and just acceptance of these types of technologies, especially in this patient population. Pete, in your work, we have one of our colleagues, Darius Moshfeghi, has done a lot of work with universal screening and has shown the ability to find incidental findings in newborns that are not premature even. What's happening with those types of findings in the images that you guys are studying?
Yeah, that's a great question. And it's relevant if we're doing something like autonomous ROP screening, where there's not necessarily a physician in the loop. And so I think as a field, we need to think through how and when we're okay, first of all, with autonomous ROP screening from a medical legal perspective. But our proposed workflow would be that, to address exactly this issue, would be that the first exam in the baby's ROP screening be sent to the physician for review, just to make sure there's not something else going on. There could be fever, other retinal vascular disease, there could be retinoblastoma, there could be unexpectedly severe ROP. And so our recommended workflow is that the first exam, regardless of the device output, be reviewed manually, exactly to address that issue. And then if there's nothing else going on, it makes perfect sense to continue to screen most of the babies who don't have severe ROP autonomously. And so that's how we've tried to tackle that issue.
Thank you so much. Aaron, I really enjoyed your talk, and you've encapsulated the effort that's been going on for decades now for imaging standards. In one of your first slides there showing those editorials. In your mind, what do you think is the best way for increasing adoption of imaging standards over time through all the interested stakeholders?
Yeah, thanks, Ted. So that is a really good question, and often something that I spend a lot of time thinking about. Just to give you a little bit of perspective, I think when that first editorial was released by the AAO in the 90s, it wasn't clear that there was a great use case for having, or why it was so necessary to have imaging standards back then. If you could see the OCT or the color films photo on the device, that was already considered, a miracle, because we were going through this transition from film to digital photography. So there was not great. It was very forward-thinking work in a way when the people were developing those standards. I think what's happened in the last 10 years or so is that there's now a very clear use case. There's a really good reason why we want imaging standards. In fact, all the work that people are presenting at this summit, it would be a lot easier if everybody was using imaging standards. And so really, deep learning and AI are one of the primary drivers for imaging standards adoption, I think. And so to kind of push that forward even further, I think it's going to take different societies around the world coming together and saying that we really need this from the vendors, and putting, not just opinion papers, but saying that we won't buy this thing if it doesn't have imaging standards built into it. And so I think that kind of thinking and demand from the community will go a long way to increasing adoption even further.
Thank you. Dr. Freeman, I guess two questions for you. One from the audience is, how are you differentiating new CNV versus old membranes like, old fibrosis using your AI? And also, did you look at a comparison of the volume analysis with the nanoliters versus just doing a thickness analysis using central subfield thickness?
Yeah, so let's do the second question first. The nanoliter analysis, what you can't do with this software is pick the region of the macula that you want. You have to pick one or more of the ETDRS zones. So we chose the zone of maximum initial involvement, and then we looked what happened after the faricimab intervention. And we found that we had a higher percentage reduction of fluid focusing on the most involved area than looking at the central macular thickness, which kind of comes out of the standard Heidelberg software. That makes perfect sense. And it's kind of nice to be able to quantify it. And you can actually quantify the nanoliters of fluid in multiple different retinal layers. The second question is work that we're currently doing, and we're looking at three ways to look at choroidal neovascular membranes. We're looking at Heidelberg, primarily Heidelberg, but also OptiView data, where the algorithm gives you a 2D picture of the vessels, and we're having human readers look at that. We're then using some software it's called AngioTool from NIH to quantify branching, frequency, average retinal diameter, and the percent of the lesion that's vascular. And then we're looking at an AI algorithm developed by our AI collaborators, which was trained on Heidelberg, on a large set of Heidelberg data. The training was carefully clinically characterized vessels. So we have untreated vessels, partially treated vessels, completely treated in the sense that there's no fluid. And then we have AMD without vessels. And what we find is that the human graders do the worst, and that the AngioTool shows us a little more information, but at the moment, the AI is doing better. And we're doing this in a multi-centered way. And actually, what I've done is asked all my former fellows to contribute cases to this large database and do the AI training that way. But it's very important to have good clinical data. If the clinical data is not correct, you can train the AI as much as you want. You're not going to get the correct answers.
Thank you so much. Our last question today for this session will be for Dr. Yao. As we know, the risk of progression from a nevus to a melanoma is significantly affected by the thickness of the lesion itself. Have you looked at using color fundus photos to address the question of how thick a lesion is? Do you think deep learning can be used for that?
Yeah, that's a great question. For all the, clinical color funded image, I'm used for this study. So we also have corresponding, ultrasound and OCT image too. So currently we are working, with Dr. Michael Haferman, to quantify the thickness for each number, each image. So it's possible, to test the deep learning training based on ultrasound OCT, as a ground truth. Yeah.
Well, thank you so much to all the speakers for contributing to this session and to this program. Talks were all wonderful. We'll be moving on to our next session now. And so I'll ask the next cohort of speakers to enter the webinar. Our first talk here will be from Yannick Liederman, and it will be on the performance indicators in trainees for ophthalmic microsurgery using deep learning. Yannick.
Thank you, Ted, for the invitation and for the opportunity to give this talk. So my most pertinent disclosure is that I am a co-founder of Microsurgical Guidance Solutions, which holds intellectual property to some of the technologies that are underlying the foundation of this talk. So the surgical training paradigm in our microsurgical residencies and fellowships, things really haven't changed in over a century. Really, almost all of the learning is one-to-one, supervised by an attending surgeon with verbal guidance during the procedure, as well as observation, and then with a lot of variability, some type of feedback after the procedure. In terms of this paradigm, this post hoc data-based review, particularly if it involves surgical video, is very time-consuming, and really, moreover, we don't have any established quantitative, objective, or standardized metrics. The evaluation that we give as surgical teachers is usually unstructured, certainly unvalidated, and often very, very subjective. So we do have some quantitative measures, although again, these are very much subjective. Here's the Oscars for vitreoretinal surgery, which uses this 5 scale. But really what should be of greatest concern is how subjective this is. And this is a pretty widely discussed now paper last year in the general surgery literature, showing that a review of all studies in this area showed that greater than 70% of them showed that women scored lower than their male peers in knowledge-based evals, in procedures, in their own self-assessments, interestingly, as well as evaluations by supervised attending surgeon. And really every study examining racial bias has found evidence disadvantaging trainees underrepresented in medicine. So we do have some more objective ways and a precedent for this. This is an example comparing ILM peeling and vitreoretinal surgery, but these are all done with manual annotation of surgical video. So this is incredibly onerous, time-consuming, certainly cannot be scaled, and also limited to what we as humans can observe in surgical videos. Similar work has been done in cataract surgery. Another area that I'm very interested in is using gaze behavior as a surrogate for visual attention, and there's a lot of data on this in the automotive space. Can we quantify what we as surgical teachers and as experts are paying attention to during a procedure? And moreover, perhaps in a more challenging way, how can we actually effectively communicate that to learners early on? So again, there is precedent for this as well, although almost all of this work is from static imaging in ophthalmology. Here's an example. You can see the top rows show how experts in glaucoma diagnosis are very, very different in trainees in terms of how they survey the optic disc. And of even greater significance, we know that once we form an intervention and actually show trainees how it is that we assess things like a fundus photograph in diabetic retinopathy, that those skills are transferable. So our primary aim is to create a feedback framework for the assessment of surgical performance that's quantitative, scalable, cost-effective, non-onerous, and most importantly, that is capable of yielding feedback to the surgeon to accelerate learners along their learning curve. That involves 4 elements for us. First is establishing a semantic understanding of vitreoretinal surgery, identification of optimal performance indicators, being able to quantify surgeon's gaze during microsurgery, and then finally trying to correlate our semantic understanding of the instruments and relevant tissues with gaze. So here's an example of what your Tesla is doing on the left, both object classification and then semantic segmentation. And we need to do a very similar thing in microsurgery. So previous work in our laboratory that's been published has shown that our tools really are fairly robust in terms of identifying critical surgical instruments like the vitrector tool trip and the forceps and endolaser and a number of tissue elements. So next, can we move on and apply those tools to the identification of OPIs? And there's good precedent for this in other surgical areas, particularly areas where robotics are very much in use, because the kinematic information in terms of what the instruments are doing is natively available in those platforms in a way that they're not for our manual surgery. But again, using those tools for surgical video allows us to do very similar things. So we performed a study assessing fellows in vitreoretinal surgery, first year, second year, as well as attendings with less and greater than 5 years of experience. We applied a deep learning approach to start to look at those differences on the following OPIs. So we looked at surgical phase length. How long does it take to perform an individual step? Idle time, defined as when the surgical instrument is present within the field but not doing anything productive. Tool velocity, acceleration, mean distance of the tool tip from the optic disc, proportion of time with the disc or fovea in the field of view, and that's really a good surrogate for how effectively or how much someone is using the wide-angle visualization capabilities and surveying the broad part of the fundus. Number of microscope movements in terms of how active the surgeon is making adjustments to the viewing. Total travel distance, this is really a pretty good surrogate for efficiency in terms of whether you're returning to the same spot in the surgical scene or not. So this is a very busy slide, but I'm just going to show you a couple of examples. All these OPIs were relevant. So look at the top row in the middle. You can see idle time, for example, in endolaser. The fellows spent much more time with the tool, not doing anything particularly productive. Middle row on the left, the travel distance, the greatest difference by far was core vitrectomy. So the fellows, for example, traveled a much longer path and presumably probably returned to the same locations or were not as systematic in terms of performing the core. And so, in conclusion, this initial set of metrics allows us to quantify certain elements of surgical behavior, and it provides a groundwork for future automation. And we're able to do this over a fairly heterogeneous collection of posterior segment procedures. So I'll just finish up in the last couple minutes on some of the most recent data we have. One, again, is an assessment of gaze. So we looked at fixations, saccades, dwell time, and total travel distance. We did this with surgeons reviewing video retrospectively, and this was attending as fellows, residents, representing both anterior and posterior segment surgery. And what we did was combined our instance segmentation neural network for detecting tools and tissues and correlating that with gaze. And you can see on that last frame what that looks like in terms of marrying those two views. On the bottom right, you can see the total gaze traveled obviously is a very complex scene over a procedure, but deep learning certainly helps parse out some trends. So again, this is what we looked at, both posterior and anterior segment phases of procedures. And here's our data. And just in the interest of time, the sort of top line summary here is that attendings overall had a lower Cartesian distance traveled. And what that means is they almost certainly systematically tended to focus on what are presumably the more important elements of the scene. Residents and fellows exhibited more fixations, interestingly, to the device parameters, things like cut rate and the intraocular pressure. Something else I think that's probably intuitive for most of us who enjoy surgical teaching is that residents had an increased dwell time with the instrument tooltip location, right? So at the peril potentially of ignoring things that are happening in parts of the scene other than the business end of the instrument. And then lastly, let's look at what happens when we marry some of that data. And for this, we used the IC simulator, which is probably the most popular surgical simulation platform. We looked at core vitrectomy, membrane peeling, endolaser, as well as phacoemulsification cataract surgery. We had attendings, residents, and fellows. And so when we look at gaze alone in terms of F1 scores of helping to classify by the network who was a resident versus a fellow versus an attending, really the results there are modest at best. Looking at surgical maneuvers are better, but far and away the best was combining maneuvers with gaze. And so not surprisingly, if we look at something like core vitrectomy, as those of you who are familiar with AI training of networks, of course, when we train and validate on a step like core vitrectomy, in our test values, the best are for core. But we really do get pretty good results across the board. Really, what's potentially even more interesting is that when we train and validate on a totally different phase, something like membrane peeling, we actually still get very good classification results for things like corvitrectomy and endolaser, and that suggests that there are probably very fundamental things. Remember, we talked about instrumental acceleration and velocity, things that probably are useful in terms of this classification problem. So let me just kind of skip to the top line summary. Ultimately, we've developed a platform for real-time surgical comprehension. We've investigated quantified instrument behavior as well as gaze behavior, and combining those two really gives us the best picture of where someone is along their training curve. And this could serve as a model for automation of training performance assessment. And I just want to highlight our team, particularly Rogerio Nespolo, a recently graduated PhD student in the lab who did tremendous work and a lot of that heavy lifting in terms of designing and training these algorithms, as well as my close partner and collaborator, Darvin Yi. Thanks very much.
Thanks so much, Yannick. Next up will be Meredith Cox from Duke University. We'll be talking about retinal imaging in relation to neurodegenerative diseases. Meredith.
All right, thank you so much for the opportunity to present. I'm Meredith, I'm a medical student at Duke, and I'm going to be talking about automated convolutional neural network-based quality assessment of OCT and OCTA images for neurodegenerative disease detection. So neurodegenerative diseases are becoming increasingly prevalent. Alzheimer's is estimated to affect over 6 million Americans, and around 1 million are living with Parkinson's. So tests to diagnose neurodegenerative diseases include cognitive status testing, cerebrospinal fluid analysis, and brain imaging. These can be expensive tests and are not always readily accessible. And advances in retinal research suggest that the retina may manifest early microvascular and structural changes that indicate neurological decline, which makes retinal images great for screening for neurodegenerative diseases because it's cheaper and it's also more widely available. Research by the Duke Eye Multimodal Imaging and Neurodegenerative Disease group, which I am a part of, the iMind group at Duke, has actually shown that convolutional neural networks, which is, as we know, type of deep learning algorithm, are able to very accurately diagnose symptomatic Alzheimer's disease using multimodal retinal imaging. So these types of models really highlight the potential for a streamlined process aided by machine learning to identify Alzheimer's disease and other types of neurodegenerative disease. In order to maximize the utility of these kinds of screening methods, it's important to ensure that the image inputs into these machine learning models are of high quality. Currently, poor quality images have to be individually identified and excluded manually by a trained grader, which is a process that's time-consuming and might not be feasible in resource-limited settings. So to address this issue, we developed a convolutional neural network to assess image quality for OCT angiography, OCTA, as well as optic nerve head angiography and enhanced depth imaging, OCT. Okay, so we developed this model in 3 phases. So first was the pre-processing phase. And in this phase, we obtained OCTA, ONH angiography, and EDI OCT images from iMind study participants. So these were participants with neurodegenerative diseases like Alzheimer's, Parkinson's, as well as other diseases alongside cognitively normal controls. Then manual image quality assessment was performed by 2 trained graders in order to create labels for our data, with a third adjudicator resolving any discrepancies. Then we split this data into training, validation, and test sets in a 60-20-20 split. And then we performed data augmentation on the training set in order to increase the kind of variation in images in order to improve our model's performance. Next was the model training phase. So we trained a ResNet 50 model, and then we tuned the hyperparameters of our model with grid search in order to optimize it. And then the next step was model evaluation. So we tested our convolutional neural network and evaluated it using various performance metrics, which I'll show you on the next slide. And then we interpreted the model using GradCam, which is an interpretation method that will highlight the most influential parts of the image for making a decision. And so here are the results of our model development. As we can see, all three models that we developed for OCTA, ONH, and EDI OCT images, so the AUC was 0.93, 0.95, and 0.94, respectively, and the AUC curves are shown on the right. These models perform very well for their respective imaging modalities, and we also were able to show with two proportion z-tests that the models perform well for patients both with and without neurodegenerative disease. Okay, so then we were able to explain our models using gradient-weighted class activation mapping, or GradCam, as I just mentioned. So GradCam works by using the gradients of a target class going into the final convolutional layer of a neural network to produce a heat map that highlights the most important regions in an image for prediction. The GradCam heat maps shown here verify that our convolutional neural networks are focusing on appropriate features in all of the retinal scans for all three imaging modalities. So in this study, we have developed convolutional neural networks for quality assessment of OCTA scans, ONH OCTA, and EDI OCT. These models are interpretable, which is important because trust of machine learning models due to the lack of explainability is a major challenge in the adoption of deep learning in medical analysis. And explainable machine learning methods have been shown to improve physician interpretation of images. The GradCam heat maps that we developed ensure that the models are focusing on appropriate features that make sense. And our models have the potential to ensure quality of retinal images prior to further analysis by machine learning models for neurodegenerative disease detection. Automated image quality assessment like this might be used to flag a poor quality retinal scan and provide the opportunity for intervention and repeat acquisition at the time of imaging. It can also provide the opportunity, once an image is flagged, it can allow for denoising of a poor quality scan if that is truly the issue with the scan. And by identifying and excluding poor quality images, these models can enhance the overall efficiency and the accuracy of automated classification of neurodegenerative diseases using retinal scans. And to bring this sort of closer to real-world applications, another collaborator on this project, Raj Kundu, has also developed a desktop application which allows a user to select an image type and upload an image. Then the application will identify an image as either good or poor quality. So that's one step towards applying this towards our intended goals. So in conclusion, we've created a proof of concept machine learning model, or multiple machine learning models, to assess image quality of select retinal images. Our models can serve as an efficient approach to screening images, leading to a more streamlined workflow for automated disease classification. Thank you so much to the iMind group for all the help and support with this project. It is truly a pleasure to work with such a knowledgeable multidisciplinary group. So thank you so much.
Wonderful talk, Meredith. We're going to also be hearing about Parkinson's disease from Alexander Richardson, also from Duke University.
Hello. I'm also from the iMind group. I'll be presenting on our work building a convolutional neural network to identify Parkinson's disease with retinal imaging. Parkinson's disease is a neurodegenerative disease characterized by the damage and death of dopaminergic cells, causing patients to struggle to initiate and control voluntary movement. The hallmark of Parkinson's disease is a loss of dopaminergic cells in the substantia nigra associated with cardinal motor symptoms, including bradykinesia, rigidity, and arresting tremor. The eye can function as a window to the brain, since changes in retinal structure and vasculature have been associated with neurodegenerative changes in the brain. Specifically, studies using optical coherence tomography, or OCT, and OCT angiography, or OCTA, revealed a decrease in vessel density, retinal perfusion density, and choroidal vascularity index in patients with Parkinson's disease. Another study also revealed increased venule tortuosity in patients with Parkinson's disease, this time using ultra-wide field, or UWF, scanning laser ophthalmoscopy, and longitudinal retinal imaging datasets have shown faster microvascular and neuronal loss in Parkinson's disease patients. Since there is a link between Parkinson's disease and changes in retinal structure and vasculature, we reasoned that these changes could be used as biomarkers to train a machine learning algorithm. We used 4 retinal imaging inputs: ganglion cell inner plexiform layer color thickness maps, 6 by 6 millimeter OCTA superficial capillary plexus images, UWF color photographs, and UWF autofluorescence, or FAF photographs. The dataset included 446 eyes from 301 patients, specifically 371 eyes of 249 control patients, and 75 eyes of 52 Parkinson's disease subjects were included. All images were of good quality, which was graded by the image quality assessment algorithm previously developed by iMind and mentioned in Meredith Cox's presentation. The machine learning model we used is called a convolutional neural network, which is a subtype of deep neural networks designed for images. Training a convolutional neural network consists of 3 main steps: convolution, pooling, and configuring the weights of the fully connected layers. Convolution filters the input data and learns feature detections. Pooling reduces the dimensions of the image while retaining the features, and the fully connected layers learn the patterns between local spatial features and the high-level label. Specifically, we use the pre-trained VGG19 neural network as a foundation, and then added 4 parallel sets of fully connected layers specific to the Parkinson's disease problem, 1 for each imaging type. Essentially, the pre-trained network extracts the low-level spatial features, and the fully connected layers learn the association between the spatial features in each imaging type and the overall label, a diagnosis of Parkinson's disease. The model then averaged the output of each neural network for each imaging type to reach a final classification. The benefits of using parallel neural networks for each imaging type is that when a certain image type is unavailable, such as if the OCTA equipment breaks, the model still works. The model also works on both right and left eyes. So if a patient has bad imaging quality on one eye, or is missing one eye, or something goes wrong, the model can still function. The model also accounts for translational variants, such as if images are flipped or offset, so it's robust to clinical realities. We built 3 submodels, one that considered only right eyes, one that considered only left eyes, and one for both. The 3 models had approximately the same performance, with all having an AUC of around 0.9 when using all inputs. We recorded the performance of models when each image type was used in isolation, and we found that the GC-IPL color thickness maps typically were the worst performing input, and that the fundus photography input was the best. The models all had substantially higher sensitivity as well, which could be explained by them identifying early signs of Parkinsonian neurodegeneration that had not developed enough to be considered a full diagnosis. iMind had also previously developed machine learning classification models for Alzheimer's disease and mild cognitive impairment, and the results for those 2 models have already been published. Our next step is to integrate these 3 models into a software package that allows for combined neurodegenerative disease screening from retinal imaging. Also, the image quality assessment. Image quality assessment is required for an algorithm to be used clinically. It's an FDA requirement, and we already have that algorithm as well. Any questions from the audience?
We'll take questions during our panel. Thanks, Alexander.
Thank you.
Up next will be Jovi Wong from the University of Toronto, talking about generating images to train models. Very interesting.
Thank you so much. So today I'm very excited to show you our work demonstrating that realistic generated images using latent diffusion models to improve retina disease classification using deep convolutional neural networks. My name is Jovi Wong. I'm a senior resident at the University of Toronto, and I'm applying for surgical retina fellowship this year. So I have no financial disclosures. So I first wanted to show you our initial work that was published last year, where we trained a deep convolutional ensemble to classify retinal fundus photographs. So we amalgamated public datasets containing over 40,000 images in order to train our ensemble to classify retinal fundus images into one of four classes: diabetic retinopathy, AMD, glaucoma, and normal fundus images. We then benchmarked our ensemble's performance against 7 board-certified ophthalmologists in our department. And the ensemble performed significantly better with a mean accuracy of 79.2%, while our human experts performed at just under 73%. And after this work was published, we retrained our ensemble with the new AROGS dataset, which contains healthy and glaucoma images, and we found that we could improve our performance further. So of course, a new high-quality data set of patient images doesn't show up every day. And we're finding more and more that patient data can be difficult to obtain, and there are more and more restrictions to prevent data security problems. So sometimes in realistic scenarios, we end up with underrepresentation in our training sets, either due to data scarcity or security challenges. So we wondered if there were some ways to overcome these challenges by generating more data. And in particular, we wondered if we could investigate whether it'd be possible to generate training data and improve the accuracy of our model without requiring any more real data. And so in just a very short time, we have seen immense improvement in generative image models. Here we can see the improvement of generative adversarial networks, which I think Dr. Vajvik talked about earlier in the session. And so you see here in 2014, the state-of-the-art images are realistic, but they look like bad photographs, which are quite grainy and pixelated. And only in a few short years, we've seen development in techniques to create very realistic photographs that in many ways are difficult to distinguish from real photographs. And then more recently, we now have a new technique, latent diffusion models, which have been rapidly refined to create beautiful, realistic images, here of Harry Potter. And in addition to this, the image generation is guided by natural language description, so you can use text to change the image that you want to create. And this is the same technology that we see with DALL-E and Meta AI. Last year, the MedFusion diffusion model was published and made publicly available, and this team adapted latent diffusion models to create realistic medical images containing pathology. So here they showed they were able to create synthetic fundus images, pathology photographs, and chest x-rays. And the top line shows their initial work, where they used the AROGS database to create images, and also the second row where they improved their model to try and reduce artifact. So for our study, we had 2 objectives. The first was to be able to create realistic retinal fundus images conditioned on disease labels matching our previous study. So that would be fundus images showing diabetic retinopathy, AMD, glaucoma, and normal images. And our second objective was to use generated images to boost performance of our automated deep learning retinal disease classification model, which I showed from our previous work. So to go over our methods, we had in green in the middle there, you can see the MedFusion model. We had this to work with, and we trained it on a curated data set of 140,000 fundus images containing the 4 classes, diabetic retinopathy, AMD, glaucoma, and normal. And from this, we generated a sample set of 48 generated images, 12 per class, and we also retained 48 real images from the original data set. And we showed these sets of 96 images together in a mixed order to 8 board-certified ophthalmologists and asked them to review these images and try to determine which was real and which was generated, and also to name the disease represented in the image. And then we generated a variable amount of images and put them back into the training set of our original deep convolutional ensemble to see if this would improve overall accuracy. And so here are some example generated images in the top row. So you can see there are some normal, a diabetic retinopathy, a glaucoma, and an AMD image. And our 8 board-certified ophthalmologists had an average score of about 61% when they attempted to identify which images were real versus which were generated. And of course, 50% would be just regular guessing. And we found that our ophthalmologists performed similarly across all classes of images, suggesting that the images were of similar quality. And when looking at correct prediction of disease grouped by real or generated images, we found generally the ophthalmologists tended to get the diseases correct on real images more than the generated images, and this was more true in diabetic retinopathy and in glaucoma images. And we also looked at images where there was perfect consensus amongst all 8 of our human ophthalmologists, where they all agreed on whether an image was real or not. We found 5 images where everybody agreed. And there was one where everyone believed the image was real when in fact it was generated. And so in our previously published deep convolutional ensemble, we had plenty of normal diabetic retinopathy and glaucoma images, but we had comparatively few AMD images. And so we wondered what would happen if we added generated AMD images. And here we see that we were able to improve the classification accuracy of our model when we add AMD images back into the training set. And we saw if we added more images, we did get some diminishing returns, but we do not ever significantly reduce the baseline accuracy. So in conclusion, in this study, we have shown that we're able to generate highly realistic retinal fundus images containing features from multiple different diseases. And these images can improve the performance of a supervised learning algorithm without any additional real data. And in the future, we hope to look at which generated image features are helping to improve classification performance, and how much do generated images help in the different availability levels of real data. And thank you very much again for the opportunity to present this work today. Feel free to contact me if you have any questions. I would very much like to thank Fighting Blindness Canada and the Canadian Medical Association Jewel Innovation Grant for their support of this research, and our wonderful faculty members who helped with these projects. Thank you.
Well, those images look great, Jovi. Let's talk more about that during our panel. Our last speaker for this session and for the meeting is Fatma Shakarchi from the Red Crescent movement, and we'll be speaking about clinician autonomy and AI decision-making, the ethics of ophthalmic practice using AI.
Good morning and good afternoon. I'm Fatma. I'm a medical doctor. I'm currently based in Geneva, working with the Red Crescent movement, and also serving in an advisory capacity with the United Nations Program on Space Applications. I'm very happy to be with you today, and I've been following up with the presentations and learning more from you about the more recent advances in research in ophthalmology and AI. So in this presentation today, I will be discussing the dimensions of AI and research in ophthalmology, and how it manifests with organizations such as the WHO and the UN and the global policy level, and then how that translates to our patient care and to the clinic. So I go back to a quote that says, AI won't replace doctors, but doctors who use AI will replace those who don't. And why is that? Because AI has many advantages in that it enables us to have health for all. It allows for early disease detection. it enables efficient diagnosis and imaging, and therefore enables us to have remote patient monitoring, especially for telemedicine and accessibility for more remote areas. It has a great role in public health surveillance, especially that the major burden of blindness globally and even in the US is for avoidable causes for the people who live in more remote areas that have challenges in accessing traditional care, and therefore enabling cost reduction and resource mobilization. However, looking at that, we need to look at the ethical dimensions of AI implementation, and we also need to go back to the ethics of medicine and of our own practice. So looking at the ethical considerations, because AI depends on data that has been generated from patients, it's usually from patients who live in higher resource settings, and therefore, we need to look at the data privacy and security dimensions of our data sets, because it includes sensitive patient information and the data availability is not the same everywhere, raising ethical challenges on the algorithmic biases that it would enable. And similarly, AI systems can be complex and they can be opaque, making it very hard to understand their decisions for both the patient and for the care provider, which raises questions on the human role in decision-making. Will human skills be central or will it be complementary to the machine decision-making? Similarly, the development and the deployment of AI-powered tools in the resource-intensive settings is more straightforward than their implementation in the more remote locations. So how can we ensure equitable access to the advances in technologies? For example, the recent advances that have been presented today. So to answer these questions, I went back to the UNESCO's first ever global standard on AI ethics. It has been published by the UNESCO, which is a UN entity, and it's been adapted by all the 193 member states. So all the countries have agreed on adapting these recommendations on the ethics of AI in all their practices. Similarly, for health specific as well, I went over to the WHO guidance on the ethics and governance of artificial intelligence for health, and I implemented these models into ophthalmology and into the current practices that we have today to come up with recommendations that we need to ensure ethical considerations in AI. So we need to ensure that we have data governance frameworks that ensure the data privacy and security for our patients. And in order to achieve that, our patients need to be informed about the mechanisms that are implemented to protect their data and the possible uses of their own data for feeding into future AI models and machine learning. We need to have rigorous bias detection, especially for the algorithmic biases that we have, and especially for the tools that have been developed in one population, but then have been implemented for the of other populations, because there might be some changes between those two populations. In terms of the human role in decision-making, based on the current position and the current stance that we have in AI logarithms, we need to augment the human ophthalmologist's capabilities rather than replace them. And we need to ensure accessible and affordable care to everyone to minimize disparities, especially as we move forward and AI tools become more of a norm. So we need to ensure that no one falls behind. Now this discussion raises critical questions about autonomy, especially ophthalmologists' autonomy, and many of our colleagues joining the call today are ophthalmologists. So how do we take it back to the clinic, and how do we discuss the clinician's autonomy given all of these frameworks that have been adopted by the member states, and also given the recent advances that we have in the science? So when we look at the Hippocratic principles of autonomy, we say that the clinician's autonomy is fundamental to promote the patient's health and to prevent harm, meaning that the clinician's autonomy is not to be protected for its own sake. And it is only protected if it is better than the alternative means. So meaning currently, and with the current progress that we have made and with the current practices we have, machine autonomy does not undermine the human autonomy, and the humans should remain in full control of healthcare systems and of medical decisions. And the systems that we have developed, they assist us rather than overtake clinicians in decision making. And that should also be communicated to the patients, especially when AI tools have been implemented in their patient care. And I conclude back with the same quotes that AI won't replace doctors, but doctors who use AI will replace those who don't. And thank you.
Wonderful talks. If we could have all the speakers turn on their cameras and join us here for the panel. I think I'd like to go to the Duke group first and talk about neurodegenerative and other diseases of the central nervous system. I think, I can certainly see how getting an eye image in maybe a non-ophthalmic setting or even an ophthalmic setting could help with the detection of potential diseases in the future. I guess for Meredith, have you thought about validating the findings from your group and, with data from other institutions or maybe someplace outside the US yet?
Yeah, that's definitely something that we're thinking about doing. I think it's important to get a lot of data. I think it's with these machine learning applications, I think it's all about data and it's all about trying our models on new data, different data, to make sure it performs well and is generalizable. So that's definitely a next step for our research.
And Alexander, were there any issues with, you worked with a movement disorder, so were there any issues with that interfering with the ability to get clear images or image quality?
Yeah, with the data sets, a lot of the images were actually excluded. We started with around 1,000 eyes, but it got cut all the way down to around 450 because of the blurriness interfered with image quality. So it slows down the rate of image acquisition. But I think for other neurodegenerative diseases that aren't movement-based, a higher percentage would be high enough quality to actually go into the data set.
Keeping on the topic of movement, Yannick, in your research, you were tracking the movements of instruments either in the virtual space or in the real space from, attendings, trainees, and fellows and residents. How, the findings you had were really amazing and impactful, but how do you think you can actually operationalize that and help trainees become better surgeons using this data?
Yeah, so I think probably the most immediate application of that is in assisting trainees reviewing their surgical videos. Even for trainees performing cataract surgery, which is often 30 minutes of video and maybe multiple a day. I've spoken with a number of my colleagues. I do some work around this at the ASRS, and workflow-wise, it seems really challenging consistently, particularly in the type of immediate feedback that trainees would benefit from at the end of an OR day or even that same week. To review that with a mentor just is not happening in our field on a regular basis. And there's literature around this in general surgery as well and other fields that are trying to systematize this. But even trainees on their own, right, just trying to make sense of their own surgical videos and look for areas of improvement. If we can identify things like use of visualization and centration during microsurgery, which you and I know as teachers is something constantly we're iterating, right, in the beginning of people's surgical training, but also use of instruments, path length, redundancy, returning to an area where perhaps you've already been in the case of vitrectomy. These are things that are, I think, very difficult for a trainee to appreciate, particularly on their own reviewing a video. So I think there's a lot of low-hanging fruit in terms of automating, literally in the context of an hour or two long video, being able to immediately highlight the learner's attention to the most salient portions of the video, and then actually in an automated way help to bring their attention to things that they really can be improving day to day, week to week. I mean, I think there are many more potential applications of this, and some of which are relatively evident from other fields as diverse as sports analysis and aviation. But there's a lot of, I think even really low-hanging fruit to help trainees make sense of their surgical video.
Yeah, I think people were really, I got a few comments offline about the eye tracking that and how that's a really important part in a lot of these analyses for multiple fields. So I definitely see how that could be applied in the future. Thanks for your comments. So Jovi, we had a question online from the chat about what type of hardware and training time did it take for your latent diffusion model to process?
Yes, thank you so much for the question. So we used one NVIDIA A100 GPU to train. And from scratch, it took approximately 24 hours for each run. So for each condition that I showed, we had a mean and standard deviation because each condition we ran it 5 times. And yeah, so that's approximately how long it took.
Yeah, I think the field of generative AI is obviously super relevant right now in society, and it's interesting to see your application for that in retinal disease training and ophthalmology. But I was wondering if you had any input or feedback about just the acceptance of the use of generated data to train AI models in ophthalmology.
Yeah, for sure. I think every time I show this work to someone asks me, is it okay if we put this generated data back in, and does it bias the model in some way? So one reassuring thing is we've noticed that in all of our runs, we never decrease the accuracy. So it appears that it's not that we're sort of providing junk to the training set and potentially making the model less accurate. The other thing is, I guess this type of work has been done previously using GANs to create the images, and I guess as long as it's well disclosed how the model was created and that some of the images were generated to help augment the accuracy, I think that would be reasonable.
Yeah, it would be interesting to see how these models trained on this generated data would be validated against very diverse population sets. So data from other geographies or ethnic groups or demographics that aren't typically represented in the areas where they were trained.
Yeah, absolutely. And that was from our amalgamated data set, because we had from international publicly available data sets. They were from all regions of the world, and there were certainly some that are more represented than others. And so trying to even that, I think, would make a model more accurate and representative.
Thank you so much for your comments. Our last question will be for Fatma. I think your talk was really relevant because I think representation is key as we move forward as a field in ophthalmology and artificial intelligence. And I think time and time again, it's shown that having domain experts be a part of the conversation is really important as these algorithms get developed. So how would you say that ophthalmologists could get really involved and make sure that we have a seat at the table as these models are developed and the conversations continue?
Thank you. And exactly as you mentioned, it's by having a seat on the table and by having collaborations and engaging with multidisciplinary teams. So the way that I think of it, so whenever I look at a policy document or at any project that we have working with the UN, I always reflect on my patients and on the hospital settings and on the actual patient needs on the ground, especially with the diverse patients that we see every day. So there are 3 main areas that ophthalmologists can engage in these discussions. The first is by providing clinical inputs and by articulating the clinical needs and the use cases and the performance benchmarks that these AI models need to adhere to for order for them to be effective and relevant to our practice. The second is exactly as you mentioned, in collaborations and engaging with multidisciplinary teams, including AI developers, to ensure that these AI tools are relevant to our modern day problems. And same thing with research and with capacity building. So I would like to go back to the talk by Dr. Wong and by Dr. Liederman in terms of how these tools could be used for capacity building, and then including them for collaborations with other colleagues.
Wonderful. Well, thanks again to all the speakers and panelists in this session for the sixth and final session here of the 4th Annual Ophthalmic AI Summit. We thank all the participants here for attending. And I would like to also put in one last word to thank again all of our sponsors, Regeneron, Apellis, Genentech, Boehringer Ingelheim, Bausch & Lomb, and iNook, who made this meeting possible. We look forward to seeing everyone again next year. Please keep working in the space of artificial intelligence, and we look forward to hearing about all the new progress next year. Have a great weekend.